and President of APG, Association of Physicians of Gujarat, Dr. Dhiren Patel, as well as Dr. Priti.
Good morning, friends. Today, I think that is really very interesting topic. Diabetes and lipids. We all know is always, we are getting always new insights about lipids and also about diabetes. But the important is glucose and lipid metabolism are linked to each other in many ways. And the most important clinical manifestation of the diabetes, dyslipidemia, is characterized by elevated triglyceride, low HDL, low high, and the important is the predominance of small LDL particles. And so today is really very interesting topic, diabetes and lipids. For this, we have very eminent speakers. Uh, Today we are listening the four the stalwarts. The name is Dr. Siddharth Vatan Soyagondo, Dr. S.K. Bagnu sir, Dr. S.N. Narsingan sir, and Dr. Raman Puri. All are excellent in their field, and we are very fortunate to listen them. With this, I am going to introduce our first speaker, Dr. Siddharth Vatan Soyagondo. He is a very well-known faculty from Indonesia. He did his graduate medical doctors and specialist in internal medicine and endocrinologist on PhD from Indonesia, Jakarta. He is a professor of medicine and endocrinology, University of Indonesia, Jakarta, 2005 to 2010. He is a president of Indonesian Diabetes Association for 2 terms and chairman of the Indonesian Endocrine Society for 2 terms. And he is invited for many diabetic education programs, and he serves as an executive committee member in IDF Western Pacific region. And he presently leading the Indonesia Diabetes Institute and practicing as an endocrinology at SS Diabetes Care, Useda Hospital and Siloam Samatubing. With this, I am inviting our first learned speaker, Dr. Siddharth Vatan Sangawado. Please, sir, over to you.
Thank you very much, Dr. Dhiren Patel. First of all, I want to thank Diabetes India, Dr. Pansi Sambu. I attended the Diabetes India since the beginning. Every year I go to India, but this last 2 years is virtual. I'm very glad to have 2 professors from cardiology and 1 from endocrinology as my partners, because actually I'm going to learn from you, because lipids is not that popular in Indonesia. Only last 2-3 years we are getting more and more interested in it, because you know, for many reasons. Let me share my slides. Okay. Can you see my slides?
Yeah.
Okay. Okay, thank you. Okay, my talk is about insights into the management of dyslipidemia and diabetes, exploring the use guidelines. We know that diabetes greatly increases the risk of cardiovascular disease. Patients with type 2 diabetes have twice the risk of cardiovascular disease when compared with the general population. Cardiovascular disease risk factors are more prevalent in diabetics than in non-diabetics, especially type 2 diabetes. They have hypertriglyceridemia, low HDL, small dense LDL, and increased ApoB, and of course hypertension and so on. These cardiovascular risks are more prevalent. And according to still 2 study, lipid lowering therapy accounted for more than 70% of cardiovascular risk reduction in diabetes. The percentage of total calculated risk reduction in cardiovascular disease, most of the CV benefits in diabetes was attributable to the use of lipid lowering therapy, not to the glucose lowering or blood pressure lowering. This lipids is getting more and more important. But why do the guidelines say, what do the guidelines say of dyslipidemia and diabetes? Dyslipidemia and diabetes, the guidelines, international guidelines, is updated. The American Heart Association, American College of Cardiology in 2018 first produced the cholesterol guidelines. The ASG, European Society of Cardiology in Paris, has dyslipidemia guidelines, a little bit different. One is cholesterol, one is dyslipidemia. What are the difference? The 2019 ASG and 2018 ACC guidelines place particular emphasis on identifying patients at a very high risk cardiovascular disease and modifying established risk factors. Such very high risk patients have established high CVD and or a combination of other risk factors, including diabetes, hypertension, peripheral artery disease, chronic kidney disease, and other dyslipidemias such as hypertriglyceridemia. Both European and US guidelines underscore the importance of treating to achieve LDL cholesterol levels as low as possible. With the European guideline setting a goal less than 55 milligram per deciliter in patients with very high risk cardiovascular disease, and the US blood glucose guidelines less than 70. Both guidelines recommend at least 50% reduction in addition to risk-specific LDL cholesterol goals. There are some difference of these two guidelines, but the risk estimation. The ASG is updated 2019, ACC is 2018, ACC is about cholesterol, and a main focus of ASG is dyslipidemia. ASG is based on all available evidence, but the American ACC is on a random control trial. But the risk estimation of the ESG is the score 10 years risk of fatal CV events. But the ACC is the pool cohort equation for 10 years risk of total CV events. There's a little bit different. There is a difference. And the ASG, if we look at the ASG, recommended a very active treatment of dyslipidemia in patients with familial hypercholesterolemia and diabetes. All are at high or very high risk of CVD. If you see the treatment goals of the LDL cholesterol across categories of total cardiovascular disease risk, the treatment goal you see it goes to 55 milligram per deciliter, and the higher the risk, the lower the treatment goal for LDL cholesterol. And not only that, for the high and very high, you have to add less than 50% reduction from baseline also. Now, if you see the algorithm, after risk assessment and stratification, you do a clinical assessment and score, and then you get these 4 risk categories: the very high risk, moderate risk, and low risk. And then you start lifestyle modification, the statin therapy, follow-up lipid profile, and the targets will be then for very high, with reduction of more than 50% of LDL and risk, and then LDL cholesterol less than 55. The high risk the same, less than 55%, and LDL cholesterol less than 70 milligram per deciliter. But the moderate risk and low risk, after risk modifiers, they can use LDL. The target is less than 100 and less than 115 for low risk. And after that, if it doesn't achieve the target, then assess adherence to statins and lifestyle changes. And if it's not achieved, to add ezetimibe. But for the very high risk, you can add PCSK9 inhibitors to reduce the cardiovascular risk. Especially for diabetes, the CV risk categories and recommendations for management of diabetes and dyslipidemia. The very high risk. What are these? Diabetes with recommended ICVD on clinical or on imaging. Diabetes with target organ damage, as proteinuria, retinopathy, and neuropathy. Or diabetes with 3 or more major risk factors: age, hypertension, dyslipidemia, smoking, or obesity. Or early onset of type 1 diabetes of long duration, more than 20 years. What about high risk? High risk diabetes duration more than 10 years without target organ damage, or diabetes plus any other additional risk factors. And the lowest is moderate risk. That is for diabetes duration less than 10 years without other risk. That means if you have diabetes less than 10 years, no others, you are already on a moderate risk. And what are the targets? In patients with type 2 diabetes at moderate risk, an LDL cholesterol target should be less than 100%, 100 milligram per deciliter. That's recommended. And patients with type 2 diabetes at high risk, then the LDL cholesterol target should be less than 70 milligram per deciliter, and the LDL cholesterol reduction at least 50% is recommended. What about the very high risk? In patients with type 2 diabetes at very high risk, high cardiovascular risk, an LDL cholesterol target of less than 55 milligram per deciliter and an LDL cholesterol reduction of at least 50% is recommended. For patients with type 2 diabetes, there's a secondary goal of a non-HDL cholesterol target of less than 85 milligram per deciliter in very high severe risk patients, and less than 100 milligram per deciliter in high severe risk patients is recommended. That is of the ASC. What about the American Heart Association guidelines and multi-societies? They divided 4 statin benefit groups. One, the first one is the secondary prevention, that's a clean ICVD. But the primary prevention, that is the LDL cholesterol more than 190, diabetes age 40 to 75 years, and then the pure primary prevention with pooled cohort equation. Let's see for the secondary prevention. If you have clinical atherosclerotic disease, then you can have ICP not at the very high risk or very high risk atherosclerosis. The age is not calculated in the very high risk. Yeah? And the very high risk, what is very high risk? Very high risk in ICPD patients, according to this ACC guideline, the definition of very high risk is if you have multiple major atherosclerotic cardiovascular events, that is major acute coronary syndrome within 12 months, prior MI, prior ischemic stroke, symptomatic PAD, then you are called very high risk. But if you have one major ICPD event and multiple high risk conditions, the high risk conditions are age more than 65, heterogeneous FH, prior CABG, LPCI, diabetes, hypertension, CKD, current smoking, LDL cholesterol, and so on. That means if you have prior MI and you have diabetes, you are already considered very high risk. And very high risk, the first step to do is high intensity or maximally tolerated dose. Statin, sorry. Now, why maximum tolerated? Because you start with a high intensity, it is high, and if it's not tolerated, then you stay there or you reduce. And then step 1, if inadequate response or LDL cholesterol is more than 70 milligrams per deciliter, ezetimibe or PCSK9 inhibitor are considered. But the guidelines recommends an ezetimibe first because PCSK9 is expensive. What about the not very high? Not very high, age is here calculated. Less than 75 years, more than 75 years. If you are less than 75 years, high intensity statin first with potential add-on therapy with ezetimibe if on a maximal statin therapy and LDL cholesterol is still more than 70 milligrams. And for age more than 75, either moderate or high intensity statin can be used. Let's see the algorithm. You start with the risk assessment or stratification. You assess first whether this patient has clinical atherosclerotic cardiovascular, has severe primary hypercholesterolemia, has diabetes, or primary prevention based on pooled cohort equation. You assess first. And after that, you personalize. You see, for diabetes, there are risk enhancers. Primary prevention, if the patients, according to the score, low risk or 5 to 20% risk, then you look for right risk enhancer. But if the high risk, then you go straight for target. Yeah, and if the risk enhancers for 5 to 20%, if they look after that, then you can lower the target to less than 50%. And if all these targets is not achieved, then check the adherence of statins and lifestyle. And for severe hypercholesterolemia and clinical cardiovascular disease, then you can add ezetimibe and later on PCSK9 inhibitor to reduce cardiovascular risk. What about primary prevention? You see the green ones on the right. LDL cholesterol more than 190, no risk assessment, just use high intensity statin. The second, if you have diabetes, is 40 to 75 years, you start moderate intensity statin. Then, if you also have or 40 to 75 years, you can do a risk assessment to consider higher intensity. If you have diabetes, only diabetes, 40 to 75 years, you start with moderate intensity. But you can do you can go to high intensity, yeah, after risk assessment. You see, with diabetes, specific risk enhancers. Long duration of diabetes, for type 2 diabetes more than 10 years, for type 1 diabetes more than 20 years, albuminuria, EGFR less than 30, retinopathy, neuropathy, anti-bacterial less than 0.9, then you can consider it to go to high intensity statin. The rest, for primary prevention of all others and all other ages 40 to 75, perform ISVD assessment, certify low to high risk, engage in risk discussion. From ISVD, use the ISVD risk enhancers. If you are in the intermediate risk, 7.5% to 20%, you have to estimate the risk. ISVD risk factors, the family history of premature ICPD, persistent LDL cholesterol more than 160, chronic disease, metabolic, and so on, and biomarkers, and selected measures for ICRP, LPA, and so on. And if still you cannot certify this to personalize this, then you reclassify, considering the measuring the calcium score of selected dust. What's next? If you have diabetes, primary prevention for cardiovascular disease. If you have diabetes, besides dietary counseling, besides exercise and treatment, you have also to treat aggressively other cardiovascular risk factors. And one of them is the lipids. And you see here, diabetes mellitus in adults, ACC 2019. Adults 40 to 75 years of age with diabetes, regardless of estimated 10-year ICP rates, moderate intensity statin therapy is indicated. And adults for 40 to 75 years of age with diabetes and an LDL cholesterol level of 70 to 189, it is reasonable to assess the 10-year risk of a first ICD event by using the race and sex prescribed PCE to help identify ICD risk, as I told you before, especially for diabetes. But what about the newest one? American College of Endocrinology. AHA is 2018 and the same with 2019. ASG 2019, American College of Endocrinology 2020. They have another certification. Now they have an extreme risk. What is extreme risk? Established for diabetes, established clinical cardiovascular disease in individuals with diabetes. Then the target, the LDL target, is less than 55. Non-HDL target less than 180. ApoB less than 70, and so on. Yeah, and very high risk is diabetes with one or more risk factors. You have diabetes only one risk factors or more, you are already in high risk. That means the LDL cholesterol should be less than 70. And diabetes with no other risk factors, is already high risk, and the target will be less than 100. And how to treat? The treating LDL cholesterol to extreme risk, very high risk, extreme risk to start with high intensity, very high risk to start at high intensity, but the target will, if it is less than, more than 70, you have to go on for very high risk. But let's talk about diabetes. Treating LDL to go type 2 diabetes, high to moderate risk, lifestyle to moderate intensity statin therapy, 6 to 8 weeks. If the LDL cholesterol is still more than 100, you increase to high intensity statin. Still high 6 to 8 weeks, you add HTMI and so on. And this you start and you go on. What about the ADA? 2020 and 2012, cardiovascular disease and risk management, standard of care and diabetes, almost the same as AHA or ACC. Because when the ACC in 2018 is when also with other societies and ADA is there. There's recommendations for patients of all ages with diabetes and atherosclerotic cardiovascular disease. High intensity statin therapy should be added to lifestyle. For patients with diabetes and ICBD, consider a very high risk using specific criteria. If LDL cholesterol is more than 70 milligrams per deciliter or maximally tolerated statin dose, considering adding additional LDL cholesterol. The rest are almost the same as Okay, let me summarize a little bit. Final note for diabetes and dyslipidemia targets. We have 4 societies: American Diabetes Association, European Society of Cardiology, American Association of Clinical Endocrinology, and American Heart Association. What are the diabetes and cardiovascular, diabetes and no cardiovascular, diabetes plus risk factors? They have all these criteria. You see here, for diabetes, cardiovascular disease, then has high intensity, very high risk, extreme risk, very high risk. It's almost the same, but only the targets, you see. Targets of diabetes and cardiovascular disease, ADA is less than 70, ASC is less than 55, ASC is less than 50, 55, AHA is less than 70. But the rest, no cardiovascular disease. The risk factors are all the same, less than 100, less than 70. Dear colleagues, treatment of dyslipidemia and diabetes, type 2 diabetes at a very high risk, an LDL cholesterol reduction of more than 50% from baseline, and an LDL goal or less than 55 milligrams is recommended. Type 2 diabetes at risk, at high risk, LDL cholesterol reduction of more than 50% from baseline, and LDL cholesterol less than 70 milligrams per deciliter is recommended. Statins are recommended also in patients with type 1 diabetes who are at high or very high risk. Treatment of dyslipidemia diabetes, intensification of statin therapy should be considered before the introduction of combination therapy. If the goal is not reached, statin combination with ezetimibe should be considered. But in Indonesia, the implementation of these new lipid guidelines is difficult. Maybe I can learn from you, discuss how can you help me with Indonesians to comply with this guideline. It's very difficult, very high end, and let's discuss. Thank you very much for your attention. I hope to have a fruitful discussion with you all. Thank you very much.
Yeah, thank you, Dr. Siddharthan, for excellent lecture and the really too much insight into the management of dyslipidemia and diabetes. Great, sir. With this, before starting the second lecture, I first congratulate and many thanks to Dr. Bansi Sabu, such a dynamic leader, and Dr. S.R. Arvind, President, on whole team of Diabetes India, and also RX events, Dr. Hardik and all, such a wonderful event. With this, now I am inviting Dr. S.K. Wagnu, sir. He is from New Delhi. He is going to take lecture on do Indian dyslipidemics need special attention? Yes, definitely. Because in India, we have different dietary habits. And usually we find that low HDL and high triglyceride, we heard about lecture of this, previously the LDL goal was 130 and now it's come to the 100 and then, 70 and then 55. It's really going to be below 30 I think we have to discuss this question in our panelist discussion. So with this, I am inviting Dr. S.K. Wagnu sir. He is trained. He trained in medicine at Banaras Hindu University. Is well-known university in India, and developed keen interest in field of diabetes, endocrinology, and metabolism. And he was awarded the fellowship of the Royal College of Physicians of London. He leads on research studies involving development of new drugs and modalities of diabetes treatment. Apart from diabetes, his other areas of interest in thyroids, reproductive endocrinology, and pituitary disorders, on which he has a numerous publication. With this, I invite Dr. S.K. Wagnu, sir. Please.
Thank you, Dr. Dhiren, for your kind words. So I'm just about to share my slide. Are my slides visible?
No, sir.
No, sir.
Okay. A very good morning to all of you. Today,
No, sir, it's not visible.
No, sir. I
No.
think you have to go for share slides, please.
this
not
is not
there.
visible.
No, no,
No, sir.
Just a minute, just a minute,
no problem.
just a minute. I don't know whether it is visible or not. Not yet.
Not yet. Sir,
Not yet. Just hold on one second. मेरी स्लाइड विजिबल नहीं हो रही है, जल्दी करो, मेरा टॉपिक स्टार्ट हो गया। ये नहीं हो रही है मेरी विजिबल।
Yes, sir. Now I think it's.
Just
Okay.
hold on, hold on.
Yes, yes.
Is it visible now?
Yes, perfect.
Thank you very much. So I'm going to discuss something very special today. Do Indian dyslipidemics need special attention? You know, just to start my talk, I'll just give a snapshot of the Indian CVD burden. You know, there has been a rising prevalence of CAD in India, and as per the Indian Heart Journal 2002 article, the CAD prevalence has gone up to 20%. And there's a exponential rise of the CAD prevalence in India over the years. And if you see the CV mortality trends in India, and this is also showing a gradual increase in the CV mortality over the last few decades. Third, the unique part in India is that the MI we see at a younger age in India. And you can see that the average age of MI is between 45 to 50 years. And now we are seeing young Indians below the age of 40 years coming to us with acute coronary event or the myocardial infarction. What is behind this rising prevalence of CAD, the rising mortality, and the changing epidemiology in India? I think that there are many factors which are responsible. Urbanization, diabetes, hypertension, dyslipidemia, improved life expectancy, the stress of the modern life, reduced physical activity, and the changing dietary pattern. They are all responsible for the increase in the number of CVD cases and also the earlier onset of diabetes in Indian population. These important 9 modifiable factors account for more than 90% of the first MI race worldwide. And among all these 9 modifiable factors, dyslipidemia is the most common risk factor, particularly in the Indian population. Now coming to the main topic, is this dyslipidemia in Indian population is different as we see in rest of the part of the world. Dyslipidemia in Indians is different. How? The metabolic abnormalities are different in Indians, and the atherogenic dyslipidemia is particularly seen in the Asian Indians, which comprised of high small density, small dense LDL particles, high free triglyceride levels, and low HDL cholesterol values. Now, what is the evidence and the epidemiology behind why dyslipidemia in Indians is different? You know, if you see that the total cholesterol levels have been increasing over the years, if you see the studies based in India, studies which were done in India from 1960s to 1990s, you can see that there is a rising prevalence of the total cholesterol levels over the years from 1980 till 1990, even today 2000. And the right-hand slide shows you the pattern of the dyslipidemia among the various states of the country. Kerala on the top and the Chhattisgarh at the bottom. The ICMR AIM study, the Rajasthan rural study, the Andhra rural study, and the Indian migration study, they all have proved that there has been an increasing prevalence of hypercholesterolemia in rural men and women. So the ICMR INDIAB study has also confirmed that there is a high prevalence of dyslipidemia in urban and the rural India. So this is the overlap of the 3 important metabolic parameters: the hypercholesterolemia, hypertriglyceridemia, and the low HDL cholesterol, leading to the high prevalence of dyslipidemia in the Indian population. Now, what is the evidence in the literature? Now, I'll give you various evidence about the secular trends or the recent trends in the epidemiology of the dyslipidemia in the Indian population. The first, let's see the Indian Heart was multi-site study, where they have shown that the trends in the LDL cholesterol and HDL cholesterol, see, as regard to the LDL cholesterol, the men and women, they show the equal numbers. But as regard to the HDL cholesterol, the female a higher number as regard to the low HDL cholesterol as compared to the male. And the numbers like particularly the LDL more than 100, HDL less than 40, and the TG more than 150. The main difference is basically in the low HDL cholesterol among male and female. In a large hospital database study, the article was published 3 years back in 2017, they have again shown the same pattern or the secular trends in the epidemiology that the HDL cholesterol or low HDL cholesterol was more in women as compared to the men, while LDL cholesterol above 130 was again more in the women as compared to the men. Coming to the multicentric fit heart study, again they have shown that the epidemiology or dyslipidemia, the HDL cholesterol, the LDL cholesterol, and the TG was almost same difference among male and the female in this multicentric fit heart study. Just focus on this particular slide because the Jaipur heart study, the Jaipur heart was studies, which basically span from 1995, and we have almost Jaipur heart was study 1, 2, 3, 4, 5, and 6. It is showing beautifully the secular trends in the number of the cholesterol, how the cholesterol has been behaving over the years, LDL cholesterol, HDL cholesterol, and the non-LDL cholesterol. In the Jaipur Heart was study 2 and 3, which had shown the higher prevalence, the maximum prevalence of the either the cholesterol or the LDL cholesterol or the non-HDL cholesterol. And over the years, if you see the pattern of the LDL cholesterol is slightly on the lower side, as well as the total cholesterol. But as regard to the triglyceride and the remnant cholesterol, there has been increasing trends over the years as shown in this Jaipur Heart was study. So there's a different kind of a trend in terms of the elevation of triglyceride in Indian population. So that is one important thing to note. So overall, the 20 years trends in the prevalence of the hypercholesterolemia and the hypertriglyceridemia among urban subjects has been showing an upward trend. The TG more than 150 and the cholesterol more than 200. And this is the combination of all the Jaipur Heart was study 6. 1, 2, 3, 4. The fourth Jaipur Heart was study, we have shown the maximum higher prevalence of the triglyceride more than 150 in the Indian population. Now coming to the atherogenic dyslipidemia in Indians. This shows a relative risk, the 95% confidence interval for acute MI in different ethnic groups for one standard deviation change in the various lipid measures in the inter-heart study. And just focus, the low HDL cholesterol was the most common abnormality and the high TG was the most common abnormality for making a huge difference in the incidence of the acute MI in different ethnic groups. Just one standard deviation change in this HDL cholesterol and the high TG. Is not only the adults. We have seen an atherogenic dyslipidemia in many asymptomatic young individuals in Indian populations. This was basically a tertiary care hospital study in South India, where they basically recruited young asymptomatic medical professionals between the age of 18 to 40 years. And you can see the breakup of the hypercholesterolemia, hypertriglyceridemia, high LDL, and see the significance of the low HDL cholesterol among young population of the medical professional in this tertiary care hospital study in the South India. So this gives us a sort of a thinking that we should aim for the screening for the atherogenic dyslipidemia from an early age to prevent the coronary artery disease. The same study had shown that instead of doing a separate lipid parameter profile, it is better to use various indices for the coronary risk assessment, which are more potent than the lipid profile. And in that study, they used three main important atherogenic risk indices, that is the atherogenic index of plasma, Cassell's risk index, and Cassell's risk index 1 and 2, just to show that they were more important and more potent in assessing the coronary risk assessment in patients, particularly Indian population, and when you're using the atherogenic indices. Not only in the middle age or the adults, the dyslipidemia is also seen more prevalent in teenagers in Indians. So this was a survey which was done in the school going children of age between 14 to 18 years. And you can see that among the boys, among the girls, the low HDL cholesterol was more among the girls. The high TG was again more in the boys as compared to the girls. And it is pertinent to note that even our teenagers are also suffering from the lipid abnormalities in the Indian population. Why? Why dyslipidemia in Indians is different? Because we have a very high prevalence of atherogenic dyslipidemia. we have a higher prevalence of the traditional risk factors and greater prevalence of the risk factors at a younger age group as compared to the Western population. Lack of awareness on the CAD prevention. The diet is a dietary factor important. Physical inactivity, secondary to the rapid urbanization, is again an important contributing factors. Well, coming to the diet, dyslipidemia profile is seen more in the vegetarians in the Indian population. And Indians diet which are rich in carbs and low in omega-3 PUFA exacerbates hypertriglyceridemia in the Indian population. Asian Indians are more physically inactive, maybe because of the fast economic developments in the recent years. And a beautiful article where they are shown what are the practices of physical activity among the future doctors in Indian population. And they are shown the lack of time, laziness, exhaustion from academic activities were identified as the important hindering factors among the medical students who did not exercise. So this is one of the important thing to note why our young medical professionals are having abnormal lipid parameters because of the lack of physical activity. There are some of the important genetic factors which are unique to the Indian population. Abnormal variants of ApoC3 and ApoE3 genes common in Indian population, which has been seen. Indians have more abdominal adiposity as compared to the Caucasians, and the thrifty gene here has to be blamed. The body composition of Asian Indians makes them more vulnerable: shorter height, lower BMI, excess body fat, abdominal adiposity, truncal adiposity, and the less lean body mass. There are some other non-traditional risk factors which should be considered in Indian population, like coronary calcium artery score, aortic stiffness, higher LP little a, obesity and metabolic syndrome, elevated homocysteine, elevated CRP, higher plasminogen activator inhibitor PI1, and the most important, altered adipokine production and action, contributing to reduce insulin sensitivity in Indian population. We are low in adipokines. And that is why our Indian population is more insulin resistant as compared to the rest of the world. So this is the called Asian Indian paradox. High disease burden, low prevalence of the traditional risk factor. We have a disease at a younger age group and with the poor outcome because of the Asian Indian paradox. Last few slides I will do why do Indian dyslipidemics need special attention or not. Yes, what can be done? Need to develop our own CV risk calculator, and unfortunately we are not able to do that because we usually follow the ACC EHA, which doesn't give a lifetime risk. But the Joint British Society 3, JBS 3, also gives the estimate of the lifetime risk, and which has been shown to be validated in an Indian population, and also they include the non-conventional risk factor. Last but not the least, need for the ethnicity-specific dyslipidemia management guidelines for the Indians. And I'm really fortunate for the group who made it possible to form the Lipid Association of India. And they were first to form a position statement, the India Expert Consensus Statement on the Management of Dyslipidemia in Indians, and the part 1, which was released in 2016. 8 meetings, 153 experts, 18 states, 30 cities. And what are the key recommendations of the Lipid Association of India? Screen early, rule out secondary causes, fasting lipid profile not mandatory, non-HDL cholesterol should be calculated every subject. Risk stratification should be based on conventional as well as a non-conventional risk factor, and here to estimate lifetime risk in all low risk individuals. Roll up primordial prevention. This is just to give the snapshot of the Indian risk stratification: low risk, moderate risk, high risk, very high risk, and I have not included the extreme risk. So these are the pointers which may slightly differ from the ACC and AHA risk stratification what they have come. These are our own consensus guidelines to stratify the Indian population. And these are the treatment goals which my previous speaker has already highlighted. I think LAI was the first to tell that lower the LDL, better the outcome. In fact, they were the first to come up a LDL target of the less than 50 in very high risk. And soon you are going to see a LDL target of less than 30 in patient of the extreme risk population. India should aim at more than 50% reduction in the lipid parameters so that you can have a 57% lower event rate. This should be our aim. We should popularize. The Indian population should aim to have a more than 50% reduction in the LDL goal. So what treatment strategy you should adopt? You have to, apart from the LDL, you have to address the residual CV risk. Target beyond LDL, you have to see the non-HDL cholesterol has been shown to correlate well with the subclinical atherosclerosis because it better correlate with the of ASCVD, include TG and LP little a, does not need fasting, can be easily calculated by the total cholesterol HDL, and it is a surrogate marker for the small dense LDL particle. So ladies and gentlemen, what else can be done for the Indian dyslipidemics? Reduction of the abdominal obesity through lifestyle measures, increase intake of the omega-3 PUFA in diets, optimal management of the risk factor, fibrates and PUFA, omega-3 PUFA also have anti-inflammatory and anti-atherogenic properties, may be additionally useful in Indian population, managing and monitoring non-HDL cholesterol, increase the public awareness about the less than 50% reduction in the lipid parameters. Thank you very much.
Thank you, Dr. S.K. Wagnu, sir, for excellent information regarding the Indian people about diabetics, dyslipidemia. With this, we'll take all question answer in panel discussion. With this, I invite our another chairperson, Dr. Priti Ahuja, well-known diabetologist from Kanpur. Please, Dr. Priti. Dr. Priti, please unmute.
Yeah, am I audible now?
Yeah.
Yeah, a very blissful morning to everyone. And it's my great pleasure and honor to chair this morning session on diabetes dyslipidemia. And first of all, I'm grateful to Dr. Banshi Sabu and his entire team, RX Events, for giving me this opportunity to chair this session. So I'm not wasting much of your time. Now moving on to the third topic of morning session, that is the case-based discussion on diabetic dyslipidemia. And that will be taken up by the prominent and distinguished speaker, Dr. S.N. Narsingan. He did his MD, FICP and FCCP from USA. He's a vice chairman of Lipid Association of India. Indian Society of Hypertension, former endowed professor, the Tamil Nadu Dr. MGR Medical University, and he's the managing director of SSN Diagnostic Center and SNN Specialties Clinic in Chennai, and Dean Professor M. Vishwanath Diabetes Research Center and MV Hospital for Diabetes. And academically, he has published 71 articles in prestigious medical journals and contributed chapters for the textbooks of medicine on lipid disorders, atherosclerosis, hypertension, diabetes, and cardiovascular disorders. And he has delivered many guest lectures at national level conferences and international meetings. And he also served as vice chairman, LAIA published expert consensus statement recommendations for lipid management 2016 part 1 and consensus statement on management of dyslipidemia in Indians 2017, and he has received many awards. He received Lifetime Achievement Award by the Tamil Nadu Dr. MGR Medical University, Master Teacher Award by Indian College of Physicians and API India, Distinguished Teacher award by Government Stanley Medical College and Hospital, Dr. Jivraj Mehta Award in 2015 by API, and he also received World Hypertension League bestowed on him an award in recognition for setting highest clinical and academic standards in the field of medicine. Now, with these words, I invite Dr. S.N. Sir, Narsingan Sir, to please start your session.
How can I share my slides? Not appearing here. Can you unshare your slides?
Yes, sir.
Slides are not visible.
No. Okay. The slides, what you introduced me, no? Can you just go back to the slide so that I can?
Yeah, it's already gone, sir. Now you can share.
The sharing facility is not visible here. That's what I'm
Click
wondering.
on the share screen.
Which is not visible here. That's why. 1 minute.
The share slide option.
Yeah. It is there now. 1 minute. Huh? Is it visible now?
Yeah, sir, it's visible.
Thank you very much, Dr. Preeti and other co-chairpersons. And it is my pleasure to participate in the scientific session on Diabetes India 2021. At the outset, I would like to thank Dr. Banti Shabu and his team for giving me this excellent opportunity to be with you this morning to talk on a case report of diabetes and dyslipidemia. Actually, a 29-year-old gentleman contacted me for the problem of type 2 diabetes with a history that he had been taking metformin 1 gram twice daily. He lost his father at his 47 years of age. His BP was 125 by 83, 878.7 centimeter. BMI was 22. There was no corneal arcus. There are no xanthelasma or xanthomata. The normal cardiovascular system examination. His lipid profile, total cholesterol 286, LDL 220 milligrams, HDL 35, triglyceride 210, lipoprotein 60 milligrams. Fasting blood sugar levels were 120, HbA1c 6.9, TSH levels normal, creatinine normal, ALT, AST normal, urine analysis nothing specific. So this 29-year-old gentleman who is a diabetic and non-smoker with a strong family history of premature coronary artery disease and death, father died at the age of 47. He has all lipid abnormalities in the form of one, high triglycerides, higher levels of LDL cholesterol, higher levels of lipoprotein and low levels of HDL cholesterol. Actually, I strongly recommend it, even for my students who are actually under me. Every time when you see a patient with a dyslipidemia, you need to rule out secondary causes for dyslipidemia, which I did it was normal. So this patient, in fact, I calculated the true LDL cholesterol. What is true LDL cholesterol? Normally, the lipoprotein contributes some amount of cholesterol to the LDL. So it is normally expected about 1/3 of the LPA contributes the cholesterol to the LDL. In our patient, the LPA levels is 60. So 1/3 of that is 20 milligrams. So 20 milligrams should be subtracted from the LDL levels, what we had seen. It comes to about 200 milligrams. It was a direct LDL cholesterol which was measured. Non-HDL cholesterol is the one. Total cholesterol minus HDL cholesterol gives you that number. And in our patient, it is 262 milligrams. Having seen this is the most interesting one which I thought I should project. This is a family pedigree of this particular individual, proband. We have seen that this gentleman has got total cholesterol high, triglycerides high, HDL is low, lipoprotein is 60. Proband is the patient. Now look at the father who also had total cholesterol high, triglycerides high, HDL levels low. The LPA levels were not available at the time when the patient lost his father. And another one, the uncle. Uncle also the same, total cholesterol raised, triglycerides raised, HDL was 28, and lipoprotein only 5. The paternal uncle also had coronary artery disease at the age of 53 years. And now look at the mother. Mother is actually normal, but she is a diabetic. Total cholesterol is 160, triglyceride is 80, HDL is 35, lipoprotein is 10. Look at the problems with the sister. Sister, she is a diabetic. HbA1c is 8.9 in control. LDL cholesterol is high, 143. ApoB is 133. She also has one total cholesterol very high. Triglyceride is very high. HDL is low. Lipoprotein is only 6. Having seen this, let me also tell you the proband, our patient also has, in addition to the LDL cholesterol, he also has the ApoB, which is very high. I think this particular family pedigree has given me a lot of diagnosis in my mind. One, can this be a case of familial hypercholesterolemia over and above type 2 diabetes? Number one. Two, familial hypertriglyceridemia. Number two. Number three, familial dyslipidemia. So, first of all, let us look at the familial hypercholesterolemia. This can be, FH can be one homozygous, number two, heterozygous. Homozygous occurs commonly in children, and of course, the very, very rare to get it. Pendant xanthoma, xanthelasma, all those markers will be identified by you, very easy to make a diagnosis. Heterozygous, probably around the age of 30 or so, they may get into problems of coronary artery disease, and they may not get the extreme longevity. Probably most of them will succumb by the age when they reach about 50 years or 55 years. So LDL, not necessary that it should be elevated in all patients with a familial hypercholesterolemia. That's the most important point. But in our patient, the LDL cholesterol is very high. So everything fits in with the familial hypercholesterolemia. But surprisingly, he's not having a corneal arcus. He's not having a xanthelasma. He did not fit into the other categories of CASH criteria or the Simon-Brome criteria. But one thing that I should tell you is that LDL cholesterol is abnormally high. If any LDL cholesterol is more than 190 milligrams, you need to think in terms of a familial hypercholesterolemia. That's most important message, what I thought I should share with you. Number two is a familial hypertriglyceridemia. Usually, such patients will have abnormal elevation of triglyceride, but the LDL is usually low in such individuals or low normal. But in our patient, it is definitely raised. So it is quite unlikely to be only a simple case of familial hypertriglyceridemia. The third one, familial dysbeta lipoproteinemia. Again, they will have the skin markers. It is not there. It is usually an autosomal recessive disorder. ApoB is usually normal, but in our patient, ApoB is high. Cholesterol is seen in larger particles in the VLDL and ideal range. So these three things which I had highlighted, probably hypercholesterolemia could be one diagnosis, familial, heterozygous, but over and above, we need to explain the hypertriglyceridemia also. So this patient not only has familial hypercholesterolemia problems, in addition, he also has a hypertriglyceridemia. So let us think about this particular diagnosis, that is familial combined hyperlipidemia, FCH. Now we'll go back to the family pedigree. Look at the proband, which I have already highlighted. All these problems. One is the total cholesterol, LDL cholesterol raised, ApoB is raised, the HDL is low, the triglycerides are raised, and the lipoprotein little in our patient is 60. That is one important information. Number one, the proband, that is a patient. Look at the father's problem. He also has total cholesterol, triglyceride raised. So that means he comes under the category of familial combined hyperlipidemia. Over and above, the father's lipoprotein little was not available. He did not get any sort of report from the father's records, but I can probably presume that his father would have had lipoprotein little levels, which is probably around 50 and above, because mother is not having it. Mother is having only 10 milligrams of lipoprotein little a. That tempts me to think in terms of a higher levels of LPA father would have had. That is why this patient proband is probably now having increased levels of lipoprotein little a. Look at mother. Mother has got only diabetes. All other parameters here are normal. Look at the sister's problem. The sister has got an uncontrolled diabetes. She has got high triglycerides, high cholesterol, low HDL, but the lipoprotein little is low. Look at the paternal uncle. Paternal uncle, which I've already informed, that the patient has got a familial combined hyperlipidemia. So familial combined hyperlipidemia is seen the paternal uncle, father, proband, and sister. All of them are having the familial combined hyperlipidemia. Over and above, this patient also has an increase in the lipoprotein little which is not seen in the paternal uncle, which is not seen in the sister, which is not seen in the mother. Probably father would have had because it is an autosomal dominant recessive inheritance. Having seen this, let me try to tell you something about familial combined hyperlipidemia. It is an autosomal dominant pattern of inheritance with elevated cholesterol, one, or elevated triglyceride, or both. Usually, VLDL and the LDL cholesterol moderate to severely elevated, and the ApoB is always elevated. In our patient, everything is now fitting into the diagnosis of familial combined hyperlipidemia. Over and above, he also has an elevated lipoprotein little a. It is again autosomal dominant trait determined by the quality of lipoprotein antigen. Now, if you want to propose the problem underlying could be a monogenic hypothesis can be entertained for this familial combined hyperlipidemia, where there is an excess production of VLDL cholesterol from the liver, which is probably having a lot of ApoB particles also. When it goes for degradation in the form of LDL remnants, VLDL remnants, they attack the LDL cholesterol, which becomes smaller and dense, precipitates an event. The VLDL remnants also crushes back to the liver again to go in a cycle. So this is called monogenic hypothesis, which can explain the familial combined hyperlipidemia. So when you look at the data available, you can see that 1 to 2% of the general population. I want to impress upon you that we should not miss cases of familial combined hyperlipidemia. 1 to 2% of the general population. It accounts for 30 to 50% of the familial causes of CHD and 10% of premature CHD. Again, the patient's father died, probably would have died only due to a problem of a combined hyperlipidemia. So it can present as hypercholesterolemia or it can present as hypertriglyceridemia or both. Variable presentation even within a given family. That's what we have seen. One patient is having only the lipoprotein little a, over and above, rest of them are all not having. Increased relative risk for coronary artery disease 1.7. It's thought to be a genetic complex disease, usually need co-inheritance of 2 plus genetic variants and affecting the lipoprotein metabolism. All along, we have been thinking that it is a monogenic hypothesis. The recent data, which was published only in the month of November last year, 2020, it gives you some indication about the characteristic abnormality seen in familial combined hyperlipidemia. Combined hyperlipidemia is usually genetically similar to hypertriglyceridemia. Combined hyperlipidemia and isolated hypertriglyceridemia share a polygenic basis, not a monogenic, polygenic basis through a common TG racing variants. An excess of common or rare genetic variants of LDL was absent in combined hyperlipidemia. So elevated LDL levels must be maybe due to unmeasured environmental or the genetic factors. This is the explanation that has been offered by the National Lipid Association statement, which was released in the month of November 2020. Having seen this, ladies and gentlemen, my patient is having a very high risk problem because he has got higher LDL cholesterol over and above the total cholesterol, which is high triglycerides, low HDL, and increased lipoprotein little a. He's a diabetic. He has got a family history of coronary artery disease and death. Almost all his family members are affected with the problem. So he comes under a very high risk group. Our data from Lipid Association of India in way back in 2016, we came out with the first recommendation saying that we should keep the levels of LDL cholesterol less than 50 and non-HDL cholesterol should be less than 80 in very high risk group of individuals. In fact, in 2020, last year, we came out with another recommendation for managing lipids in our country. In this, we have also included that lipoprotein little a more than 50 milligram is considered as a very high risk feature. Between 20 and 49 is considered as a moderate risk non-conventional risk factor as per our recommendation. Whereas in 2016 itself, the first recommendation, we came out saying that non-HDL cholesterol should be considered as a co-primary target in ASCVD prevention. what I would like to tell you, we were the first organization, Lipid Association of India was the first organization to come out with the recommendation that very high risk individuals should keep the levels of LDL cholesterol less than 50 milligram. Only in 2019, the ESC guidelines came up with saying 55. ASC comes out with 255 for a very high risk. Whereas in 2016 itself, we started coming out with the recommendation that it should be less than 50 milligram. Having seen this, I should also tell you, since our patient is also having hypertriglyceridemia, maybe that non-HDL cholesterol becomes a primary target. But we need to consider the evidence. We need to concentrate on LDL cholesterol first, and next concentrate on the non-HDL. For our patient, non-HDL cholesterol should be less than 80. Of course, we should emphasize diet and other modifications, particularly the therapeutic lifestyle changes, to be emphasized again and again to our patient. Of course, the sister's blood sugar need to be controlled. Sister's triglyceride need to be controlled after controlling the sugar also. The therapeutic consideration for my patient will be statins at a very high dose, which I started 40 milligram of rosuvastatin. And that did not bring down the LDL cholesterol to the satisfactory level. Then I added acetamide also. So aggressive lipid lowering is a must in this patient because of the strong family history. Of course, triglycerides should not be neglected. He has to be probably given some importance for the reduction. Where is the evidence for acetamide? All of us know about the improving trial, which has shown the way for us to add a non-statin drug like acetamide over and above the high dose or moderately higher dose of statin, which can be tolerated by a patient. You can always bring it down to the levels, particularly these patients who were diabetic. They were able to bring down the LDL cholesterol to 46 milligram, which resulted in the reduction of 24% of MI, and ischemic stroke came down by 39%. You can look at the Kaplan net curve on the left side. You can just see 5.5% of the absolute risk reduction that has been seen in those people who received acetamide plus statin in diabetic persons. Having seen this, you have reduced it, but you have not gone to the levels which we want. It is 46 milligram. Actually, it's 46 milligram, we can reach it, but in our patients, it's not possible because our levels are 220. Not possible to reach that level. So that means I need to go again to another drug, that is PCSK9 inhibitor. That is the evidence. You can look at this particular data on the left side. Compared to the non-diabetic people, people with the diabetes also have shown good amount of response. Whereas the 14.4% of diabetic individuals, in spite of reaching levels of less than 30 milligram, they were at a high risk of developing a residual risk. That means you need to concentrate on triglyceride. Where is the evidence to add any drug for triglyceride reduction at the same time getting a benefit? So far, we have not got any sort of evidence, but luckily, we have now got the evidence from reduced trial, which has shown icosapent given 2 grams in the morning, 2 grams in the evening, had benefited these patients who were diabetic with a higher levels of triglyceride, with almost normal levels of LDL cholesterol in the long follow-up, had resulted in about 25% reduction in the primary endpoints and 26% reduction in the secondary endpoints and 20% reduction, 26% reduction of cardiovascular death, which had been identified in reduced trial. Of course, now the criticism has started coming up with the reduced trial, which we can probably discuss it during the panel discussion. PCSK9 inhibitors, ladies and gentlemen, has shown us the best way of managing lipids. For my patient, I think is an ideal candidate to take PCSK9 inhibitor because it not only reduces the LDL cholesterol over and above whatever has been seen in the high dose statin plus acetamide, which you are not able to reach, put the patient on a PCSK9 inhibitor. It not only reduces the LDL, reduces the VLDL, remnant lipoproteins, LDL numbers comes down, non-HDL cholesterol comes down. And because when you concentrate on non-HDL cholesterol, if you're bringing it down, that means it subsumes all the bad effects of triglyceride. The lipoprotein little the only drug that has shown 25% reduction of lipoprotein little has been seen with the administration of avalokamab and alirocumab in studies. But it is not being recommended now. But what has been witnessed in the studies tells me that it is a potent drug, not only to reduce other abnormalities, but also lipoprotein little, which is the problem in our patient. Now, the bempedoic acid, it is yet to arrive our Indian market. It has been recommended FDA approved drug over and above statin drugs over and above eczema, you can use this drug in those patients in whom you are not able to reach the goal. And it is probably indicated for patients with heterozygous familial hypercholesterolemia. Probably our patient can also be benefited if that drug arrives into the Indian market. Okay, if you have gone to the text, you need to know what is in the pipeline. Inclisiran is another drug. It is a small interfering messenger RNA interfering drug which can probably suppress the PCSK9 levels, which is beneficial for patients with this sort of abnormality. So inclisiran probably will be helpful in due course in the years to come. So ladies and gentlemen, this is my last slide. Statins are the best drug. Statins are safe. Statins are efficacious. If you give a high dose statin, you will definitely get a good result. If you're not able to reach the goal in your patient, having given a high dose, which each patient can tolerate, then look for another drug, non-statin, that is estimate at 10 milligrams. You may get only about 15 to 20 milligrams reduction of LDL cholesterol over and above statin. But when you use a PCSK9 inhibitor, nearly 60% reduction of LDL cholesterol can be achieved. That's the only drug which is available in our country, which I actually had given the prescription for my patient, for which he is not willing to take it because of cost factor. Of course, I need to wait for the bempedoic acid to arrive into the market. We need to wait for the icosapentaethyl ester to be used in our patient with hypertriglyceridemia. Of course, time is not far off to witness the introduction of inclisiran in the place of PCSK9 inhibitor because it becomes cost effective. We can use it only twice a year, whereas PCSK9 inhibitor every month, whereas inclisiran can be used twice a week. Thank you very much, ladies and gentlemen, for patient listening.
Thank you, sir, for such a beautiful presentation that you explained the thing so wonderfully, that how we should diagnose the familial triglyceridemia, familial hypercholesterolemia, and then to make the diagnosis of familial combined hyperlipidemia, and how we should start the treatment early so that we can prevent the coronary heart disease in the patient. So now moving on to the last topic of this morning session on diabetes dyslipidemia. That is the latest guidelines for the management of diabetic dyslipidemia, and that will be taken up by the renowned Dr. Raman Puri. Now, he is a senior interventional cardiologist at Indraprasth Apollo Hospital, New Delhi, and is one of the leading cardiologists of the country. He is the senior interventional cardiologist with more than 1 lakh non-invasive cardiac procedures and more than 3,000 invasive procedures to his credit. He has been the pioneer and instrumental in framing expert consensus statement to treat dyslipidemia among Indians and Asians. His key contribution is in the field of lipids, and he has established Asian Familial Hypercholesterolemia Registry, where such cases can be reported by Asian healthcare workers and patients. He has conducted an epidemiology study to understand the prevalence of dyslipidemia in school-going children, abstract published in GAACC in March in 2015. And he has been instrumental in starting Healthy Heart Cricket Tournament, had first tournament on 1st April 2018, a unique initiative for increasing the awareness among doctors and public. Over to you, sir, now. Dr. Raman Puri, sir.
Thank you, Dr. Preeti. Are my slides visible?
Yes, sir.
Yes, sir. Visible.
So for good morning, everybody. And first of all, I'll thank Dr. Bansi Sabu for giving me an opportunity to present the latest guidelines for management of diabetic dyslipidemia. If you look into the prevalence of diabetes, it's a global problem. There were about 463 million adults in 2019 living with diabetes, expected to touch 700 million by 2045. Even the diabetic population has increased in India from 26 million to 65 million between 1990 to 2016. This is an important study from India, 11 cities. And it was found that in the age group of 30 to 39, the prevalence of diabetes was 11.7% and impaired fasting glucose was 21.5%. And any dysglycemia was about 33.2%. The importance of this figure is because the impaired fasting glucose is associated with increase in cardiovascular events. As you can see here, as compared to normal fasting glucose, those with impaired fasting glucose or pre-diabetic state, the hazard ratio becomes 1.29. And in that ratio is about 1.66 when patient is, develops diabetes. And even in patients with metabolic, when they compare to non-metabolic, the events goes up, and event goes up to the extent the component goes up. Another study from India, a newly diagnosed patient, there were 4,600 patients. It was found that 46% of these newly diagnosed patients were in the age of less than 40 years. That shows that there is increase in prevalence of early onset diabetes in our Indian population. Now, these young onset diabetic patients have high chance of cardiovascular event in their late 50s and early 60s. Therefore, it definitely needs an effort to control all modifiable risk factors, and we should try to achieve LDL cholesterol and non-HDL cholesterol target at earliest. There are some complications which are duration-related diabetes, like cardiovascular burden. There is increase by 48% in diabetes of 15 years plus. Not only the CVD burden, even mortality goes up. So duration-related CVD mortality and morbidity should always include the period of pre-diabetes, which may be for 5 to 10 years, since there is a strong possibility of underlying subclinical atherosclerosis at the time of diabetes is diagnosed. Therefore, there is a strong need for achieving lipid target at earliest, including starting statin from day one of the diagnosis, in addition to lifestyle intervention and control of all modifiable ASCVD risk factors. The prevalence of coronary artery disease and cardiovascular disease in diabetes is 21 and 32 respectively. And if you look into the dyslipidemia, 85% of male diabetic has dyslipidemia, and 98% of female diabetic have dyslipidemia. As already been discussed, diabetic dyslipidemia means high triglyceride, low HDL cholesterol, and LDL cholesterol is either normal or mildly raised, and there is increase in small dense LDL particle. Why LDL particle, small dense LDL particle is dangerous? Because it is more atherogenic. Why it is more atherogenic? Because it is more susceptible to oxidation. And it's only oxidized LDL cholesterol which is taken up by the macrophage, which subsequently changes to foam cell. And when the size is reduced, the ApoB100 undergoes a conformational alteration. This results into a decreased affinity of this LDL particle to LDL receptors. Therefore, these LDL particles stays for much longer time in the circulation, and they get more opportunity to get into the subintimal space and initiate process of atherosclerosis. And also they have an increased affinity for proteoglycans. So therefore the retention in subintimal space is more than the large LDL particle. As being discussed before, also we have the diabetic patients have high incidence of stroke and cardiovascular mortality. And most important thing is that 70% of them die because of cardiovascular disease. Now let us see what is the CVD mortality statistics of India. It has gone up by 41% from 1990 to 2015. There are important facts about CVD, disease, cardiovascular disease in India. We have high incidence of premature coronary artery disease, as 40% of Indians with CAD are less than 40 years of age, and 25% of those dying of coronary arteries are less than 40 years of age. And I've just said in one of the study, 46% of the new onset diabetes was also less than 40 years of age. Therefore, and the combination of diabetes and coronary artery disease extremely lethal. I will discuss it in my subsequent talk. There have been a great benefit in lipid guidelines in United States. There has been a significant decline in CVD mortality there. And not only in United States, even in European countries, the CVD mortality has come down. So what is our objective? Our objectives are very clear. We have to reduce CVD mortality in diabetes. The first is good glycemic control. Then we have to treat dyslipidemia, achieve targets at earliest, and we should control hypertension and other ASCVD risk factors. These are extremely important for us to reduce the CVD mortality. There are strong scientific evidence that if diabetes is present in patients with coronary artery disease, there are more events at any level of achieved LDL cholesterol. Whatever the level of LDL cholesterol, diabetes will increase cardiovascular event. This is very clear from these statin trials. You will find that patient of coronary artery disease on statin with diabetes had more events, 33.4, as compared to patients of coronary artery disease without statin. That shows that the absolute risk of cardiovascular event is markedly increased by presence of diabetes in patients of coronary artery disease. This will be more clear in this IMPROVE-IT trial study. Here you can see that these are the diabetic patients, these are non-diabetic patients. Both of them had coronary artery disease. Diabetic patients have more events as compared to non-diabetic. There is a greater benefit, there is a wide separation, less benefit. Absolute risk reduction 5.5, absolute risk reduction 0.7. And this orange line is achieved LDL cholesterol of 53, and the blue line is achieved LDL cholesterol of 70. Even at 53 milligram of achieved LDL cholesterol, diabetic patients have more event as compared to coronary artery disease patient at a higher LDL cholesterol value. That shows that we have to be very aggressive when we are treating patients of coronary artery disease and diabetes. Please look for diabetes in patients with coronary artery disease, and in patients of coronary artery disease, look for diabetes, because your target changes as soon as they are together. Now, what about the lipid guidelines? Let us go back to some old guidelines. In 2008, ACC consensus statement, diabetes with one or more additional CVD risk factor, LDL cholesterol recommended was less than 70. Then came ACC 2013 guidelines. They said there is no need for target. They identified 4 statin group of patients. And in diabetes patient, those diabetic patients with LDL cholesterol of 70 to 189 without ASCVD, if their 10-year ASCVD risk was less than 7.5%, you give moderate intensity statin. If it was more than 7.5%, high intensity statin was advised. In 2016, LAI came out with first expert consensus. I'm not going to discuss in detail. We classified diabetic patients into 2 categories. Those diabetic patients with no or 1 ASCVD risk or no target organ damage, they were classified as high risk group. And patients of diabetes with 2 or more ASCVD risk group or target organ damage was, classified as a very high risk group. The goal of LDL cholesterol has been discussed before also. 4 months later, European guidelines were published. What they recommended, that diabetes with target organ damage, the goal should be less than 70. And those without target organ damage, the goal was 100. This differed from our guidelines, and it made us in a difficult situation, because it was very difficult for us to convince our colleagues that what targets we have recommended looks justified. But in 2019, they came out with new guidelines. Here, they brought down the target level to less than 55 in diabetes with target organ damage, and without target organ damage, they gave a target of LDL cholesterol target of 70 milligram. But the problem is this. They have not given any recommendation for LDL cholesterol target in patients with CAD plus diabetes and associated comorbidities. This is the biggest limitation for EAS. They have given another risk group, which they call is an extreme risk group. If you have a recurrent ACS, they have given a target of less than 40 milligram. But they have not given target of coronary artery disease and diabetes in their guidelines. American Diabetic Association is very simple. They simply say if patient is in the age group of 40 to 75, give moderate intensity statin in addition to lifestyle intervention. If they have, in those who are having diabetes between 20 to 39, you can initiate diabetes if they have an associated ASCVD risk factors. And if the ASCVD risk factors are more, or patient is in the elderly age group of 50 to 70, you start with high intensity statin. But these are a lot of limitations, we can discuss, because this is in short time, I will not be able to discuss. Now, this slide shows the TNT is patients of stable coronary artery disease, and IMPROVE-IT trial is patients of post-ACS. That the diabetic patient, despite high intensity statin, had more residual cardiovascular event as compared to non-diabetic. This is a very important slide. It's a post-hoc analysis of IMPROVE-IT trial. Patients with diabetes and patients without diabetes. Both of these patients have coronary artery disease. Based upon number of risk indicators, these patients was classified into low risk group if there is no or one risk indicator. If 2 risk indicator, it is a intermediate risk group, and it is 3 or more, it is a high risk group. You will see that in diabetic patients, irrespective of the risk group, there is a significant benefit in cardiovascular risk reduction. Absolute risk reduction of 5.8% in low risk group, 2.7% in intermediate risk group, and 5.5% in high risk group. Whereas in those patients of coronary artery disease without diabetes, there was no benefit in low risk group, absolute risk reduction of 1.3, or intermediate risk group, and only benefit was seen in patients with high risk group. Another slide. With coronary artery disease, when there is associated diabetes, risk goes up, and if there is associated peripheral artery disease, the risk goes up further to 56%. That shows that you cannot equate all patients of coronary artery disease or diabetes in one platform. You can't put them in one basket. That is something which is very important to understand. This is another trial. This is a trial of patients of acute myocardial infarction undergoing PCI. This is 1 year follow-up in hospital, 6 months and 12 months. You will see that those patients of coronary artery disease, when compared with coronary artery disease and hypertension, coronary artery disease with the diabetes, and coronary artery disease with diabetes and hypertension, the risk goes up as the number of comorbidity goes up, both in hospital, 6 months and 12 months. So these all comorbidities plays a very important role in future cardiovascular event in these patients. So I think you will agree to my statement that you cannot justify having the same goal of LDL cholesterol in patients of diabetes with or without ASCVD and with or without other comorbidities. American Association of Clinical Endocrinology was first to bring extreme risk group, in which they gave a target of LDL cholesterol less than 55 in patients with diabetes and coronary artery disease, but they did not give any target for diabetes, coronary artery disease, and other comorbidities. And this was also with the Taiwan lipid guidelines, LDL cholesterol less than 55, but no recommendations for associated comorbidities. Then American Diabetic Association, very simple. If the patient has diabetes and coronary artery disease, give high intensity statin. If they have coronary artery disease, diabetes, and other ASCVD risk factor, try to bring down LDL cholesterol to less than 70. Either you add ezetimibe or you add PCSK9 inhibitor. They have made it very simple. So they have not given different goals. They have talked about threshold. They have not given goals. So this is again a limitations of theirs. Even American Association of Clinical Endocrinology, they have recommended goal of less than 55 in their latest publication, but they have not given the same limitation which I have discussed before. Now, with these ideas in our mind, that why people have so many cardiovascular events at much lower LDL cholesterol, what are the baseline characteristics of these patients? We had series of meetings and we published 2 documents. One was published in March 2020, another was in November 2020. And we came out with our extreme risk group, which Dr. Narsinghan has already talked about details. These are the goals of LDL cholesterol in patients of diabetes with ASCVD and without ASCVD. And I won't like to go into detail because this has already been discussed about the goals. Now, why we came to diagnosis of 30 milligram? What was the point which made us to come to and give a, give a target of LDL cholesterol less than 30 milligram? One was the 4-year trial in which LDL cholesterol was brought down from 93 to 30 milligram with the 15% reduction in primary endpoint. And 2 important meta-analysis, statin trial meta-analysis and non-statin trial meta-analysis. In both these meta-analyses, it shows that if you achieve LDL cholesterol less than 30 milligram, there is a significant reduction in cardiovascular event. And that these are 3 most important post-hoc analysis, which again shows lowering LDL cholesterol down to 30 or below 30, there is significant reduction in events as compared to those who have a higher achieved LDL cholesterol. Recently, National Lipid Association of United States has come out with a statement on prevention of ASCVD in South Asia in United States. I happen to be a part of this position paper. And here they also, created an extreme risk category, and they have put patients of diabetes with the coronary artery disease as one of the extreme risk group category, and they have given the target of LDL cholesterol less than 30 milligram. Now, even if you achieve LDL cholesterol 30 milligram, 14.4% of these patients had events. So we have to look for other lipoprotein levels too, like non-HDL cholesterol, triglyceride, and lipoprotein A. And we have, in our latest recommendation of 2020 triglyceride, we have recommended LDL triglyceride of less than 150, but it should be, we preferred less than 100. If you can achieve 100, it is good. And importance of lifestyle intervention is very important, and good diabetes control is extremely important to have a good level of triglyceride. And non-HDL cholesterol target is co-primary. It is as important as LDL cholesterol. And we have now added ApoB in our recommendations, and we have recommended ApoB assessment to estimate ASCVD risk in diabetes, metabolic syndrome, and obesities, and extreme risk for category B. And these are the target of LDL cholesterol, non-HDL cholesterol, and ApoB in what is our recommendation. In the ApoB is less than 50 in extreme risk group. That is all you can do when you are treating your patient, and always in a discordant ApoB and non-HDL values, target ApoB. You should not look for non-HDL cholesterol, but ApoB is expensive. Non-HDL cholesterol is for India, it's a poor man ApoB, so you should always try to achieve these targets. So take home message, my last slide, that you should screen Indians for diabetes, pre-diabetes, and other ASCVD risk factors, including lipid profile, include lipoprotein small and ApoB level if possible at age 20 or earlier if indicated. Lifestyle intervention is very important. Decide diabetic patient ASCVD risk category. Classify in which category this patient belongs to. Achieve LDL cholesterol target, non-HDL cholesterol target, and ApoB as recommended by Lipid Association of India. Initiate statin or day 1 of diabetic diagnosis. Once you make the diabetes diagnosis, day 1, you should start statin and try to achieve all targets at earliest. Good glycemic control is, in addition to lipid lowering drug, is important to achieve these targets, and treat all modifiable risk factors as per respective guidelines. Thank you very much for your kind attention.
Yeah, thank you, sir, for such an excellent presentation. You very well explained the things. So now the house is open for question answers. Dr. Patel, are you there? And there are no questions in the chat box as well. So we can have the panel discussion. So may I ask you one question, that what is the role of this omega-3 fatty acids in controlling this dyslipidemia? Dr. Ramanpuri.
Okay. See, omega-3 fatty acid has been in ongoing talk for many years, But there were some trials which showed positive result. Many showed negative result. Many meta-analysis showed negative result. It was only reduced trial in which icosapent ethyl ester, when given in dose of 4 grams, showed significant reduction in mortality. If you look into the total mortality, it came down by 10%. If you look into the cardiovascular mortality, it came down by 20%. Same mortality reduction what we got in statin. When in 1994 statins, results were published, the same mortalities. What a wonderful reduction of cardiovascular events. But there has been some controversies because we are not able to explain the benefit, on what basis this benefit has come. It has no relations to LDL cholesterol, no relation to non-HDL, neither to triglyceride, neither to level of EPA also, because there was another trial, strength trial, which was published recently, and this has been discontinued prematurely because there was no benefit. EPA level was much higher, but there were no benefits seen in those patients with high EPA in strength trial. So it is still not possible to explain the, such a wonderful results with reduced trial. One of the reasons which has been said is the mineral oil which was given prevented the absorption of statin. Probably there were more events in this patients in this group as compared to those group in which icosapent ethyl ester is there. It's a part of a discussion. There are no conclusions at present. We recommend. So in our patients, if we achieve LDL cholesterol target and we are not able to achieve non-HDL cholesterol target, then we should add, in Indian scenario, fibrate as the first line of treatment. And in case we are not able to, afford, if we can afford icosapent ethyl ester, then it becomes a choice because it reduces cardiovascular mortality and total mortality. That is extremely important. But of course, if you fail to achieve with omega fatty acids also the TG level and non-HDL cholesterol target, then PCSK9 is always a final drug, though a very expensive. How many of us can afford it is a $1 million question. So at present, we have to wait for icosapent ethyl ester availability in our country and its price. What is going to the price? If it costs 2,000 rupees per day, nobody is going to have it, So that is a biggest, issue at present. But definitely, if the results are correct, then it is a wonderful drug.
Dr. Ramanpuri, can you just tell us the cutoff of the TG values in Indian patients, particularly at what level after the LDL reduction, if the TG is high, you are bound to add either the fibrates or the omega-3 fatty acid?
Dr. Wangnu, I think this question is raised many times in various platforms, and I tell them very, very simple answer to this. Triglyceride value is important to us when it is more than 500, because our treatment is to reduce pancreatitis. We have to bring it down to less than 500 to prevent pancreatitis. When it is below 500, our target is non-HDL cholesterol. We have to target non-HDL cholesterol, because if you bring non-HDL cholesterol to the target, triglyceride will automatically come, because what non-HDL cholesterol is total cholesterol minus HDL cholesterol. So non-HDL cholesterol includes LDL cholesterol also, and if you subtract LDL cholesterol from non-HDL cholesterol, you have remnant cholesterol, and this remnant cholesterol is what? It is the cholesterol content of the triglycerides. So when you are reducing non-HDL, you means you are reducing both LDL cholesterol and remnant cholesterol. And if you have achieved non-HDL cholesterol, this means you have brought down the remnant cholesterol in the triglyceride particles, triglyceride-rich lipoprotein. So to make it very simple, you have to bring down LDL cholesterol, number one, non-HDL cholesterol, number two. If the triglyceride is more than 500, that is your target. And once you bring down LDL and non-HDL to the target, and patients are extreme risk category B, patients of diabetes with multiple comorbidities, assessment on ApoB is very important, because if ApoB is discordant with non-HDL cholesterol, means you have achieved non-HDL cholesterol, but ApoB is high, then you have to be more aggressive in reducing, LDL and non-HDL cholesterol, because you have to achieve ApoB target. But if ApoB is normal and non-HDL cholesterol is high, don't be very aggressive in non-HDL cholesterol, because they are large particles, and these large particles will not cause atherosclerosis. So that is something which is very important, which we have highlighted in our latest expert consensus statement, that these are the importance of ApoB in not routinely, but in those patients, selected patients, which falls into extreme risk category B and diabetes with so many comorbidities.
Yeah,
But
Dr. SN.
If you look into the triglyceride, we will definitely prefer less than 100 milligram.
Sir, so after this full dose of statins, then if there is a hypertriglyceridemia, in spite of we have controlled this non-HDL cholesterol, then would you prefer this ezetimibe or this fibrates?
See, you have to first go to the high intensity statin and make sure that patient takes it. Make sure that patient is taking that. Number two, if your LDL cholesterol is achieved, for example, LDL cholesterol has come down to the target value, say less than 50 as per that, but non-HDL cholesterol, which should have been less than 80 or 80, is 110. Then I will definitely not add fibrate in this particular. Then we should give another, we can add ezetimibe also, because all statin reducing, all these drugs reduces triglyceride also. And even if non-HDL cholesterol is high, lowering LDL cholesterol is always going to help you. But there can be a controversy. Somebody may say that if you give fibrate does reduces LDL cholesterol. It has been 5% or 10%, so that will always add to the reduction of this. So either you increase azithromycin, what LAI has recommended is that you give high intensity statin, then azithromycin, and if azithromycin doesn't bring down the non-HDL cholesterol to the target, then you add fibrate plus minus omega fatty acid. Fibrate first or omega fatty acid first is a point of a discussion and physician choice. But wait for PEMA fibrate results, because PEMA fibrate results will be expected in a year or so. If it gives a good result, then definitely this will come a place before omega fatty acid. We are just waiting for PEMA fibrate results. I think Dr. Wangnu may be knowing something about it.
Yes, is going to be a better drug than the already available. I have one question with Dr. Narsingham, that is a paradox what we see in our Indian practice, that we see so many diabetic with dyslipidemia and we straightway put them on the statin as per the guideline. But I don't know, there has been a lot of individual response, whether it's based on genetics or anything. A simple moderate intensity statin, a low dose statin versus a high dose statin. In a patient, even if he's having LDL cholesterol 120, after giving him a low dose statin over a period of time with a good diabetes control, his LDL is achieved below 50. While in the other patient, even by using the high dose statin, we are not able to achieve it. This paradox I am seeing in my clinical practice. What is your opinion?
I think it is actually universal phenomenon. You are also experiencing it, and we do also come across such sort of patients, hyper responders, and probably people who are not responding to the conventional treatment with high dose statin, bringing down the LDL cholesterol with an attempt to bring it down. In spite of your very high dose, you are not reaching the goal. Such things are commonly encountered in our clinical practice. I think it all depends on the genetic factors, which are probably responsible to some extent, and of course the adherence by the patient. Patient may be may not be taking the adequate dose what we had prescribed. Probably he may be trying to consult the Google doctor and try to appreciate the effect of statin and then look at only the side effects of the statin, and then probably may not take it also. And the next visit the patient comes and tells you that I've taken it, sir. It's like that only, it is not responding, and I'm getting muscle pain, I stopped it. I think if you go into the depth of the details, people will come out with the truth that he has not been taking it. That part of it has to be probably given importance. We need to see whether the patient has been having a long-term adherence to the dose, what you had prescribed, and what you want in your clinical practice to achieve the goal in that particular individual has to be probably informed to the patient, and a good amount of interaction between the doctor and the patient has to be entertained. And we need to emphasize the fact that the patient requires the benefit of statin in the long run for him to avoid the cardiovascular burden and dying due to cardiovascular disease. This has to be explained, and we should not probably think about the so-called side effects of muscle pain. People who experienced muscle pain, they are all 50% of them, when they are put back on statin, they do very well. So this statin so-called intolerance is probably a myth.
Sir, may I ask one question?
Yes.
Sir, I want to have a clear message to the audience that in diabetic patient, should we do baseline lipid profile? If yes, fasting or non-fasting, or
Yes.
straightway start with statin and then do lipid profile?
No, the thing is, we are not supposed to straight away start with the statin. You need to have a lipid profile. When you ask your patient to go for a fasting as well as a PP blood sugar and the HbA1c levels to assess his diabetic status, why not we ask him to go for a fasting lipid profile? And that should include triglyceride. It should include a direct LDL measurement if possible. Otherwise, a calculated method by using the free dwell formula can be done in those institutions where the direct LDL measurement is not available. A non-fasting sample can also be encouraged in many situations. When the patient walks into a clinic in the evening time, probably you can ask him to give the sample and can come and get the results the next day. If the triglycerides are not raised, not more than 200, and if it is well within the border limits, probably you can depend on the lipid profile. You need not ask him to go for a fasting. In case it is more than 400 triglyceride, probably you should ask the patient to come in a fasting state so that you can assess exactly what is the level of fasting triglyceride, which will help you to identify whether the patient requires a separate attention for you to concentrate on the triglyceride reduction and the amount of blood glucose reduction, so that it will have impact in the reduction of triglycerides also. Not only that, if persons have been taking some drugs for triglyceride reduction, it is always mandatory that you should submit your patient the fasting lipid profile. In case the direct measurement of LDL cholesterol is not available, I think you should always ask for a fasting lipid profile, which will help you to identify whether the patient has got an problem. I think one should ask for a lipid profile. Only then you should start the patient on a statin drug. The parameters may be normal even in a diabetic who had spent about 10 years of his life with diabetes or 5 years of his life with diabetes. He comes and sees you for the first time and you ask for a lipid profile. The lipid profile appears to be normal. Even then, he requires statin. What we are now recommending from Lipid Association of India is that if you make a diagnosis of diabetes today, you should see that your patient takes statin also along with your oral hypoglycemic agents or a polypharmacy which you are attempting to give to these patients to have a good glycemic control.
Thank you.
One thing more I want to add to it is that even if fasting triglyceride is normal, you should always go for non-fasting, because we have recommended in our expert consensus that you should have both the values, because there may be abnormal response, maybe high postprandial triglyceride, and one should understand that there is a strong relation of coronary artery diseases, postprandial hypertriglyceridemia, and most of the time in a day we are in a postprandial state. So these postprandial triglyceride or remnant cholesterol is our arteries are exposed to these values. But rightly, what Dr. Narsinghan has said, that we require lipid profile assessment before the statin treatment to be started, and please include lipoprotein small a and ApoB if patient can afford, because though it is lipoprotein A is not related to the diabetes as such, but high values of lipoprotein A detected at age 20, we can prevent so many premature coronary artery disease or coronary events at 40s or 50 of that patient. So early detection of lipoprotein A is extremely important, and please include that in the standard lipid profile at age 20, which we have recommended. Nothing to do with the diabetes as such to reduce cardiovascular risk.
What about the patients who are less than 20 years having a normal lipid profile? What are the recommendations worldwide? Can you start statin therapy in the younger age group?
Dr. Wangdu,
forgot about the familiar.
No, I agree. I agree. What we have recommended in our first expert consensus is that when a patient comes to you at age, say, 25 or 20 or 26, no history of diabetes, he's not a smoker, his blood pressure is 130/80, and LDL cholesterol is around 130. Now, let us say this is a picture which is not uncommon. Question comes, should we start statin in this? Calculate lifetime risk score. If you, by JBS3, as you have said in your presentation, if it is more than 30% and lifestyle intervention of 3 months or 6 months fail to bring down LDL cholesterol to less than 100, there is no harm in starting small dose of LDL cholesterol like atorvastatin 5 milligram or 10 milligram. And this has to be a shared decision where patient should agree to it, and you have to explain him the benefit versus potential so-called adverse effect. I tell you, statin is one of the safest drug, can be given blindly also without liver function test, because it has shown that it has reduced so many cardiovascular events so far in last 30 years. So I think giving small dose of statin in young person, because it is not the level of LDL cholesterol reduced, how long it has been reduced is extremely important for us. Earlier you reduce it, better it is. Just for an example, a 40 milligram LDL cholesterol reduction from childhood as compared to, say, at 30 or 30, 40 years, what is the difference? At childhood, the CV reduction is to the extent of 54%. And whereas if you start in late 40s or 30s, it is only 22%. The benefit is much more if you bring down LDL cholesterol earlier. So I think that you have to have a mental framework to to have the benefit of statin and reduction of LDL cholesterol, and you have to just convince the patient. If both of you are convinced, it should be started.
And last question for the LAI, because I'm a part of LAI, a very pertinent question to ponder upon: the role of vitamin D in causing the insulin resistance. We know the insulin resistance is directly implicated in the process of atherosclerosis and the abnormal lipid profile in diabetic patient per se. And we have seen, and many of the literature says the a direct or indirect role of vitamin D in inducing the insulin resistance. Can LAI take a sort of a pilot program, whether the vitamin D replacement along with the other modalities of therapy will be an additional tool to bring down the abnormal lipid profile?
Dr. Narsingan?
In fact, routinely, we may not be in a position to recommend vitamin D for every patient who has to be given some statin therapy. Most of our patients, if they identify that vitamin has been prescribed, probably he will try to take only vitamin tablets and stop taking the statin. That's number one. People in whom you find that the patient has become a statin intolerant individual, in whom there is a vitamin D deficiency which has been identified, there is a definite indication for a continuous supervision and then vitamin D substitution therapy. Whereas patients in whom the vitamin D levels are normal and the lipid profile is abnormal, or you need to give the patients, depending on the risk what he is facing in life, you need to put the patient on statin. I think whatever has been said so far, I need to tell you that I don't think there is any pharmacological agent today available at our disposal to compare it with the statin, which had gone to prove that lakhs and lakhs of people who have shown benefits not only in cardiovascular morbidity reduction but also in mortality reduction. The final message that I would like to tell you about statin therapy is that earlier the better, faster is the better, and longer the better as far as the lipid lowering is concerned. With the statin therapy is still the gold standard. Whatever drug that you are getting at your disposal, it is still gold standard in the management of lipid disorders.
So I would like to ask, yes, sir. Yes, sir.
Okay, thank you. Specialist. We in Indonesia, we don't have we cannot do the risk estimate because we don't have the cohort. I'm asking you, which can I use in Indonesia? Because you have the risk estimates, risk assessment, that's the score of the ASG, ECA, of the HA, but which one to follow? You meet your own risk estimate.
I think JBS3 will be a good risk estimator because it takes ethnicity into account. So and so many other comorbidities and non-conventionals. I think what we have discussed a risk calculator in details, and I think finally everybody concluded that JBS3 will be best for most of the ethnicity because it takes into account, like for Pakistani, they have different risk assessment. For Bangladesh, they have a different risk assessment. So I think that will be much better for anyone rather than other. ACC is definitely, pool cohort is not good because they take only Americans and Afro-Americans. So they will underestimate our risk in our country. So I think that JBS3 will be an ideal, the best out of all for risk assessment for other ethnic group also, like Indian ethnic group.
I think I can request Dr. Siddharth one. I think you projected a lot of information about various guidelines. Now that you are aware about Lipid Association of India's recommendation, I will not call this a guideline. We will say only expert consensus statement from Lipid Association of India. I request you to go through our recommendation right from 2016, 17, 19, and 20. If you can go through all these things, you will probably come to the conclusion that this may be the correct one for at least for South Asian population.
I think I will do it because you adjust with in India. We don't have these studies which we have to learn from you. Thank you very much. But I have still one question for Dr. Ramanpuri. What about Steve Nielsen's comment of the strength study against the reduced it because of the corn oil placebo and the mineral oil placebo?
I think in reduced trial, it was mineral oil, and corn oil was in strength trial.
Right.
In strength trial. So corn oil has not shown any negative effect, but mineral oil, which we don't know, and the good results of reduced trial to great extent is blamed on this mineral oil. So right now we will take results of reduced trial with pinch of salt, and maybe with time we will be able to say yes to it, or plus minus or minus, we don't know. But at present we are happy with the results, and if it is true, it is correct results, then it is like statin, it is another wonderful drug if the price is reasonable.
But what is your own opinion?
We don't have much experience about all this. To be very frank, we'll not be able to answer this question because we have not discussed in our platform also anytime.
Because reduces is too good to be true, isn't it?
If it is true, then it's a wonderful drug. There is
Thank you very much.
Which one, sir? Which one?
Reduce icosapent ester.
Okay.
Shortly, we are coming out with 3 important consensus statements. One is in stroke, it is already gone for publication. Second, we are coming out with the PCSK9, role of PCSK9 inhibitor in ACS, it is on pipeline. And third, we are coming out with whatever I have discussed today, the position paper on recommendations on management of diabetic dyslipidemia. In 3 months to 4 months time, you will all see these important documents from LAI.
Thank you. Thank you very much.
Dr.
I think
Preeti, any other question that you would like to raise? Because you have another 3 minutes
Sir,
left.
what is the role of this saroglitazar in diabetic dyslipidemia?
Saroglitazar is not only a PPR alpha as well as a gamma agonist. It is a good drug to reduce the triglyceride. The drug was recommended mainly to control hypertriglyceridemia in people with diabetes. No doubt it works. We have seen it. We have used it also. But however, I need to tell you that we don't have any cardiovascular outcome data.
Any more questions from the panel side? So I think with this, we can wind up today's session. So I'm grateful to all the speakers. They have spared their valuable time and they have really enriched the knowledge on diabetes dyslipidemia. So thank you so much. Thank you, everyone. Thanks, sir.
Thank you
Bye.
very much.
Thank you.
Wagner, thank you. Thank you very much.
Thank you.
We had a wonderful time with you all. Thank you, sir.
Thank you very much.
Thank you, Dr. Preeti, Dr. Dhiren, Dr. Sio Gondo from Jakarta, Dr. Narsingan, Dr. Ramanpuri, and Dr. Wanganu for an excellent session on diabetes and lipids. Now we will move on to the next session in this all, that is related to novel therapies, that is SGLT2 inhibitor symposium. And I will invite Dr. Hina Goswami, the young dynamic diabetologist from the city of Jamnagar, to carry on with the proceedings of this session.
Thank you very much, sir. I'm Dr. Hina Goswami from Jamnagar. I'll introduce the 2 chairperson. First, I'll go with Dr. Surajdeep Sengupta, sir. He's practicing physician with special interest in diabetes and endocrinology. He did his UG and PG from Delhi and Jaipur. Certified in diabetes and endocrinology from Royal College of Physicians, UK. Fellow of Indian College of Physicians, Fellow of Royal College of Physicians, Glasgow. Member Endocrine Society, USA, and American College of Endocrinology. Fellow of Diabetes, India. Consultant in National Heart Institute, New Delhi. Second chairperson is Dr. Alka Gandhi from Mumbai. She is a founder director of Ayushi Diabetes Clinic, consultant diabetology in Namaha Hospital, speaker and faculty at national conferences. She has conducted various public awareness and camps and CME lectures for physicians. She has published articles in journals and papers at RSSDI, EASD, and ADA. She is the managing committee member of CID, managing committee member of Women in Diabetes Conference. She has special interest in GDM and Diabetes Forum. Thank you.
Hina. And good morning, everyone. Thank you, Team Diabetes India. Thank you, Dr. Bansi Sabu, for this opportunity. And we have a very interesting session coming up with very interesting and dynamic speakers. I welcome all of them. Welcome Dr. A.K. Singh. And we will start with him. Of course, all of us know him. And he's a senior endocrinologist at GD Hospital, Kolkata, and Sun Valley Hospital, Guwahati. He is an MD/DM. He has got honors in pharmacology and internal medicine. He has got various chapters in textbooks. He has got a most inspiring diabetologist and endocrinologist of India award. And he is reviewer at various articles in various important journals and PI in various phase 3, phase 4 trials. Dr. A.K. Singh is known for his a very important dissection of all important trials. So without wasting much time, we would welcome Dr. A.K. Singh for his presentation today on redefining management of diabetes by SGLT2 inhibitors.
Welcome. Thank you, chairpersons. Thank Diabetes India, first of all, Bansi and the entire team. Give me the opportunity to take you through this very popular topic, especially in the Indian context. I took the topic later. You can see, although this is a SGLT2 symposium, but it would be unfair if I do not look into other anti-diabetes drug, which has got a huge potential to lower body weight. And that's why I took the topic to managing diabetes with pharmacotherapy, of course, include P1 receptor agonist. Well, so this is a Jensen-sponsored symposium, but entire thoughts are mine and slide belongs to me. And Jensen has got no responsibility in my views. Well then, so what is diabetes? Of course, the name suggests that this is a coexistence of both diabetes and obesity put together. Why it is important? As you can realize that if you put on body weight, your chance of increasing impaired blood glucose gets high. And as you can see, with every 1 kilogram rise, your chance of getting diabetes is increased by 4.5%. It is obvious from this slide, as you can appreciate, that majority of diabetic patients, when I'm talking diabetes, it refers to type 2 diabetes. So if you are obese, and in Indian context, as you know, all definition is much lower than international cutoff. So once you are crossing the BMI 25, the chance of having diabetes goes, exponential. Problem lies is, as you can see, the both diabetes and obesity is, coming at the top. Remember, 10, 12 years back, India was, in almost at 13th rank in obesity, but now, if you see the entire globe, India is right now at number 3 with regards to the people with obesity. And of course, India had a dubious distinction of diabetes capital of the world. We have become second now, and we are projected to again become first. So we were already the number 1 in diabetes prevalence. And right now we are at number 2, but then expectedly 10 years down the line, we would be again diabetes capital of the world. So if you combine obesity and diabetes together, of course, we are in a twin epidemic of diabetes and obesity, as we are right now in COVID-19 and mucormycosis. So there's similar analogy, obesity and diabetes are twin epidemic in the Indian context. Now, what is worrying is that if you are obese and diabetes both, your chance of developing heart disease gets almost 2-fold higher. And you can appreciate from this slide, as you have got BMI increases, the chance of dying from heart disease goes exponentially. And this is data from HOPE study. This is subgroup analysis of HOPE, suggesting that if your BMI, and this is a waist circumference tertile, the moment you goes up, the tertile of waist circumference goes up, the chance of dying from cardiovascular disease or any cause death is exponentially high. Well then, how to reduce it? Now, if you look into the context of diabetes and obesity, two drugs which come to the forefront is SGLT2 inhibitor and GLP-1. And this is what is my focus is to talk about today. Now, when you look into the trials and try to understand in between SGLT2 and GLP-1, which anti-diabetic drug or rather anti-hyperglycemic agent has got a potential to prevent you from putting on weight while treating diabetes. Now, to compare two class of drug, you need to have ideally a head-to-head trial. However, in absence of head-to-head trial, there are ways to understand which drug in the class has got the highest potential to take care of HbA1c and body weight. What you can do is you can compare the trials with a similar baseline HbA1c and body weight, and then to indirectly compare which one has a potential to reduce HbA1c and body weight larger. The next way, in absence of head-to-head trial, is to go for network meta-analysis that gives you also indirect hint. But as I said, of course, the ideal way and the best evidence to understand is to conduct a head-to-head trial to really conclude that A is better than B. Now let's look into where are the studies we compare SGLT2 among themselves, GLP-1 receptor agonists, and the head-to-head trial among themselves, and finally the head-to-head trial between SGLT2 and GLP-1 direct. Now, if you look back and data prior to the head-to-head trial, so I will show you some of the head-to-head trial which has recently happened. Prior to that, this is a paper which we wrote 4 years back in 2017 when there was no head-to-head trial, and in fact still we don't have any head-to-head trial amongst SGLT2 inhibitor. Now, what you can measure here in this comparative analysis, when we measured the baseline HbA1c pretty similar in those studies and tried to understand which SGLT2 had highest potential to lower diabetes and body weight, means diabetes ability reduction, you can appreciate the highest dose of 3 permissible dose of SGLT2 inhibitor. You can clearly find out that the CANA 300 milligram, which is the highest permissible dose, seems to have the largest HbA1c reduction. But then again, the caveat remains that this is not a head-to-head trial. This is just an indirect way to assess. So this can hypothesize, but it cannot conclude in the absence of head-to-head trial. But the one thing that looks very prominent, if you see whatever kind of drug, plan of therapy, whether it is monotherapy or add-on to metformin or add-on to SU-MET or add-on to MET-PIO, you can clearly make out that tallest bar lies with CANA 300 milligram. And there is a reason behind why CANA 300 could have a best potential to lower HbA1c among all the SGLT2 inhibitors. When you look into the body weight, similarly trying to match the baseline body weight similar, you again can make out that CANA 300 seems to have the largest body weight reduction with the highest permissible dose when you compare 3 SGLT2 inhibitors. But then again, as I said, this is indirect comparison, not a head-to-head trial. Now the question is why the CANA 300 has got this ability, and I will come quickly onto that part. In the GLP-1 receptor agonist, this is a busy slide, no need to read. I will just give you the summary of this study, very recently published a couple of weeks back. We have 14 head-to-head trial amongst GLP-1 receptor agonists. Remember, this is double-blind randomized head-to-head trial. So what we understand from these 14 head-to-head trial with regards to HbA1c, that the highest HbA1c reducing ability lies with, injectable semaglutide, in order. So the highest HbA1c reduction right now seems to be with subcutaneous semaglutide, followed by oral semaglutide, that is in highest to lowest order. Then dulaglutide is pretty similar to liraglutide, and so on and so forth. If you look into the body weight part, again in this 14 head-to-head trial, it seems that the body weight in order, the highest being with the injectable semaglutide, followed by pretty closely followed by liraglutide and then dulaglutide when you talk about these four GLP-1 agonists. Now, what about GLP-1 versus SGLT2? Well, in absence of head-to-head trial, we had opportunity to again compare how the SGLT2 compares with GLP-1 agonist. Now, this is very interesting way to compare. And, if you look into HbA1c with the highest permissible dose of SGLT2 and GLP-1 receptor agonist, it looks like that Cana 300 milligram, in fact, is pretty close to GLP-1 receptor agonist. Then again, caveat remains that these are the studies we published in 2017, was prior to the injectable semaglutide and the oral semaglutide trial. So this is what we are comparing with dulaglutide, liraglutide, and exenatide once weekly. We didn't have any study at that point of time with semaglutide, both injectable and oral. But then it appeared that Cana 300 seems to compete with any GLP-1 agonist. Now, if you look again, body weight reduction, it seems, quite amazing that Cana 300 milligram is having a good competition with GLP-1 agonists. But then again, this was not comparing with semaglutide, both injectable and oral. Well then, if you look into the network meta-analysis in absence of head-to-head trial, there are many network meta-analysis. In fact, all of them suggest that Cana 300 could be even superior to liraglutide 1.2 milligram, both in HbA1c as well as body weight reduction. So these are, indirect way to understand how a SGLT2 works compared to GLP-1 in reducing diabetes. Now, why Cana has this 300 milligram has got this potential and looks to be different from other SGLT? The simple reason being that Cana 300 milligram is, has got highest potential to reduce, to increase glucosuria and RTG max. Now, if you compare Cana 300 milligram to Cana 100 milligram, you can see in this slide, this is the glucose excretion over 24-hour period of time. And you can see that Cana 300 is far superior to Cana 100 milligram. Now, why it is happening is perhaps the ability of Cana 300 milligram working through the SGLT1 in intestine. As you know, Cana 300 milligram is this selective SGLT2 right now, except the sotagliflozin, which has got SGLT1 blocking ability in intestine majorly and to some extent in kidney as well. Now, if you look into this data, this suggests how SGLT1 is responsible for glucose absorption in intestine. And if SGLT2 has ability to block SGLT1 transiently, remember the transient is important. If you block SGLT1 in intestine permanently, this will produce toxicity. So you need to block this SGLT1 in intestine very transiently. And because of this ability, the Cana 300 milligram has been able to reduce prandial blood glucose significantly. As you can see in this head-to-head comparison between Cana 100 and 300 milligram, there was significant reduction in prandial glucose spike with Cana 300 compared to the Cana 100 milligram. And, this ability of SGLT1 blocking lead Cana 300 milligram to have some kind of incretin mimetic ability by increasing GLP-1. So amongst the SGLT2, the Cana 300 milligram is one SGLT2 which has been shown to increase GLP-1 significantly by virtue of blocking SGLT1 in intestine, by blocking the absorption of glucose in intestine. The moment the glucose goes into the distal part of small intestine, it stimulates L cell to increase GLP-1. Also, it stimulates increased PYY, peptide YY, which is responsible for appetite. So Cana 300 milligram has been shown to increase GLP-1 and PYY significantly. And because of this PYY, it may have additional ability to reduce body weight by increasing satiety and appetite. These are the mechanistic explanation as to why Cana 300 milligram is different from other SGLT2 inhibitor, because both DEPA and IMPA doesn't have any ability to inhibit SGLT1 in intestine, even in the maximal permissible dose. And this is the reason as to why, look into this slide, the Cana 300 milligram monotherapy is as good as a combination of SGLT2 and DPP4 fixed drug combination. You can see the HbA1c lowering ability of Cana 300 milligram is as good as a combination of other SGLT2 with DPP4, because simply the Cana increases GLP-1, and as I said, has got partial incretin mimetic activity. Remember, these are not head-to-head trial. It's an indirect comparison just to realize how Cana 300 milligram is different from other SGLT2 inhibitors. Now let's quickly look into the head-to-head evidence, because this is the final nail in the coffin to understand how really the SGLT2 fares with GLP-1 in head-to-head trial. So if you really look into the data, we have got two head-to-head trials where SGLT2 was compared directly to the GLP-1 receptor agonist. So I will take you through these two trials, which is Sustain 8 and Pioneer 2, where in Sustain 8, semaglutide injectable 1 milligram was compared head-on to canagliflozin 300 milligram. And in Pioneer 2, the oral semaglutide was compared to the highest dose of empagliflozin, that is IMPA 25 milligram. The right-hand side trial are again head-to-head trial, but this is a combination of GLP-1, SGLT2 versus SGLT2, which is not my topic today. So let's look into Sustain 8 and Pioneer 2. So what happened in Sustain 8 trial? Semaglutide highest dose 1 milligram injectable once weekly was compared to Cana 300 milligram daily, 394 patients in each arm, double-blind randomized controlled trial. Injectable semaglutide outrightly beats canagliflozin 300 milligram, not only in HbA1c, but also by 1 kg in body weight reduction. So that was the first evidence, head-to-head evidence, suggesting that injectable semaglutide rules the roost when it comes to glucose and body weight reduction. As you all know, the injectable semaglutide has been given approval as an anti-obesity drug. That is absolutely a different GLP-1 agonist. However, what was surprising even in Sustain 8 trial, which people noticed, to forget to notice, that the blood pressure reduction was significantly higher with Cana 300 milligram. It outrightly beats GLP-1 injectable semaglutide on BP reduction. It not only in systolic, but also on diastolic blood pressure reduction. What is more important is to note that there are many fold higher percentage of people who discontinued semaglutide. You can see twofold higher compared to Cana 300 milligram because of all adverse event. And of course, GLP-1 receptor agonist increases heart rate. So there was mean 3.3 beats, per minute heart rate was significantly higher with semaglutide compared to canagliflozin. The second trial is Pioneer 2 trial. It was compared between oral semaglutide in both highest permissible dose, 14 milligram sema versus IMPA 25 milligram head-on. In this trial, oral semaglutide was found to be superior in HbA1c lowering by 0.4% HbA1c, additional lowering. But there was no difference on your right-hand side in body weight between oral semaglutide and IMPA 25 milligram. Again, the caveat lies that almost twofold, 2.5-fold people stopped taking oral semaglutide because of different side effects. You can see the drug discontinuation rate was quite high with oral semaglutide compared to empagliflozin. But here empagliflozin didn't show any difference in blood pressure lowering. And as expected, heart rate was pretty high with oral semaglutide compared to the empagliflozin. Remember, we don't have any head-to-head trial between canagliflozin 300 milligram versus oral semaglutide. I think that would be the best trial to conduct in future to understand how Cana 300 is doing with oral semaglutide. The biggest drawback with GLP-1 is the adherence, as I've shown you in both the head-to-head trial. Even prior to the oral semaglutide trial, there was enough evidence that suggested people who started with any GLP-1 actually did not continue compared to canagliflozin. And this is a very recent paper came in BMJ, nearly 3,000 patients given on any GLP-1 versus canagliflozin 100 milligram. You can see over 1 year period of time, Cana 300 milligram was as good as or significantly better when it comes to HbA1c compared to GLP-1. The reason do not being that the GLP-1 reduces HbA1c lesser than the SGLT2, just because of poor compliance, people left taking. This is data from USA database. So simply suggesting that people left taking a GLP-1 receptor agonist because of increase. So ladies and gentlemen, to conclude my presentation on how to reduce diabetes, it is very important that the current anti-diabetes drug should not only lower HbA1c, but should have the ability to reduce body weight as well. Both parameters are very important when you tackle a diabetes. Remember, if you compare the cardiovascular outcome trial, which I did not discuss here in detail, between SGLT2 and GLP-1, both the class of drug has shown a significant ability in reducing the 3-point MACE. However, the heart failure reduction lies exclusively with SGLT2 compared to GLP-1. Secondly, the renal benefit also exclusively with the SGLT2 compared to GLP-1. So when I have to conclude, taking into account kidney, heart, as well as diabetes, it should not be unfair to conclude that if you compare all the anti-diabetic drug and if you compare the oral segment in particular, because the unpopularity of GLP-1 is injectable more, and the semaglutide perhaps will solve those issues with GLP-1. But if you look back into the data amongst all the oral anti-diabetic drugs, perhaps canagliflozin 300 milligram and semaglutide 14 milligram oral seems to have greatest effect on HbA1c and body weight. Because we don't have any head-to-head trial, I can't conclude here that Cana is better than oral semaglutide or vice versa. But then still I would recommend, because oral semaglutide has not passed any CV outcome trial and has not shown any cardiovascular and renal benefit at the moment, in contrast to in the Canvas program, also in the Credence trial, I would still give Cana 300 milligram a little edge over oral semaglutide 14 milligram in reducing diabetes. Thank you very much for your patience listening.
Thank you, Dr. Avdesh Singh, for a very wonderful lecture on the similarities and dissimilarities between the various SGLT2 inhibitor molecules and their very astute comparison with the GLP-1 receptor analogs. I think we will be addressing the questions at the end of the entire session.
Dr. Sengupta, sorry to, I have to, so if any question, I will quickly take it through. I have to leave for some other engagement. If
okay.
Any, I would be happy to quickly finish it. I won't disturb Krishna and Manoj later on.
Okay, so if there's any question.
Can I ask a quick question to AK before he leaves?
Sure.
Yeah, please.
AK, correct me if I'm wrong. In the original data for, in the phase 3 data for canagliflozin before the launch, there was a certain small Indian subgroup. Somehow at that point in time, the 300 milligram data was not very encouraging in the Indian subjects. Correct me if I'm wrong. And then the later on studies have not shown the same. This was only in that initial one. Any thoughts on that?
Yeah, so right. So I agree with you to that extent, but this is that was a subgroup analysis. Then there were a big trial conducted by Professor Prasanna Kumar, and Cana 300 milligram was, surprisingly, it was associated with lesser side effect even compared to Cana 100 milligram. Matthew John also did one study of Cana 300 milligram and compared with Cana 100 milligram, and he also shown the side effect profile of Cana 300 milligram was surprisingly, despite that it is much more stronger, lower than Cana 100 milligram. So now we have good, in fact, I had a slide, but I have omitted just because of paucity of time, because that is important to show people that Cana 300 milligram don't have any additional side effect compared to other SGLT2 or compared to Cana 100 milligram. But you are correct, there were initial data, but that was a subgroup analysis in a very small number of people.
Thank you.
I just had a small query to ask Dr. Singh, sir. If you are considering diabetes as one of the factors, along with the other comorbidities, what makes you choose one SGLT2 inhibitor over the other in the optimum dosages?
Well, so Dr. Sengupta, as I have shown you, Cana 300 milligram is a little different species amongst all SGLT2 because of very simple mechanism that this is the only SGLT2 right now available to us, because even sotagliflozin is not approved in the United States yet. So still across the world, the Cana is the only 300 milligram is the only SGLT2 at the moment which is approved, which has got additional SGLT1 blocking. So there is a landmark shift in thinking about whether we need a specific SGLT2 receptor blocker or we need a non-specific SGLT2 receptor blocker. We learned through the Mendelian inheritance study. Remember, people complained that if you are a non-specific SGLT2 inhibitor, chance of adverse cardiovascular event is likely to be high. However, the genetic study just suggested just opposite finding. Remember, in the sotagliflozin SCORE trial, that is the only SGLT2 inhibitor that shown a significant reduction in MI and also in a stroke, as in contrast to what we saw in IMPAREG outcome trial, where there was some signal, although it wasn't a statistically significant increase in a stroke. So now we are learning that if you have got the ability to block SGLT1, perhaps you can reduce atherosclerotic cardiovascular event significantly, in particular a stroke and MI, what we saw in the SCORE trial with sotagliflozin. And I would like to remind you, even in the CANVAS trial, if you look the stroke reduction, it was 10%, but it wasn't statistically significant. So a suggestion that a non-specific SGLT2 blocker may have a better ability to protect us from the atherosclerotic cardiovascular disease. So there is a landmark shift in thinking in last 10 years since Cana was first approved by US FDA in 2012, that SGLT1 blocking ability of SGLT2 blocker could have not only a better potential of HbA1c lowering, but it could be associated with atherosclerotic cardiovascular event.
Any comments or questions from the panel?
One quick question, Dr. A.K. Singh.
Yes,
as DAPA-HF sub-analysis showed prevention of new onset diabetes in people having pre-diabetes. So would you recommend these molecules to obese people who are having pre-diabetes?
Well, so that's very provocative question. I absolutely agree that this was the first evidence generated so far with SGLT2 that this is another class of drug. If you go back, look into metformin, pioglitazone, etc., has got a preventive ability that it can reduce diabetes progression from impaired glucose tolerance to frank diabetes. So the DAPA heart failure for the first time shown that dapagliflozin reduced 28% chance of developing a frank diabetes from pre-diabetes. But then that was not the primary outcome of the trial. We need to have a kind of trial as we did with metformin DPP, as we did with pioglitazone ACT now, or many other trials with early STAT, Gendos trial, and various other trials. So this is not a moment to recommend SGLT2 for diabetes prevention. We need to generate more data before claiming anything. But that's a good positive first evidence that suggests SGLT2 inhibitor may have the ability to prevent that.
Thank you.
Any more questions from the panel or
So one more question. So now from an anti-hyperglycemic agent to cardiorenal drugs, the SGLT2 has progressed. So where do you see as an anti-obesity drug? Do you see it or no?
Well, so remember, anti-obesity drug to be claimed, you need to have a certain specified criteria given by FDA. And a SGLT2 inhibitor as a class, they have not opted for becoming an anti-obesity drug, unlike GLP-1, because in this case, for SGLT2, you don't have an opportunity to increase further because you won't get any. See, the mechanism of SGLT2 is pretty clear, that it blocks SGLT2 in the kidney and therefore it reduces glucose reabsorption. And even if you increase the dose of any SGLT2 inhibitor, you won't further do anything. So the mechanism of body weight lowering of SGLT2 is very straightforward. Whereas for GLP-1, it is little complex and exactly we don't know. There are variety of mechanism by which GLP-1 receptor agonist reduces obesity. And therefore, the GLP-1 class has underwent a number of drugs. They can increase the dose and go ahead to look whether they reduces body weight. And that's the reason semaglutide, as you all know, in 2.4 milligram has been recommended as an anti-obesity drug. Liraglutide, Saxenda 3 milligram is already approved anti-obesity drug. So the GLP-1 class has got pharmacokinetic ability to conduct such kind of trial and to claim as an anti-obesity drug. I don't think even in future the GLT2 will claim as an anti-obesity drug. But surprisingly, despite doing everything good, the GLT2 is quite competing with GLP-1, as I have shown you in all head-to-head trial. In fact, in duration 8 trial, dapagliflozin shown numerically better body weight reduction than exenatide once weekly. But exenatide once weekly is little, weaker drug in body weight reduction compared to semaglutide, and therefore the dapagliflozin was found to be somehow having a better body weight reduction. So that's interesting.
Thank you, sir.
If there are no more questions, I think Dr. Singh may be allowed to leave.
Thank you so much. Thank you, everyone.
Thank you.
Thank you.
Thank you, sir.
So let me take this opportunity to thank Dr. Banshi Sabu and team for inviting us to chair this session. It's really been a privilege, and it's my honor to introduce the second speaker, again a very astute and very well regarded speaker in diabetes circles, Dr. Krishna Sheshadri. He's an American board certified endocrinology specialist in diabetes, metabolism and internal medicine, an MD consultant endocrinologist at the Chennai Diabetes and Endocrine Clinic, and research lead at the Apollo Sugar Clinic. Also a senior consultant at Apollo Hospitals, and is a visiting professor in endocrinology and medical education at the Sri Balaji Vidyapeeth, the recipient of the P.N. Shah Oration of the Endocrine Society, and the Professor Sam G.P. Moses Oration of the RSSDI, funded translational research, gut microbiota and inflammation, vitamin D and glucose transport, metabolic abnormalities in PCOS, thyroid nodules, and FOXO. These are some of his research topics and areas of interest. And he's presently the president of the Endocrine Society of Tamil Nadu and the associate editor of the JDDC. Also the editor-in-chief of Thyroid Research in Practice, member of the Reconciliation Board Medical Council of India, of the UG Expert Group, and very diverse interest in Chola history and Advaitic philosophy. So may I ask Dr. Krishna Sheshadri to please go ahead with his presentation on CRM risk modification and the present pandemic and what we can look at the other chronic infections. What is the present status? Dr. Sheshadri, sir.
Can you hear me now? And is my screen visible?
Yeah, your screen is on.
Can you hear me?
Yeah, you're very well audible.
Thank you, Dr. Sengupta. Thank you to Banshi, Arvind, Sanjay, and the rest of the team in Diabetes India for inviting me. It's a very interesting topic because we've always looked at it from the numbers. I thought I would take a look at it from some of the mechanisms that are involved and some interesting thoughts. So we may not have all the answers, but I hope at the end of it we can think a little about this in terms of diabetes in India and how the pandemic has probably given us some answers on what has happened. I will not talk about the new onset diabetes that Manoj is probably going to talk about in terms of the pancreas. So just for us to know that, remember the basis that we have, that about 2/3 of our patients have subclinical CV disease, about 1/3 patients with diabetes have known CV disease. The question is, as a pandemic accelerated, initially in the first few days, the first few months of the pandemic, there was something very interesting that people noticed, that that there were less number of acute myocardial infarction visits to the hospital, and less number of PTC has been performed. This was something that we all thought, oh wow, this is because we've all slowed down. But interestingly, what we've seen over a year, and a year is a long term in terms of research history, you find that some of the things have happened. Remember that Indians as a baseline have a higher incidence, have prevalence of CKD risk. And we already are a substrate for cardiovascular, renal, metabolic diseases. But what is also interesting is that the national health policy goal is to actually to ensure 25% reduction in premature CV deaths by the year 2025. And let's see what the pandemic is. One of the things that the pandemic has done, and this is from the Frontiers of Public Health that was published at the end of last year, is that patients with morbidities have a significant challenge that's happening in the pandemic. A 48% increase in the odds of significant challenge, especially with multiple morbidities. So while we keep talking about this and the access to care and telemedicine, what is really important to understand is what is happening under all of this. One is our already under investment, that our reserves are actually. There's an underinvestment in early diagnosis, there's an underinvestment in screening, recognizing of NCDs. Then what has happened is that these services have been stopped. Especially while we're all looking at the pandemic, what has happened, as somebody said, it's probably a twindemic, because while the pandemic is a threat, the consequences of the lockdown, the consequence of people being inside, has unlocked this potential for an exponent increase in NCDs. Right? So clearly what has happened is that the pandemic, far from giving people the time at home, the wonderful things that we talked about discovering our families, at some point of time has disrupted life. No longer do you see people saying how wonderful it is to be home. They're waiting to get back. Work from home that was considered to be wonderful is no longer considered wonderful for most people, because we are not used to being with our spouses for 23 hours a day. Isn't it? We have people. There was a time when the Instagram was full of people who were putting up all the new stuff that they cook. Don't see that so much, isn't it? Because life gives you a licking. This is an Italian study, a small study, but it is sort of gives you a dip into what has happened before and after the lockdown. These are the features of the metabolic syndrome. This is the presence of dyslipidemia. This is the presence of IGT and DM, mild increase, but can you see what's happening here? Hypertension, not so much, but see what's happening. The forerunner of diabetes is obesity. And in this particular small cohort, there was the presence of obesity was around 40%, which jumped up to 60%. So what do we have as a new disease? That's called sedentarism. So many of our people, remember, the doctors at least get up, but even we have moved to in front of a screen. Several things that have happened. One is a poor muscle activity and reduced energy expenditure. That has led to reduced motor perfusion, dysglycemia. I've talked about inflammation so many times. Ectopic lipid accumulation. Then the liver is storing more fat, more triglycerides. In addition, there is some renal issues because of poor renal function. But ultimately, sedentarism is going to be remember that we keep talking about it even before the pandemic, that sitting is a new standard, is a new smoking. And of course, back in neck pain, obesity, the most important, of course, is the long-term effects of cerebrovascular disease and coronary disease and renal disease. This is a older study, but it sort of tells you what is happening. When you're inactive, this is CHD deaths. And this is estimated increase in, and this is CHD deaths, and this is C80. And can you see what is happening? The more and more inactive we are, the more and more we are sitting. This is the amount of increase in deaths that's going to occur. So if you look at this per person, let's say if 60% of the population is inactive, this is what you're going to expect another 0.2 million people. The third thing that is, so one is sedentarism. The second thing is that if you talk to most of your patients, they are either anxious or there is some problem with sleep. One, people sleep later, and those who sleep later also sleep longer. The sleep is also disrupted. There is difficulty in initiation of sleep. And interestingly, what that has also led to is an epidemic of spending more and more time in social. And this is again a European study that looked at what has happened. This is in Sweden. And I can tell you, this is probably even more exaggerated in our case, that during the lockdown, that sleep has been disrupted. Those of you who've listened to me in the past, and my interest is sleep because I love to sleep. The second thing is also my work is on sleep and circadian rhythms. And I can tell you that we did a very interesting experiment last year. It was accepted in the ADA, and all we did was to put Fisher rats through a sleep cycle that was similar to nurses. And the changes in the pancreas and especially in the beta cells were need to be seen to be believed, and maybe we can talk about it another day. But clearly, the sleep disturbances is, and of course the anxiety is adding to this. And this is another study that is published again from Italy. And what is interesting is, again, looking at the post-lockdown, and they actually looked at something very interesting. They did a wellness score, right? If someone was feeling well at the end of the lockdown and that their overall wellness is not affected, their A1C was fine, and their weight also didn't. On the other hand, if they did not perceive wellness, the perceived wellness score. So if they did not perceive wellness, their A1C went up, and also their weight. So clearly, what the pandemic has done is it has unleashed a cardiorenal metabolism. I've seen some small studies that have looked at the baseline inflammation increasing before and after the lockdown, but these are too preliminary. Now, so I talked about sedentarism and the gain in weight and the A1C. I talked about sleep. The third thing, and especially important for Indians, is this particular bit, and I can tell you that this is affecting our elderly a lot, and that is sarcopenia. So we do, as we are sedentary, we don't use our muscles. And at the most, our elderly take a walk. Many of us do not do resistance training. And I can tell you how evident it is. I'm someone who actually does resistance training, and while I do have a tummy, my muscles are not bad. And I went through a small illness, a non-COVID illness, for a couple of weeks, and I was forbidden from exercising or eating by my spouse, who also thought it was a good idea for her to learn all the other cooking that she has not done in 22 years and feed me. Which was nice. I enjoyed it. But I can tell you that my muscle mass, I feel it has already come down. So as soon as I finish this, I'm going to hit the gym. But what is important to understand is, can you imagine that these are people who already have sarcopenia, and each acute illness or extended bed rest leads to a further down. Now, what is going to happen if somebody is actually not exercising, not using their muscles, sitting in front of a television or a thing for a year or more, and many of them are afraid to come? And you see what happens. Interestingly, remember what happens to, let's say, a pre-diabetic patient. Also, there is some work on ATP by Srikumaran Nair from Mayo, but I thought this was interesting. This was an Indian group, so we don't have comparison with the Western population. But what it shows is, even the muscle mass is the same, the muscle strength is completely down in these people. And I can imagine, and there are IR studies that show that the insulin resistance also goes up. Of course, can some of our one of the interesting questions that we need to ask is, do our drugs work for sarcopenia? The DPP-4 inhibitors seem to improve sarcopenia, and there is data with the SGLT2 inhibitors that also show that it decreases fat without decreasing the muscle. So to sort of summarize, we have people who, and then I'll move on to SGLT2 for a short period of time. We have people who are increased, who are alone, who have decreased activity, decreased step count, increased sitting time, stress, anxiety, decreased sleep quality. I didn't go into the eating bit. I think people are, the good part of the eating bit is that processed food has come down simply because people are cooking at home, except for those who are living alone and are dependent on Swiggy and Zomato. But for most people, this has come down, but snacking is increased and mealtime is increased. This is something quite different in India. Again, vitamin D is decreased, insulin sensitivity is decreased, and because of vitamin D, mTOR is gone, oxidative stress is increased, probably inflammation. So there is a loss of muscle mass and function, there's sarcopenia, and there is sarcopenic obesity. Long term, if this isn't taken care of post-lockdown, cardiovascular disease, osteoporosis, cognitive decline, frailty, and risk of. So this is empagliflozin, and any SGLT2 inhibitor can do all of this. It decreases visceral adiposity, it can decrease chronic inflammation. I won't spend time on two of this, but couple of things matter. One is the SGLT2 inhibitors are probably more efficacious in patients with type 2 diabetes and probably safer, so they can be used in the past. May have a lower risk of hypoglycemia than sulfonylureas. Interestingly, reduces waist circumferences, and as I said, it does not reduce the muscle mass. Remember that when you lose weight, 50% of up to 50% of the loss is muscle mass, except for the SGLT2 inhibitors. This is something very interesting. Also, there seems to be some improvement in inflammation and reduction in OMA-IR. Reduces adipose, and some very interesting data. This was published in 2018 that there is actually an increase in empagliflozin and a normalization of the K1C, but also some interesting information about NASH. In the pandemic, with sedentarism and with all the other things that I talked about, the gliflozins and the gliptins seem to be very, very good fits. Not that you shouldn't use any. It also sort of reduces the risk of obstructive sleep apnea as a post-hoc from the EMPA-REG outcome and helps you with the systolic blood pressure. And importantly, when a gliflozin is added, there's an early separation of curves. And especially in the Asian patient, then there seems to be a decreased risk of CV death. So at least remember that this the EMPA-REG was in patients with established CVD, not with those who trying. So if you look at 100 patients with CAD and type 2 diabetes, you have 3.4 years of total life gain, 9.8 CV events prevented, CKD is reduced, insulin requirement is reduced, hypertension is reduced, but interestingly, new OSA events are good. Are SGLT2 inhibitors safe in COVID? I think the most important information we have is the DARE trial, where they actually used it in COVID-19 patients. Remember that this was while it looks like the curves are separated, the hazard ratio is 0.8 to 1.1, which means at least we know that it's not harmful in patients with established COVID-19. So in patients with increased risk of COVID-19 or those who are on lockdown, I think these are fairly safe to start. In addition, this is looking at the mortality, and this is looking at the CKD events, and all of those were also non-inferior. The study was underpowered, but it's interesting to know that these are safe, and this was a RCT. So clearly, these drugs are fairly useful in patients with COVID-19. So to sort of summarize, I want you to say that the epidemic of pandemic, the pandemic of COVID-19, has exposed a soft underbelly of metabolic syndrome and diabetes, and our care, despite telemedicine and all the things that we do. What we know is that sedentarism, decreased sleep, sarcopenia, and of course, I want to add here the anxiety and the the overall reduction in perception of wellness will contribute to an uptick in both obesity and in all three, obesity, diabetes, and cardiorenal outcomes. It's time we take a look at it. And when the pandemic's over, strengthen our mechanisms to help patients achieve the lifestyle they want. Drugs like SGLT2 inhibitors, as pointed out in this particular, are useful. But it's also important to remember that the overall care of the patient is probably even more important. Thank you for your patience. I hope this was what you wanted. And I hope that there was a couple of new things that you learned today, or at least a few more questions that you can go home and think about. Because that's all, after all, that's what a talk is supposed to be.
It didn't offer what it promised. I thought you were trying to put us to sleep, Krishna. It definitely didn't.
I think he will never. His all lectures are always very interesting. And thank you, sir, for presenting an interesting data on current pandemic situations and the role of SGLT2 inhibitors. Questions from the panel or anyone?
You want me to wait for Manoj or take questions now, Manoj?
Yeah, we'll do it in the end.
I'm okay.
I'll be around. I actually wasn't even sure about my network today, so I've actually recorded and given it, and they will play it, but I'm around here for the questions.
Okay, so I will wait for, and Manoj and I together can take questions. Manoj.
Thank you, sir. So now we have our next speaker, Dr. Manoj Chawla, and Manoj is a very good friend. So I will start with that. And he is a director and consultant diabetologist at Lina Diabetes Care. And he is a consultant at Asian Heart Institute and Raheja Fortis Hospital, founder president of United Diabetes Forum, and honorary visiting faculty at D.Y. Patil Medical College. He was awarded RSSDI Fellowship for the year 2017 and Fellowship of Royal College of Physicians in 2019. He is PI for various global MNC trials and devices. Welcome, Manoj, for your talk on conundrum of CRM risk in diabetes.
Thank you, welcome.
Good afternoon, everyone. The outset, let me thank Dr. Bansi Sabu, Dr. Arvind Sosale, and the entire team of Diabetes India for inviting me to speak at this Congress. It's always a pleasure to be with friends and with Diabetes India. The topic that I'm speaking on is the conundrum of cardiorenal metabolic risk in new onset patients with type 2 diabetes, the ticking clock hypothesis making us all aware that every patient with type 2 diabetes right from the beginning is actually a potential cardiac patient or has potential cardiac, renal, and metabolic complications. Now, we go back to the basics to understand the difference between the thin fat Indian phenotype and as compared to the Caucasian population. Now, clearly, our individual, as beautifully shown here, even though the lean mass, as we can see, is much lesser than the Caucasian counterpart, if you look at the fat mass that we have as part of our visceral adipose tissue, is no different. So we may be thin, but we are actually viscerally fat, and that's what makes us more prone for all the metabolic risk, just like any of the other Western counterparts. We look at the natural history of type 2 diabetes to understand the entire pathophysiology of how things start. The fact that your insulin resistance is something which is gradually increasing, and the process starts a few years before onset of clinical diabetes. This, of course, is then related to the failing beta cells, which then leads to the rise in the impaired fasting and the impaired postprandial sugars. So there is always this rise in the period of impaired glucose tolerance, where you have the postprandial sugars on the rise. You have insulin resistance always on the rise, and this persists through the life of a person with diabetes. And then, as we clearly see here, in terms of the beta cell, you have the increased secretion initially, and then the failing secretion. All of this, of course, is related to the rise in postprandial sugars first, then rise in fasting sugar, connected with worsening endogenous insulin production. The important aspect here is to remember that the onset of macrovascular risk is seen even in early dysglycemia. There are enough studies and evidence which have showed that patients with impaired glucose tolerance will have a higher macrovascular risk possibility as compared to the normal glucose tolerant individuals. We also look at some more evidence for the same. This is the common soil hypothesis for cardiometabolic risk, again, from the Nurses' Health study, which looked at the risk for cardiovascular events. And they showed that when you talk about the increasing risk for MI or stroke, which of course are the macrovascular complications, and the individuals with their diabetes status in the Nurses' Health study, so those who remained non-diabetic throughout the study, and you compare them to those who had diabetes prior to diagnosis, you see a higher relative risk. For those who we're talking about after diagnosis of diabetic or even diabetic at baseline, there is a gradual increase in the risk of their possibility of landing up with an MI or stroke. Similar way, you look at the increasing risk for MI or stroke by time before onset of diabetes, and you'll be able to appreciate that when we compare to somebody who's non-diabetic throughout the study, and then you compare with the amount of years before diagnosis of diabetes, so this is 15 years or more before diagnosis, gradually the relative risk increasing in the population who had less than 10 years before the diagnosis of diabetes. So again, clearly telling us that in the Nurses' Health study, all those depending on their early diabetes or those even before clinical onset of diabetes, but then landing up with diabetes in the study had higher incidence of cardiovascular risk. So the whole process of linking diabetes to cardiac risk is actually starting much before the onset of clinical diabetes. You also look at the connect with CKD. Now, this has been a well-accepted secondary analysis from the Eye Care Diabetes Survey, which is telling us that your stage of CKD doesn't only depend on the eGFR category, but also on the albuminuria categories, which allows us to very clearly classify our patients as to their CKD risk. Now, in this study, they found that amongst the percentage of patients being surveyed in the regular clinic studies, you find that almost 41% patients have already low risk possibility of chronic kidney disease, moderately increased risk in another 36%, high risk in 13%, and very high risk in 8.7%. So again, driving home the point that patients, even in their early life of type 2 diabetes, already have some renal background or renal disease risk with them right from the beginning. So what does good metabolic control mean for patients with new onset type 2 diabetes? Well, we look at the effect of various glucose lowering therapies to see their impact on cardiometabolic risk factors. And you look at the SGLT2 inhibitors, and you will see, like metformin, there is reduction in glycemia, which something is being caused by all the drugs. Low risk of hypoglycemia, well, sulfonylureas are the ones which stand out in increasing the risk there. The other drugs would be safer. But reduction in visceral adiposity, well, you get this with SGLT2 inhibitors and largely with GLP-1 receptor analogs. Reduction in blood pressure is another added pleiotropic benefits is seen in the SGLT2 class, to some extent in GLPs, and maybe with pioglitazone as well. And then you have the impact on other pleiotropic benefits, which we shall be highlighting on. Also, when you look at the glycemic efficacy, important to remember that the efficacy in terms of HbA1c reduction of a drug should always be compared depending on their baseline A1c. Now, when you compare empagliflozin as an SGLT2 inhibitor to sitagliptin as a DPP4, and you look at the baseline HbA1c of 8, you see numerically higher reduction of HbA1c in the empagliflozin group. But as the HbA1c starts rising, this difference gets more and more prominent, driving home the point that your efficacy in terms of A1C reduction is far better for empagliflozin as compared to DPP4 inhibitors like sitagliptin. We move on to look at the benefits of other pleiotropic benefits and benefits on comorbid conditions, what recently I have started calling as collateral benefits. We've always highlighted collateral damage as a term, but let's understand that SGLT2 inhibitors like empagliflozin are actually showing great amount of collateral benefits. So you look at the benefits on visceral obesity. Waist circumference is now soon being regarded as the 5th or 6th vital sign and is extremely important. And we look at the data for empagliflozin, both the strengths 10 and 25 milligram as compared to placebo, and see the reduction in the visceral obesity or the waist circumference. We also look at the evidence for adipose tissue inflammation reduction with empagliflozin as compared to sitagliptin. This is a randomized clinical trial in 106 patients with type 2 diabetes who were uncontrolled on metformin monotherapy. You have addition of empagliflozin 25 milligram or sitagliptin 100 milligram, a study over a 24-week period. And then we see in terms of HbA1c level, you get almost similar reduction in both these groups on the background of metformin. You start looking at serum adiponectin. And we clearly see the stark difference here, a clinically significant difference in favor of empagliflozin with increase in serum adiponectin, which we know today is extremely favorable for reducing insulin resistance as well. You look at the evidence of empagliflozin non-alcoholic steatohepatitis. Well, everyone today is talking about the importance of fatty liver, NASH, NAFLD. But how do we really change that? We know that not too many drugs have shown evidence, some for vitamin E, some for pioglitazone. But again, very, very sketchy evidence there. Again, very happy to see the impact of empagliflozin in this condition. Possible histological improvement in NASH at 6 months in patients with type 2 diabetes. And you see that as compared to placebo, when you are comparing improvement, whether it's in steatosis or lobular inflammation or hepatocellular ballooning, NASH resolution, all these histological appearances for patients with NAFLD, you see much improvement in the EMPA group as compared to placebo. We move on to see some more evidence for empagliflozin, and this is one of the sub-analysis from the EMPA-REG outcome study. You're talking about between the two groups in the EMPA-REG study, the amount of new initiation of insulin. And again, in favor of the group on empagliflozin, you see a 54% risk reduction in terms of lesser requirement or initiation of insulin. You also look at another insulin parameter, which is significant increase in dose, which would be considered as more than 20% increase in dose on existing insulin users. Again, when you compare both the groups, you see a 57% relative risk reduction in favor of the empagliflozin group as compared to patients on placebo. So SGLT2 inhibition is not really recommended for delaying insulin, but where in therapies that patients are given SGLT2, we are seeing that the requirement for another new drug, especially insulin, does get delayed because of the glycemic and other benefits. You also look at the benefit in patients with obstructive sleep apnea. Again, an extremely common comorbid condition in our patients with type 2 diabetes. And here, again, we see that for patients on empagliflozin, you see much better results. You see almost a 52% relative risk reduction in new onset obstructive sleep apnea in patients on empagliflozin as compared to placebo. So you're seeing all these benefits which go beyond just glycemic benefits. You're seeing for visceral adipose fat reduction, increase in adiponectin, improvement in new chance of obstructive sleep apnea, improvement in chances of avoidance of new onset insulin, and so on. So how early should this organ protection be considered in patients with early onset diabetes? Well, we need to remember that empagliflozin has proven CV safety regardless of the cardiovascular disease status in type 2. We are all aware of the EMPA-REG data, which had almost 99% patients with established cardiac disease. But when you look at the meta-analysis of phase 3 studies of empagliflozin, and as we see here, that in these trials, the patients with coronary artery disease or peripheral artery disease or cerebral vascular disease background was a small percentage of patients. So in these patients who did not have established cardiovascular disease, when you start again comparing the data for the 4-point MACE or the 3-point MACE or the composite of cardiovascular death and hospitalization for heart failure, you again see statistically significant results in favor of empagliflozin as compared to placebo. So all these benefits in terms of cardiovascular protection and even cardiovascular death and hospitalization for heart failure can be seen even in patients with early diabetes without established cardiovascular disease. You look at, again, the data from EMPA-REG for systolic goal, systolic blood pressure. So empagliflozin improved the achievement of systolic blood pressure as compared to placebo in the empagliflozin group. This is, of course, on top of all the existing therapies which were there in these patients. Empagliflozin used for 12 weeks improved the odds of achieving systolic blood pressure goal of less than 130 millimeters per mercury by almost 69%. So we know that's an important parameter that we need our patients to be under target blood pressure control, and empagliflozin doing the same for us. What about renal protection? What about patients where there is already pre-existing prior albuminuria? So we are looking at data for both these aspects from the EMPA-REG study again. So new onset normoalbuminuria in patients with prior microalbuminuria. So recession of this microalbuminuria, getting them back into the normoalbuminuria group, 43% increased likelihood in patients on empagliflozin. New onset normo or micro in patients with macroalbuminuria. So again, a regression from macroalbuminuria, either becoming just micro or becoming absolutely normo. Again, in the empagliflozin group, you're seeing 82% increased likelihood, clearly driving home the point that this drug is offering us great renoprotective benefits, and not too many drugs in the past have offered us that. We've been very often stuck with just the use of ACE, ARBs, and really what beyond that. We look at more data in patients with type 2 diabetes and atherosclerotic cardiovascular disease. Empagliflozin conferred early and sustained decrease in risk of cardiovascular death. This, of course, is the original data from EMPA-REG. Overall study population, we know that there was a 38% relative risk reduction for cardiovascular death, which is why empagliflozin today is the drug that it is and accepted so well globally. We look at the Asian patient subgroup, and here we in fact see this to be further magnified, and a 56% relative risk reduction in cardiovascular death in patients on empagliflozin as compared to placebo. And today, of course, there is more and more evidence that drugs like SGLT2 inhibitors are actually working much better in the Asians and the Asian phenotype and genotype as compared to the white population. Empagliflozin consistently reduced the risk of CV death in patients with diabetes and ASCVD with or without heart failure. So when you look at patients, irrespective of their heart failure status, you're still seeing the benefit of cardiovascular disease or reduction of cardiovascular death, irrespective of their heart failure status. So this is without heart failure. And then you look at patients with heart failure burden, and you'll still see the benefit in favor of empagliflozin in terms of reduction in the cardiovascular death outcome. What's important to note that when this post-hoc analysis of EMPA-REG was presented at the ADA 2020, which was last year by Subodh Verma and group, they were clearly able to show the separation of lines happening as early as day 27. And if you're able to appreciate here, this is the line of unity, and it becomes significant in terms of the 95% confidence interval ranging to less than unity. This separation in favor of empagliflozin for cardiovascular death or hospitalization for heart failure outcome happening as early as day 27 of its usage. So imagine that you're using this drug, and after the first month itself of its usage, you're seeing the benefit in reduction of cardiovascular death and hospitalization for heart failure. Why wouldn't we want to give this drug to our patients right in the beginning? We also look at the data analysis from EMPA-REG, which is talking about reducing the risk of first and recurrent CV events. So when you again have a closer look at this data, it showed us that there was a 21% decrease in the risk of MI events with empagliflozin versus placebo. And this takes into account both whether the first event or recurrent events, but benefits again in favor of empagliflozin. So if you analyze all of this data and put that into perspective, 100 patients with coronary artery disease and type 2 diabetes treated with empagliflozin in 3 years, what really are the benefits we are getting? Well, 8.5 reduction in CKD events, 3.4 reduction in acute kidney injury or acute renal failure, 12.9 insulin requirements prevented, 5.1 additional patients reaching the systolic blood pressure goals, 5.5 reduction in edema, cardiac failure or new OSA, 3.4 additional life years gained. I think that's extremely important, and 9.8% reduction in the cardiovascular events. Well, what's also important to remember that when we talk about cardiovascular death reduction, there have been certain meta-analyses which get put up in terms of the various cardiovascular outcome trials for SGLT2 inhibitors. One may question these kind of meta-analyses, but even if you look closely in the meta-analysis and you see here that it gives you the overall benefit of cardiovascular death reduction if you see the data. But this entire data for all these CVOTs is largely driven by one single one, which is EMPA-REG outcome trial. So empagliflozin is the driver here for the cardiovascular death reduction. And if you see again in patients without ASCVD, you see no difference between any of these drugs. So in patients with type 2 diabetes and atherosclerotic CVD, well, you look at, if you again want to compare all these different trials, I'll just drive home again the point what we really saw in EMPA-REG. MACE, 14% risk reduction, cardiovascular death, which is the strongest hard endpoint, 38% risk reduction, which could not be seen in any of the other CVOTs. All-cause mortality, again, 32% risk reduction, not seen to be significant in other ones. Hospitalization for heart failure, probably more of a class effect. And chronic kidney disease improvement, again, probably more of a class effect. But all-cause mortality and CV that purely seen with empagliflozin. You also look at some of the real-world data, and from the EMPRISE study, which has been well accepted as a real-world data, you look for hospitalization for heart failure and all-cause mortality, and you again see a 41% risk reduction in hospitalization for heart failure, 48% risk reduction for all-cause mortality. This is a real-world data for the kidney events from the Scandinavian real-world evidence, again showing that in terms of new users of SGLT2 or DPP4s, you are seeing significant reduction in the renal outcomes or renal endpoints for SGLT2 inhibitors. So not only the cardiac and renal benefits are seen in RCTs, but well replicated even in the real-world studies. You look at the prescription of glucose-lowering therapies in the COVID-19 period, and this is important in the current times. So in the context of the pandemic, there is no clear indication to change your prescribing drugs. But when you see in terms of mortality of patients on the background drugs, you see great results in favor again of metformin and SGLT2 inhibitors, again saying that probably the use of these drugs may be offering some protection, but too early to say about that. Let's never forget the sick day rules for diabetes during illness. So if you have your patients who are on different drugs, you may want to follow the sick day rules, especially on patients on SGLT2 inhibitors. Be cautious of dehydration. If somebody is extremely dehydrated, hospitalized in a critical state, you may want to stop this drug to prevent dehydration and onset of ketosis. The ADA standards of care, of course, today have evolved in the 2021 to talk about the need to look at comorbid conditions earlier. If your patients have comorbid conditions like heart failure or CKD or ASCVD, your choice of SGLT2 inhibitors is right up there. With somebody with ASCVD, you may want to give them a GLP-1. A lot of our patients may not be able to afford or tolerate GLP-1 therapies, and SGLT2 then becomes the natural choice as all the evidence points towards the same. Also important to remember that when we talk about the benefits in terms of the guidance, let's also remember where to be cautious.
Can I ask RX to stop here the presentation as there's some repetition? Thank you. Right. I realize there's some repetition in slides, and I think I have conveyed the message that I wanted to. We can have just a couple of minutes back to the chairpersons for any discussion that.
Yeah, thanks, Manoj, for a very wonderful lecture. Just wanted to check, I mean, empagliflozin did not really show the same results in the Emperor reduced, as we know. Your comments?
Different population, yes, that we have in these trials. So Emperor reduced was in terms of your population there was heart failure patients with reduced ejection fraction. What we saw in EMPA-REG in terms of reduction of cardiovascular death data was seen in patients with almost 99% patients with pre-existing cardiovascular disease. This was a different population. It showed the benefits, but yes, I agree that the statistically significant data for cardiovascular death was not as appreciable as what could be seen in EMPA-REG. But I think largely that would depend on the population which is included, and that's what probably is the reason for the difference in the outcomes that you see in different CVOTs.
Also, possibly the introduction of the newer, drugs for heart failure, etc., might have compounded the results somewhat.
Somewhat. I don't think there was a very large proportion of patients with the background of sacubitril valsartan in the trial. Somebody can correct me if I'm wrong here. I don't think that was a very significant reason.
Manoj, can I just say something?
Yeah.
Yeah. So I think the alpha for the Emperor reduced and the Emperor preserved. The sponsors actually decided to have a joint alpha. So what they are looking at is both the trials put together and then showing a statistically significant reduction in cardiovascular death. So they were not, if you look at the primary endpoints, it was not one of the primary endpoints, and that's why it didn't reach statistical significance. But this is to be taken, both the drugs have to be, both the trials have to be taken in conjunction. It's actually mentioned in the paper also.
Thanks for that. Yeah.
Sorry about that.
No. Thanks for clarifying that, Vinayak.
One more question. I mean, in the setting of the COVID-19 pandemic, we have seen patients obviously who have been had to put on, non-invasive and invasive ventilation. One of the first drugs which have been withdrawn is metformin. So do you think, I mean, initially continuing with metformin, despite its benefits in medicine in diabetes, one should try and basically withdraw and continue with something which is considered more safe rather than, looking into the myopathy point of view, etc.?
I think the principles don't really change, Dr. Sengupta, and I'll let Dr. Krishna also answer that. But basically, if your patient is critical, there are going to be issues about oral intake, ventilation. There's no doubt that you're going to stop all orals and shift these patients to insulin. So I think the data that a lot of data which came out in the last year was just trying to show on background medication. There was some data that you continue metformin also during the hospitalization phase. But today, continuing metformin and SGLT2 is fine as long as the patient is not critical, is kept in the hospital for monitoring, maybe some oxygen, but is able to have good oral intake. I think there are no issues. But otherwise, as you rightly said, we will have to stop these drugs and do standard critical care practices. Dr. Krishna, if he wants to add.
No, I think if
Absolutely.
someone is sick enough to get into the hospital, you're sick enough to stop metformin and most oral agents. The only exception is probably a DPP-4 inhibitor, which probably has in-hospital safety, but again, not critical care safety. So I would be very careful about leaving any of these drugs on. The DARE study was interesting, but I think it was underpowered. And at this point of time, all it says is there is no excessive mortality, but there is no reason for us to continue it. I would stick with the FDA recommendations of stopping it before and then starting after.
Thanks, Manoj and Dr. Krishna. Any comments or questions from the panelists, please?
So one last question to both of you, Dr. Krishna and Dr. Manoj. Do you feel that in near future we will have a EGFR cutoff revision as far as SGLT2 inhibitor use in CKD is concerned? Currently it is up to 30. Do you think it go up to 15 ml per minute, that we can use these agents in more of our CKD patients?
So I think in all these studies there were patients who actually dropped. The DAPA one is 25 to 75. It's not so we have at least up to 25 the data. But also in all these studies there were people who actually slipped below the 25 or the 30, and it seems to be reasonably safe. At this point of time, there's no recommendation to continue it once dialysis is started. So I think if you've started the patient already and the patient has an EGFR of 25 or 30 above, and the patient slips to below 25 or 30, we're all the way up to 15, there is no reason to discontinue the drug. I think that information we are very clear. The important thing is that once dialysis is commenced, this needs to be stopped.
So I'll just quickly add to that, Pratap, that yes, I think the recommendation has in fact recently changed to 30. I don't see that dropping, and it probably shouldn't. There would be some safety concerns, and let me remind that what the DCGI said, and Krishna can again correct me, that this 30 also is purely for nephrologist use. So it's not actually licensed for others to use it at that GFR.
Yes.
Right. So remember, the KDIGO guidelines also tell you that you need to start taking help of a nephrologist if your EGFR actually slips below 45. So these are in line with those recommendations. My minor point being that if you initiated it at a higher SGLT2, higher EGFR, and the EGFR slipped below a certain number, there is probably no data to support that you have to discontinue. The recommendations are all for initiation. I don't think there are recommendations for discontinuation below a certain EGFR. And I think the safety data seem to support.
Thank you both of you for that clarification. Dr. Hina?
Yes, sir.
It's been a wonderful session. Thank you very much, and it's been really, full of knowledge. And thanks so much for Dr. Manoj and Dr. Krishna for your inputs.
Thank you.
I
Thank you, all
had
the
a great
chairpersons.
time learning from all of you. Sir.
Thank you.
Thank you so much. Thank you so much.
Thank you. Thank you very much.
Thank you, everyone. Bye.
Thank
So
you.
I think we conclude this session on SGLT2 inhibitor here. Thank you, Dr. Hina Goswami, Dr.
Thank you,
Alka
sir.
Gandhi, Dr. Sen Gupta, Dr. Manoj, Dr. Krishna, and Dr. A.K. Singh for highlighting the importance of SGLT2 inhibitor in type 2 diabetes management way beyond glycemic control and its much more pleiotropic benefits which we now are recognizing in our routine clinical practice. So now we will move on to the next symposium, that is recent therapy symposium. And I will invite Dr. Amrita Ghosh to carry on with the proceedings of this symposium. Dr. Amrita Ghosh.
Thank you so much, sir. I welcome you all to this symposium on recent therapy. And we have many stalwarts joining this session today with us. And in the next 1 hour, it will be an enriched session for all of us. I invite Dr. D.K. Hazra, Padma Shri Awardee, and Dr. Mridul Das to take over the session, please.
Thank you. Thank you so much, Dr. Amrita. I just want to say that we know half of the diabetes patients, especially type 2 diabetes, fail to achieve therapeutic target. And selection of drug to achieve therapeutic target is of great importance in order to prevent risk of hypoglycemia, micro and macrovascular complications, as well as morbidity and mortality. And therapeutic choices are more preferred and discussed and studied with few molecules like DPP-4 inhibitor, SGLT2 inhibitor, and GLP-1 receptor agonist. So in this recent therapy session, we are going to listen about DPP-4 inhibitor and SGLT2 inhibitor. Our first speaker is renowned famous speaker, Dr. Binayak Sinha, and second speaker will be Dr. Amrish Mittal. I'm going to introduce Dr. Binayak Sinha, and I will hand over to introduce Dr. Mittal to Dr. D.K. Hazra later. Dr. Binayak Sinha, he is past consultant, diabetes and endocrinology, University Hospital, Birmingham. He is MBBS, MRCP from UK, FRCP from London, and he is consultant of diabetes and endocrinology of Ambly Hospitals. He is member of Royal College of Physicians in the year 1995, and his specialty of research was on PCOS and gestational diabetes. And for this, he was awarded Young Investigator Award at the International Conference of Endocrinology in 2002. And there are extensive publications by Dr. Binayak Sinha, and he was given the oration on PCOS by the Indian Medical Association. He was honored for that. And he is a co-author on many handbooks in diabetes and endocrinology. He teaches on various courses all over the country. So I invite Dr. Binayak Sinha to start his deliberation. Thank you.
Thank you, Dr. Das, for your very kind words of introduction. I will be sharing my screen to present to you some data on simplifying type 2 diabetes management in the current era by using the right choice of DPP-4 inhibitors. Now, as we know that there has been an exponential rise in the number of patients with diabetes over the years, extending from 2000, and continues to increase every year. We've also seen a complete explosion of newer drugs like GLP-1RA, DPP-4 inhibitors, SGLT2 inhibitors, which has kind of sidelined the older drugs like AGIs, thiazolidinediones, sulfonylureas, and metformin. Of these, the main drug that is going to be a focus for today's discussion is linagliptin, which has been in use since 2011. And we have to take that with the perspective that diabetes is a cardiorenal metabolic syndrome with prediabetes and early type 2 diabetes caused by a combination of insulin resistance and beta cell dysfunction, leading to increased glycemia, increased body weight, falling EGFR, and high CV risk, which in turn translates into advanced type 2 diabetes with obesity, insulin resistance, hyperglycemia, dyslipidemia, and NASH. Also, cardiac complications like hypertension, increased clotting, atherosclerosis, heart failure, and coronary artery disease, along with renal diseases like CKD, worsening of albuminuria, which also leads to electrolyte imbalance, which might also cause hemoglobin to be low and causing anemia. So a typical diabetes population has a twofold premature CV mortality and has multiple complications, including retinopathy, neuropathy, and amputations. And about 30% have CV disease, 20% have some degree of CKD, and another 20% have some degree of albuminuria. And as we know, most of our patients with diabetes will be having hypertension, which makes diabetes the largest category on the dialysis register, as well as the largest category on the blindness register all across the world. Now, to treat diabetes, we've got multiple drugs, as I showed you. But if you look at this part of the slide, you will notice that there has been a continuous rise in the usage of a particular group of drugs. And that group of drugs is none other than DPP-4 inhibitors. And this has been at the expense of sulfonylureas, which it has somehow overtaken. Even if you look at SGLT2 inhibitors, the rise in the usage of SGLT2 inhibitors has not been that exponential. It's gone up definitely, but not exponential. The GLP-1s have not been that popular. And DPP-4 inhibitors have become so popular because they provide with us a simplicity in type 2 diabetes. And if you look at the evidence-based pillar of simplicity, it is a powerful HbA1c lowering agent with a low risk of hypoglycemia. It can be used once daily without need for adjustment. There's safety in heart disease, there's safety in renal and hepatic disease, and it can be used across diverse patient groups in clinical practice. And it is my job today to take you through the journey of all these 5 areas which I have already mentioned. So the evidence of safety and efficacy, I'm sure I'm preaching to the learned. So everybody knows that they're very safe and efficacious drugs, leading to a 0.75% reduction of HbA1c. All of them provide the same degree of HbA1c reduction. And linagliptin, whether you use it as monotherapy or whether you use it as a combination with metformin, it leads to a robust reduction of HbA1c. Naturally, the closer to the baseline, the lesser is the fall. The higher you go, the greater is the fall. So 12.1, you get a 5%, and again, around 12, you get a 4% reduction of HbA1c, which is seen in all molecules and probably a hallmark of diabetes per se. In addition, linagliptin versus glimepiride, when you add on to metformin, provides this additional huge benefit of reduction of hypoglycemia to the extent of about 5 times. It reduces body weight to the tune of 3 kilos with similar HbA1c reduction, which is maintained over a 2-year period and probably longer, which is something we tend to be losing with sulfonylureas. Also, it is useful in patients who have a long history of diabetes, so you can continue to use it over a prolonged period of time, which means it's durable and can be used at any stage of diabetes. As you can see from these slides, that if you use it in patients with diabetes for more than 10 years, it still continues to provide a robust HbA1c with a large percentage of patients reaching the target HbA1c of less than 7.5% to the tune of about 62%. In the elderly, it provides a robust HbA1c reduction like in all other groups. So it can be used safely to reduce blood sugar in the elderly. And also the combination with metformin leads to a 2 to 3-fold increased chance of reaching the HbA1c goal. So as you can see, this is about 2.84 if the HbA1c is lower, and then if you go up a little higher, the chances of reaching the HbA1c is far higher if you use when in combination with metformin in an increasing dose. There is increasing evidence, particularly from the southern part of India, from Dr. Mohan's group as well, that HbA1c is much more susceptible to reduction with DPP-4 inhibitors. Again, that is with sitagliptin, and this is data with linagliptin, showing a reduction to the tune of 0.9%, whereas if you see in the Western data, it's about 0.7%. So there is probably a bit more robust data in Indo-Asians as far as the usage of DPP-4 inhibitors is concerned. He moved, therefore, on to other areas like CV and heart failure safety. And of course, this is hedging on the two randomized controlled trials. The CVOT is published with linagliptin, Carmelina, and Carolina. Carmelina looked at 3P MACE and a composite renal endpoint of sustained ESRD, sustained reduction of GFR of greater than 40% and renal death. And Carolina, which looked at 3P MACE and 4P MACE. And what did these results show? Carmelina showed that everything is just about 1, which means linagliptin is completely safe. There is no bad signal. There is also no bad signal with sitagliptin. However, there seems to be a little bit of a bad signal with savertimi. The saxagliptin showed a 27% risk in the increase in the risk of hospitalization for heart failure. Vildagliptin has no CVOT, but the VIVID trial gives an evidence of increased LV volumes and a numerically increased number of CV deaths. Teneligliptin has no CVOT. I will not be discussing teneligliptin any further. And if you look at the QT prolongation, you see that the only drug with absolutely no QT prolongation is linagliptin. Even if it's used in a dose 20 times higher than its prescribed dose. Sitagliptin showed some kind of QTc prolongation with 800 milligrams, and vildagliptin with 100 milligrams at 1 and 8 hours. So double the dose led to vildagliptin having this. Teneligliptin, as I said, is not worth discussing. So we come back to Carmelina, which shows an increased risk of hospitalization for heart failure with a history of heart failure at baseline to the tune of 27%. And as you can see, this is 12% reduction of risk, but this did not prove to be statistically significant. But it was enough for the ESC-ESD guideline to take cognizance and say that Sita and Lina have a neutral effect and may be considered for diabetes patients with heart failure. Saxa, however, is not recommended, and neither is vildagliptin because it has no trial and it increases ejection, it lowers the ejection fraction. So there is also real-world evidence from insurance databases of US and South Korea, which shows that there is a reduction of hospitalization for heart failure when you compare it with second-generation sulfonylurea. These are as robust as insurance database studies can be with the 1:1 propensity matching. If you come to the kidney disease, we know that linagliptin reduces HbA1c all across the board, from mild renal impairment to moderate to severe renal impairment to patients on renal dialysis and NODAT. So this can be used safely, and it can also be used in patients with renal transplant. And there is data. There is a composite kidney endpoint in a pre-specified, pre-adjudicated study in the Carmelina. I know it's a secondary endpoint, but it was pre-specified and pre-adjudicated to look at sustained kidney failure, sustained rise of creatinine and renal death. And it also took into account that this was the largest, sickest kidney population with about 60% of renally sick patients in the Carmelina group. If you look at the other studies, they did not have that many patients with established kidney disease. So it did provide long-term kidney safety with, as you can see, all these diamonds are next to the unity, but it did reduce the number of episodes of macroalbuminuria and microvascular composite outcomes, probably relating to natriuresis, diuresis, hyperfiltration, or reduction of tubular interstitial fibrosis and podocyte loss. There is also this interesting study, the Carmelina study, which has not been highlighted too often, but this is in patients with nephrotic range proteinuria. And as you can see, the number of patients who had increased risk of proteinuria or all-cause hospitalization was increased in the arm which was randomized to placebo, but it did not reach statistical significance. We come to liver disease. Today, NAFLD is starting to become another arm of complications of diabetes with worsening death rates. And most or a large number of patients we find have some degree of NAFLD or NASH. And we see that the exposure relative to normal hepatic function with linagliptin remains the same across the board in this PKPD study. We also know that if you compare it with placebo, it produces a robust HbA1c reduction, which is similar to what it does in patients without liver disease. And this is seen all across the spectrum of CLD, except for decompensated liver disease, wherein, of course, insulin would be a drug of choice. So naturally, it is the first-line treatment in patients with chronic liver disease with no hepatic, with no dose adjustment required. Vildagliptin is not recommended for use in patients with impaired liver function. In addition to all these scientific evidence, we come to practical issues like convenience, and we know linagliptin is excreted mostly unchanged in the bile, and it is highly selective. So it doesn't interfere with anything else, whereas the others seem to be going through the urine. So as you will see in my later slides, they will need dose adjustment. In addition, linagliptin also provides greater than 90% inhibition. It's only linagliptin and sitagliptin which provide this degree of DPP-4 inhibitions. The other drugs do not provide this level of DPP-4 inhibition continuously. And therefore, we also know that if you do not adjust the dose of DPP-4, you can have an increased risk of all-cause death, severe hypoglycemia, and emergency department visits. I wouldn't be taken in too much by this 11.5, 19.2, and 7.4, because these are all database studies, but definitely there seems to be a signal. And in this group of patients who were studied, there were patients who were on Sita and Vilda with unadjusted doses of gliptin. There was no patient on linagliptin, which is, of course, very reassuring. Therefore, we can use it once daily with no dose adjustment, whether it be CKD or CLD, except for decompensated CLD. And it's obviously convenient as a single dose, a simple method to maintain patients on licensed dose without dose modification, which is a bit of a challenge, particularly in our country with so much of problems of follow-up and patients coming back to see you after 5 years with a creatinine which is probably tripled in this 3 or 5 year period. So dose adjustment challenge is removed by the usage of linagliptin. We come to the broad range of type 2 diabetes patients. This is patients in the continuum of cardiorenal risk. So this is Carmelina. This is high risk patients in Carolina with lesser risk. So you see that across the board, it seems to be having similar kind of neutral effect in the continuum of cardiorenal risk. We look at the spectrum of CKD, and if you look at 3P MACE, HHF, and ESKD, they're all the same across the entire spectrum of EGFR or the entire overall heart failure. And so in whether you have a worsening CKD or you have similar amount of CKD, you will have the same kind of CV safety and CV neutrality by the usage of linagliptin. It can be used in elderly, and in comparison to glimepiride, there is, as you would expect, a bit of a no-brainer, a huge reduction of risk of hypoglycemia, which I'm sure all of you will agree is a huge advantage in the elderly. Also, there is the weight advantage to the tune of about 1.5 to 2 kilograms, which are very important considerations when we have to take into consideration when we are choosing drugs for the elderly. There is no increased risk of cardiorenal events. This is in whether you look at patients between 65 to 75 or whether they are greater than 75. As you can see, all these lines are crossing unity. So there is no increased risk of any kind of event across the entire age spectrum of patients with diabetes. So to summarize, we have linagliptin, which is the broadest clinical evidence in DPP-4 inhibitor class. It has highest DPP-4 inhibition, about as much as sitagliptin. Similar HbA1c reduction. The unique convenience being once daily, one dose, and efficacy safety data available in a broad range of patients. There are 2 CVOTs and CV safety profile from these outcome trials to back it. There is no increased risk of heart failure, and the only DPP-4 inhibitor which has demonstrated kidney safety profile in large outcome trials. I thank you, ladies and gentlemen, for listening to me. Thank you.
Thank you, Sir Binayak Sinha, for your very lucid and interesting presentation. You almost covered almost all aspects of the DPP-4 inhibitors, especially you discussed and compared the outcomes of CVOTs. And your index finger goes towards linagliptin. So far, at last, I came to know. Anyway, thank you very much. Over to, we'll take questions at the end of speech of both speakers, okay? Over to Dr. Daya Hajra.
It's a pleasure to welcome Dr. Ambrish Mittal, and I hope he has joined us. Yes, and Ambrish is not only a distinguished endocrinologist, he's a very old friend, right from his IGPGI days. He was awarded Padma Bhushan in 2015. He has a deep interest in bone density, and he was awarded the International Osteoporosis Foundation President's Award in March 2016. He is very active in diabetes control and is going to speak to us with a somewhat intriguing title of CRM approach for T2 diabetes management. CRM has capable of many expansions. It was interesting to hear Dr. Ambrish on this. So over to Dr. Ambrish.
Thank you, sir. Thank you for the kind words. It's always an honor to be on the same podium as you. We all know your contribution to medical science globally and particularly in India. At a time when no one was talking of immunoassays and endocrinology, Dr. Hajra is one of the pioneers in the country. Some of the youngsters may not know that. So am I allowed to share my screen? Yes.
Sure.
So it's a pleasure to be talking about new approaches in management, which actually are not that new anymore. And I think most people who are in the audience, or at least those who are in the faculty, would be very well versed with this approach. The concept that we are talking about is the change in our understanding of managing type 2 diabetes, with the focus shifting from what used to be good glycemic control as our primary goal to actually looking at reducing complications overall. And certainly even earlier, when we always thought of reducing complications, if you got better glycemic control, you had better outcomes with regard to microvascular disease, and somewhat better outcomes, a little bit more questionable with regard to macrovascular disease. However, a recent understanding has sort of changed our approach, because we are really not thinking of these as completely separate entities altogether. We are really talking of overall complications related to diabetes. Some of them are related to glucose control, some are related to hypertension, some are related to genetics, but it's about a conundrum of complications, which actually it doesn't just include micro and macro in watertight compartments, but spills over from kidney to heart to overall metabolic complications, and I would actually start adding liver, all those things. And as typically understood, we start with insulin resistance and then move towards a state of progressive insulin deficiency. But we also know the role that visceral adiposity is playing in that. We know the role of inflammation, glucotoxicity, gut microbiota. The whole thing is changing from being simple pancreatic defect and peripheral defect to a combination of many things. And the advent of new therapies has actually opened up infinite possibilities, newer possibilities for preventing this progression. Of course, as you know, this CRM is a fancy acronym. It doesn't mean much. Basically, cardio, all cardio, renal, right? And all metabolic, but the fact that they overlap, and that's the whole concept. It's not that renal disease is separate, cardiac disease is separate. The main cause of death in renal failure in ESRD is coronary events. the main cause of death in diabetes is coronary events. Now we understand heart failure as an important link between diabetes and the heart. So the whole thing is all merging onto each other. And as I said, some newer therapies help us address these all together. And that's the whole idea of this discussion. So, I mean, you know this, right? There's nothing that I'm going to tell you which you don't know, that it's not just vascular disease. It's, of course, renal failure, oxidative stress, inflammation, cellular apoptosis, but the so-called diabetic heart pump failure or pump dysfunction is actually much commoner than we think. Much, much commoner. Only the last few years have shown us that it's not only about ischemic heart disease, it's about reduced pump capacity that we see in patients with diabetes, and that's far commoner than we thought. And as usual, the focus on these things, like the focus on lipids, changed completely after the advent of statins. The focus on osteoporosis changed completely after advent of bisphosphonates. Similarly, the focus on heart failure, on heart changed completely after the advent of newer molecules, especially SGLT2 inhibitors. So we focus on early management. The important part is glucose-lowering drugs that have non-glucose lowering actions also. So you can call them pleiotropic actions. I probably think they're primary actions, and glucose-lowering may be just one of the actions of these kinds of molecules. So you obviously work towards weight management. So when you are looking to focus on your patients now, when you start treating a person with diabetes, you're not just looking at blood glucose, you're looking, of course, at blood glucose, but you're looking at helping the person lose weight. You're looking at avoiding hypoglycemia. And you're looking at long-term vasculometabolic control, all again jargon, basically meaning you're looking at strategies that will reduce the risk of long-term complications of the heart, kidney, etc. I think that's really, really important. So we all know that our A1Cs are not well controlled and everywhere in the world, and we don't do much better than that. We know that most of our patients, typically, when you recruit patients for a trial, it's a good way to look at it. And typically, you find A1Cs between 8 and 9 in the OPD. So most of our patients are not very well controlled. With the advent of newer agents and more understanding, the numbers who are well controlled will go on improving, hopefully. But at the moment, we know that 2/3 of our patients are not achieving targets at all. There's no question about that. And as I said, our classic approach was climbing up these steps. From diagnosis, you talk, first time we were always told, don't prescribe a medicine. Dr. Hajra will remember, you just tell him to go and follow a lifestyle, come back in 3 months. We still do that, but we do that with people with A1Cs of 6.5 and 6.6, not with anyone above that. So the approach was first try that, then you try metformin, then you try a second drug, and then which is okay, which is how pharmacology was built. But now we understand that attacking it on multiple fronts right from the beginning gives us better long-term results. What is the goal? The goal of treatment is not just to keep blood glucose normal. The goal of, if you keep blood glucose normal, but you can't prevent complications, is quite useless, your whole approach. So it's about preventing complications. And for that, going stepwise need not always be necessary. Of course, there is some stepping, it can't be all at one go. But yes, we have become much more aggressive in our approach to treating diabetes in the early stages. So therefore, you climb up this, reach the goal, and therefore, in every step, there is inertia. Every step that we take, there is some inertia because of simply patient request sometimes your own lack of time, sometimes your own mental laziness, because you think maybe we can try another 3 months, let's see. So, all those kind of things happen in real world. So clinical inertia has been a big challenge in this. So, but we know that when we are treating diabetes well, even glucose control, we know that we clearly reduce microvascular complications. This is an oversimplification, this slide. There are numerous studies that have shown, the UKPDS, starting with UKPDS, that even in the studies that showed that in patients with advanced heart disease or with existing heart disease, tight control like Accord and advanced special, they didn't have any favorable outcome. Even there, lowering of A1C, even at that stage, improved microvascular disease, reduced the risk of renal complications. So lowering of A1C will have benefits across this micro and macrovascular disease. And again, its targets are important, but even a 1% lowering makes a difference. So remember that. Even a 1% lowering makes a difference. Now, there's other thing is, well, there is some data saying that glucose lowering is better with these newer agents in people of predominantly Asian ethnicity. That was mainly that was not South Asians. These were Asian, which is mostly East Asians ethnicity, and no difference with GLP-1 RA. I'm still a little cautious about jumping to conclusions, because everyone gets up and says, maybe it works better in Indians. Maybe we have more beta cell defects. Maybe a symptoms work better. But I think it's a bit premature to make a definitive statement that, we know that DPP-4 works better in India. I think at least I'm still a little unsure. Probably yes, but I'm not certain yet. Again, this is going for you. We talked about this many times, from just a simple, as I said, liver and pancreas and peripheral muscle disease. It has now moved to multiple things that are. So if we attack multiple pathophysiology at the same time, we will get better results. And the beauty of these modern combinations like SGLT2 and DPP-4, that they have separate mechanisms altogether, and they don't clash with each other. They're completely different mechanisms. Like SGLT2, we know act by increasing glucose output through the kidney and suppressing some glucagon from the pancreas. So there's no interaction. There's no possibility. It's not like combining a meglitinide and a sulfonylurea, which is the wrong combination. It's having two drugs that act on two different pathophysiological aspects of diabetes. And therefore, when you look at empagliflozin, you actually, over a period of time, reduce insulin resistance. Look at HOMA-IR. And you look at linagliptin, you actually improve beta cell function. Again, no big surprises here, because one drug is acting primarily on the pancreas, that is the linagliptin or any gliptin, and the SGLT2 inhibitors, they act by so many mechanisms, but one of them being that they do reduce insulin resistance, which is thought to be primarily because of weight loss, because of fat loss, and maybe because of reduction in hepatic liver fat that we have shown in our own studies. So when you look at all this together, if you look at a metformin and a sulfonylurea combination, it is powerful and effective, right? There's no question about that. If you look at metformin and DPP-4, it's probably a little less effective in terms of potency, but very low risk of hypoglycemia, right? I hope this is clear. Right is hypoglycemia, and as you go up, as you go down, the risk of hypoglycemia decreases. So we know that metformin SGLT2 combination is fantastic for this. But if you look at metformin plus SGLT2 plus DPP-4, you're actually doing everything together. Think of it. You're helping to reduce weight and blood pressure, left upper quadrant. They're powerful and early efficacious. Early efficacy, you know that DPP-4, SGLT2 in particular are powerful molecules, especially when combined with metformin. The risk of hypoglycemia is really low, right? Bottom quadrant. And the left bottom shows the icing on the cake, which is actually see benefits in the long run. And I think that's fantastic. And when you use a fixed dose combination, I mean, I'm not going to take you data. There is no surprise there. We know that EMPA works very well. We know that Lina works well. When we put them together in an FDC, it doesn't mean that 1 + 1 = 2, but 1 + 1 may equal 1.5, right? So you actually do get improvement in HbA1c. This is EMPA 25, Lina 5, EMPA 10, Lina 5. This is EMPA alone. So just look at this one. 0.62 with EMPA alone and above 1 with the combination. Fantastic, right? And Lina alone, again, about the same. But when you have a high baseline A1Cs, that you commonly find your patients in our OPDs when they start out with us, then you can get almost a 2 reduction, 1.5 to 2 with this combination. The idea being that if you start using these combinations early, you can get significant benefit for your patient in terms of A1C lowering, weight reduction, long-term benefits without risk of hypoglycemia or minimal risk of hypoglycemia. The risk, of course, is GTIs. We know with SGLT2 that the risk of GTI is fairly high. There is some evidence, and again, this is evidence which I still take with a pinch of salt, that when you combine SGLT2 and DPP4, it reduces the risk of genital infection. Now, it's okay. Yes, there is some evidence, but I'm not completely convinced that when you combine them, the risk of genital infections is less. But anyway, that's what, and we know that body weight reduction, we've all seen that, we've published that. BP reduction, one huge advantage with SGLT2 is their mild diuretic nature, which actually leads to significant blood pressure reduction, and a sustained reduction of 3 to 4 millimeters is actually really important in a long-term history of a person with diabetes, right? And you may be able to reduce one like antihypertensive, like a mild diuretic. You may be using a low-dose thiazide, which can go out of the window once you have somebody on empagliflozin. That's the added thing. And as we know, body weight benefit is a huge thing, and I'm not talking about it here today, but we've done the the E-lift study, which actually looked at hepatic liver fat. There was no time to include all that. We're talking only of FDCs. So, and there was clear reduction in published in March 2018 in Diabetes Care, clear reduction in hepatic liver fat in the group that got EMPA in an open label study versus those that got standard of care. So all this is happening as an effect of EMPA. And despite all this, you're not getting any additional hypoglycemia risk. That's the beauty of the whole thing. And as I said, this is what is presented to me again and again. Maybe it's true. You can read the title. But as I said, I think we need more data to prove this kind of thing. Now, we're not going to bore you with all these studies. You know, EMPA-REG, Canvas, Declarity. We know that there is cardiac reduction in cardiac risk with the SGLT2 inhibitors in coronary events in 3-point MACE. Different studies and different inhibitors have shown little something different or the other, but EMPA remains the leader of the pack by being the first one of the block and having nothing negative really about it. So there is no question about that empagliflozin is important in this regard, but it's not just the myocardial, not just the atherosclerotic events, which I think the effect is less pronounced and little bit hazy at times, but the hospitalization for heart failure is remarkable. The effect on hospitalization for heart failure is remarkable and consistent across all SGLT2s. So in one line, empagliflozin reduces hospitalization for heart failure very significantly and possibly also helps in reducing coronary events or adverse cardiovascular events, even excluding hospitalization for heart failure. And again, there you go, CV deaths, hospitalization for heart failure. A very, very significant reduction. This is consistent. The HHF data is absolutely consistent. CV deaths was very well seen with EMPA. Some others did not show it so striking. Some others showed some. So I'm not going to hair splitting over differences between SGLT2s. That's not the topic today. But I think what is more important is, yeah, we know this. Right? You've seen this about 1 million times. The EMPA-REG study. The reduced risk of CV deaths was started very early, too early to be pure atherosclerotic. That's the point we are making here. It's not going to have, so it's probably an impact on the heart failure at that point, some other mechanisms which are still being studied as to why, but the benefit was clearly seen, no question. And across all heart studies, CV outcome trials with all these SGLT2 inhibitors, hospitalization for heart failure was one thing that stood out consistently. So the issue here is about the DPP4, and very in one line, there has been some data on alogliptin and some data on Saxa, which suggests that they may possibly increase the hospitalization for heart failure, but certainly no data on Lina to suggest anything like that. And Vinayak so neatly presented data on Lina from Carmelina, very clearly showing that it is cardiac safe in one line, both with regards to MACE and with regards to heart failure. There you are. We won't repeat this. Absolutely no difference. And of course, some impact on albuminuria. I really should have put the liver slides here. But anyway, so decision cycle for patient-centered management. Basically, we have to keep the regimen simple. We have to keep it at a level that optimizes patient adherence and persistence to treatment. When you have chronic care medication that has to be given for years and years, having separate pills or reducing pill burden makes a big difference. The fact that you don't have to time it with a meal makes a big difference. Take it any time of the day. The fact that it's a single pill will make a big difference. The fact that it doesn't produce hypoglycemia will make a big difference to compliance. So if you're talking of people and their effects, we forget that these things actually determine in clinical practice. If you're advising molecules which have to be taken half an hour before a meal, 90%, 95% of patients will not be doing that. I don't know how many doctors do that. Many doctors have diabetes, hypertension. How many will take their medicine half an hour exactly before meal? It's very difficult to manage in real world. So all these are huge advantages in addition to the advantages I already showed of long-term impact. So, right, no confusion. You can read the title of the slide. These are the ESC guidelines. And renal evidence is strong. Hepatic evidence in terms of safety is strong, but also in terms of some benefits, which we haven't shown today because of lack of time. And of course, combinations will work. There are 3 combinations available, empagliflozin plus Lina. All of them work well for glycemic control, no question about that. All of them work well for weight reduction, no question about that. All of them work well for that they don't, in the sense they don't produce hypoglycemia. But when you look at the long-term outcomes, there seems to be a difference. It's a Lina and EMPA combination that seems to be the safest for the heart. And the Remo and Vilda, which on short-term results seems as good, or at least about as good, we don't have that kind of long-term outcome data on heart. So going by this, quite clearly the EMPA-Lina combination is most cardiac friendly in the long run, proven cardiac friendly in the long run. So to a holistic, as Dr. Hajra was saying, CRM, cardio-renal metabolic approach, it does all those things together. I think it's easy to do this and in a fixed dose regimen. And I think you're not going to worry. We all know the benefits of taking a fixed dose regimen. So I think the beauty of things is in combination. This is a picture I took last week from my terrace, and the sun alone was shining. It would not look that beautiful. When you combine it with the clouds, it becomes sky art. And that's why combining things adds to the beauty. And this is where this combination comes in. Thank you very much.
Thank you, Dr. Ambrish, for that excellent account of the cardio-renal-metabolic benefits of using these newer agents, and proved right across the spectrum. I just say, in humorous aside, that if you look up Google, then CRM also stands for Crew Resource Management of Diabetes, which has apparently been a term used in some US studies. Anyway, we know what Professor Mittal was emphasizing. The only point I would ask is that perhaps knowing the safety of these combinations, the time has come when we should be recommending them in pre-diabetes. And I look forward to long-term trials on this aspect. When we know the benefits early on in diabetes, both for the heart, and for the heart, we now know it is not simply cardiac failure, not simply obstructive heart disease. We now there's some evidence they may also be helping in cardiac arrhythmias, atrial fibrillation, and the liver benefits which Dr. Ambrish and his other groups have shown, which to be outstanding. So, in fact, the 2 next frontiers we ought to be looking at, in my view, are the pre-diabetic frontier, and as well as maybe we are also doing good work in the eye. That's also something to be looked at.
So, as usual, is ahead of his time. He always was, while we are still trying to position it in early diabetes and it's becoming more and more acceptable. Maybe the future will see even earlier than early diabetes, maybe in pre-diabetes, who knows? Because the benefits are there for all to see. There is no question. So I appreciate that viewpoint. I think that
there is a question, sir.
Yes.
There is a question about renal safety of evogliptin in CKD patients compared to linagliptin in type 2 diabetes. Question was done by Dr. Pankaja J.H. As both of you have explained about DPP4 inhibitor, can anyone please explain it?
I'm not aware of any head-to-head study.
There isn't any study, and the renal data with evogliptin it's still ongoing clinical trial. So as of now, there is no data.
I have a question, Dr. Binayak. What
Go for
about
it, Leena.
Dada? What about linagliptin? What about vildagliptin OD? It's flooded the market. Will it be able to block the DP4 receptors for 80% of them, or more than 80% for 24 hours?
I can see Dr. Mittal laughing as you ask this question, because you see, there's no paper. The only thing that has been done is there's a slide which has been sent out by the company which is making the XR preparation. So I don't know. The honest answer is I don't know. If there's data, I would be very happy to use it, because I think of the cheaper gliptins, I think the amount of evidence that exists with vildagliptin, it would definitely be my choice of the cheaper gliptin in comparison to other gliptins which are cheap.
And the other question is, why not use vildagliptin 50 OD in CKD? You're going to bring down the price to half, because after all, even when you use 50 OD, you achieve similar as linagliptin 5 milligrams. So
why not, as far as the renal side of things is concerned? But of course, you will appreciate that people with CKD will also have a high degree of coronary artery disease and heart failure. And vildagliptin does not really have any kind of data with heart failure or coronary artery disease. And I think it's a bit of a shame, because the VIVID has really sowed some doubts in the minds of all clinicians and researchers that there might be some kind of a soft signal of some kind of damage. So I think in my situation, if I have somebody with CKD, that is the only thing that influences my decision. But one thing is true, is that if one of my patients is on Vilda 50 and is in renal failure and comes to see me, I probably will not stop it.
So, Meena, I tend to agree with Vinayak, and I think we do use Vilda 50 OD in renal patients without much concern. But yes, if there is a choice, and it's all very subtle and mild distinctions, but if there's a choice, I would use Leena.
Sir, what about sarcopenia and SGLT2? Because in India, we see a lot of sarcopenic patients being given either the combination or SGLT2 alone. And there is a decrease in not just, there's a decrease in lean mass as well as a decrease in, so patients already have, because Indian patients, most of them are vegetarians. Is it an absolute contraindication to using an SGLT2?
It's not an absolute contraindication, but we shouldn't push it. I've seen it being pushed in people with BMIs of 19 and 19.5, and because they've had an MI and they're virtually shaking like a leaf, and then you add an SGLT2. No, I think we have to individualize, as you always do. So basically, not for everybody. Every drug will have groups of patients where I would not use it. I would not push it for long-term protection in someone who can't tolerate it short-term. So I would be cautious. I would be cautious in those patients, definitely.
But this is a minority. The majority of our patients are obese. There's no doubt about that. Rather than
that agreed, sir.
I also think, Dr. Mittal, Dr. Hajra, there is this group of people in India. I think there's a large group of these people in India who hate losing weight. They actually come back to you and they say that I have lost so much of weight because of this drug. So that is another group that you have to really, I find it difficult to convince them.
There is no doubt, Vinayak, and you have to modify that since you're talking of the Indian cultural setting. It's the spouse who's most often worried, especially wife. The glow has gone out of his face.
Absolutely.
The person is 150 kg, has come to 160, and everyone is worried the glow has gone. That's how it is.
Sir, I have a question. Type 2 diabetes patient with, say, NFLD, will you prefer pioglitazone over SGLT2, or like which one do you want to go about with?
That's a great question. The data on pioglitazone and NAFLD is very strong. It is a fairly solid actual indication for usage. The problem with pioglitazone is that most of our patients tend to put on some weight, and one of the things we are pushing NAFLD patients to do is to lose weight. So I would be cautious, but it is a justifiable indication. There is more data on pioglitazone. It's been around much longer than SGLT2. So by and large, I am a small user of pioglitazone. And I would, in NAFLD, at the moment, given the evidence and the evolving evidence, I would settle for SGLT2. Unless for some reason it's a very lean patient, as Meena was saying, and you want to avoid SGLT2, you can use pioglitazone for NAFLD. Nothing against it.
Dr. Ghosh,
Better not to use both together. A word of warning here. I mean, you can use them together also. There is no guideline that you should not. But given the fact that pioglitazone clearly has an impact on fracture risk, and given the fact there is some suspicion in the air, which is, on and off about SGL2 and bone, I would hesitate to use them both together. But that's my personal view.
So Amrita, I'll just focus you on our latest publication in Nature Scientific Reviews. So we've published the usage of pioglitazone and a meta-analysis weighing the pros and cons. And it's come out 3 months back, but because it's pioglitazone, I don't think it's been focused so hard. And we've actually convincingly showed in a large-scale meta-analysis of randomized controlled trials only that there is no benefit of using pioglitazone unless other drugs are precluded. So you might want to look that up. It's in Nature Scientific Reviews.
I'll do that, sir. Thank you.
I would go even further. I would say that in the present context, where we are increasingly conscious of the contribution of heart failure to diabetic and diabetic death, I would not touch glitazones with a barge pole.
Neither do I, actually.
Actually, we use them very little. I hardly use
Dr. Amrita and Dr. Binayak, yesterday we heard Dr. DiFronzo say that in COVID, he wants to use glitazones because there is some fat in the lung, he says, of the COVID patient. Yesterday in his talk in Diabetes India, he said, I would use glitazone in COVID. That was one very different observation. And I heard him yesterday from Dr. DiFronzo himself. So
one fails to agree. The major pathology in the lung is not due to fat deposition, as we know. It is due to progressive fibrosis.
So, sir, I have some question to both of you, sir. Can I, sir?
Yes.
In diet exercise treated patient or only metformin treated patient, if sugar is not controlled, do you like to start FDC? If not, which one? DPP4 inhibitor or SGLT2 inhibitor you want to start first? This is number one question. And number two, there are some FDC available in the market. For elderly patient, which FDC you will prefer?
Who wants to go first? Binayak, you want to go first?
Okay, sir. So the first question is, there's a good reason to use either. I think if the HbA1c is a little higher than 7.5, I'd probably go with a fixed drug combination, because the reduction of HbA1c I would be looking for would be about 1%, particularly younger patients. So there would be a very good case for using an FDC in that situation, like Empalina combination. Also, if you look at it as Dr. Mittal was presenting, he showed very robustly that if you use the two of them, you're addressing more of the pathophysiology of diabetes. So there's a very good case of using them. The anti side to this is, of course, starting two drugs means you're increasing the cost, and you're also giving them the side effects of two drugs. So, it's a choice, but I don't think there's any kind of decision making. You can go for a FDC if it's more than 7.5, but if it's less than 7.5, I think as far as SGLT2 inhibitors becoming second line in the treatment of diabetes, I think there's going to be very little debate in view of the onrush of evidence that we've seen in the last few years.
Yeah, sure. I mean, if you have to choose one between the two, if the single drug, then DPP-4 are milder drugs. If there's a mild elevation of A1C, you can add a DPP-4. They are completely innocuous. If it's really someone who's much older and you're worried about blood pressure fluctuation, you're worried about postural hypotension, or you would again prefer a gliptin. But otherwise, often SGLT2 is crept up the ladder. And if the person doesn't have any significant reason not to use it, you would often go for SGLT2 after metformin.
But in literature, sir, it is said that first starting with DPP-4 inhibitor and later addition of SGLT2 inhibitor, the outcome is better than starting with SGLT2 inhibitor and later adding with
Well,
DPP-4
if
inhibitor.
you read that data carefully, it's not that simple. I think basically what happens is that once you have the SGLT2 in place, there's very little that DPP-4 adds actually, not too much. It's probably that. That study keeps coming up. I don't know, everywhere it pops up. So, but I don't think it's a very powerful data. I would suggest that we don't take it on at face value.
May I make a comment?
Yes,
that
sir.
the wise clinician like to use drugs separately rather than fixed drug combinations because the factors modifying the dose of each drug may be different. I know the cost is a very soft and compliance are considerations, but if cost and compliance are not considerations, using two drugs separately and modulating their dose individually sounds to me to be a much more sensible course.
Sir, I totally agree with you, sir.
Sir, if there is no more question, can we wrap up the session?
Yeah, we should not
I
wait.
thank you. I thank you, every one of you. Thank you so much.
Thanks.
Thank you. Thank you all. Thank you, everybody.
Thank you. Bye-bye.
Thank you. Thank you.
Bye.
Thank you, Dr. Manayak. Thank you, Ambrish, for the excellent presentation. Thank you.
Thank you, sir.
Okay, so yes, so my name is Dr. Swapnil Shah. I am from Ahmedabad, and today we are having an interesting session called Injectable Therapy Symposium. Now, as we all practicing as a diabetologist, whenever we come across the patient, we have the first thing, like, when we have to start the patient on any injectable, it is very much like, we got very much resistance from the patient. So till now, it was happening for the insulin. Now we got the GLP-1 agonist as well. So like, I would like to introduce Mr. Pradyuman Sharma, who is the chairperson, and the Dr. Sachin Gupta from Bhopal. And our main the main topic is preventive cardiovascular complications in type 2 diabetes with once a weekly GLP-1 receptor agonist from Dr. Supratik Bhattacharya. So over to you, Dr. Sharma. Thank you. Dr. Bhattacharya, who is the director of the Ascan Diabetes and Endocrine Center in Calcutta, who has published more than 20 international and national publications as the first author, and who also received the Rising Star Award in 2021 with Indian Academy of Diabetes. So I would like to, rather wasting the more time, I would like to ask Dr. Bhattacharya, can you please continue with the session?
Just let me speak a few words about Dr. Bhattacharya. So he would be speaking on with a once weekly GLP-1 receptor agonist. Very important topic, because we all are worried. If you just go back 10 years before, the quality of the drug, oral diabetic drug, what we used to assess just only HbA1c control and blood sugar control. But now we have lot many factors. We want that it should be very safe, cardiac safe. We want to prevent kidneys also, and we know that our diabetic patient, they die up because of cardiac problem. So if this glucose lowering drug is giving a lot of extra glycemic effect, that is weight loss and cardiac and renal benefit, that's a wonderful thing. So a very eminent scholar, Dr. Supratik Bhattacharya from Kolkata, would enlighten us regarding this. Over to Dr. Supratik Bhattacharya.
So much, Dr. Gupta. Thank you, TI, for this kind invitation, and a warm welcome to all of you. I'll take a second to share my screen. Hopefully the screen is visible to all of you.
Yes, yes.
Perfect. So I think the discussion from the morning has been very interesting, and we have been talking about the newer molecules and the reason why we should go beyond just the control of glycemia per se. So today's topic is preventing cardiovascular events in patients with diabetes. And this is my disclaimer that I've been contracted by Eli Lilly for this talk. So the learning objectives would be to highlight the risk of micro as well as macrovascular complications with type 2 diabetes and its correlation with glycemic control. Highlight the cardiovascular risk in patients of type 2 diabetes with cardiovascular risk factors and discuss the possible therapeutic options in that regard, showcasing evidence therein. And discuss the safety of GLP-1 receptor analogs in patients with type 2 diabetes and CKD, with particular reference to once weekly dulaglutide, highlighting the ease of administration of the same from a real-world perspective. So we want to understand how low to go when it comes to eGFR, and there are some interesting data that I'll be showing you during my talk. The risk of micro as well as macrovascular complications in patients with type 2 diabetes. And we are completely aware of the ticking clock hypothesis, and we are aware that the macrovascular clock starts ticking even before the diagnosis of type 2 diabetes, and microvascular complications probably set in after the diagnosis. And clearly, there are increased incidences of both micro as well as macrovascular complications with diabetes. And we are aware of the microvascular complications like retinopathy, nephropathy, and neuropathy, which are higher in incidence in the type 2 diabetic patients. Similarly, 2 to 4-fold rise in cardiovascular mortality and stroke in type 2 diabetic patients. Also, heart disease is responsible for 50 to 80% of the diabetes-related death. Similarly, the peripheral vascular diseases like atherosclerosis in the lower extremities are extremely high, along with amputation rates. We also know that there is a crosstalk between the heart and the kidney, and there is a common soil to both the cardiorenal dysfunction, and that could be the type 2 diabetes, smoking, obesity, hypertension, dyslipidemia, genetic risk factors, and acquired risk factors. So let's look at a case, and this is a prototype of a case and something that walks into your clinic very often. So this is a lady who does not have any prior cardiovascular events like stroke or MI, and has been suffering from diabetes for the past 13 years. And also, she has got several cardiovascular risk factors. Recently, she had experienced a transient ischemic attack, and she's worried whether she's going to have a stroke in future. And if you look at the medical details, she has got type 2 diabetes, hypertension, hyperlipidemia, she's having atrial fibrillation, and of course, we talked about the recent TIA. She was a passive smoker because the late husband used to smoke. And if you look at the current medications, she's on metformin 1 gram, glimepiride 3 milligrams, enalapril 20 mg per day, and atorvastatin. So strong family history of hypertension, and the blood pressure is to control with the anti-blood pressure medications. And also we see that statins have controlled the lipids well, but the HbA1c is still not to control at 7.4. So if you consider the EAC-ASD treatment algorithm, and you look at the risk, so anyone with type 2 diabetes with established cardiovascular disease would be a very high risk candidate. Similarly, anyone with target organ damage, proteinuria, eGFR less than 30 mils, or retinopathy would be a very high risk candidate. Similarly, this particular lady who has got hypertension, she's dyslipidemic, She's got obesity, so more than 3 major risk factors putting her in the very high risk category. So cardiovascular risk in type 2 diabetes and correlation with glycemic control. We know that if you are targeting the glycemia very well from the various landmark trials, whether you're talking about the VADT, ACCORD, etc., we know that targeting hypoglycemia does take care of the microvascular complications, but not so much when it comes to the macrovascular complications. So these are the landmark trials, and clearly, if you are looking at the mortality, you see whether you're looking at all-cause mortality or the cardiovascular death, there seems to be no benefit in treating glycemia very stringently, whether you're looking at ACCORD, whether you're looking at ADVANCE or VADT, and we've been talking about this from the past sessions as well. Probably the only sort of study where we did see some kind of benefit in terms of macrovascular complications was the UKPDS study, but ACCORD, ADVANCE, VADT in general didn't show any benefits in terms of reducing all-cause mortality or even in the terms of reducing the macrovascular complications. The therapeutic options to address the heightened cardiovascular risk in patients with type 2 diabetes and the scope of primary as well as secondary prevention. So these are the previous cardiovascular outcome trials done with GLP-1 receptor analogs, and we are all aware of this. And I just wanted to highlight how REWIND study was very different from the previous cardiovascular outcome trials. You see, the patient recruited was 9,900. The duration of the study was 5.5 years. It's clearly higher as compared to the previous cardiovascular outcome trials. The females in this study were almost 46% as compared to much lower numbers that were recruited in the previous trials. Also, if you look at the baseline HbA1c, it was 7.3, which was much, much lower as compared to the previous cardiovascular outcome trials with the GLP-1 receptor analogs. But the most interesting thing is the pre-existing cardiovascular disease or those with events was only 31.4% as compared to almost 100% or more than say 70 or 80% in the previous GLP-1 receptor analog cardiovascular outcome trials. So why is this interesting? Because this clearly demonstrates the kind of patients that walk into our clinic. So not all of them will be having established cardiovascular disease. So many of them will have the risk factors, but they would not actually have had an event. So this REWIND study was closely simulating our clinical practice. Once weekly Trulicity or dulaglutide significantly reduced the relative 3-point MACE by 12%, despite majority of the patients not having established cardiovascular disease. And you see the benefit starts coming in very early, almost within the first 1 year. And if you keep going, the median follow-up period was 5.4 years, and you see the Kaplan-Meier curves starts diverging from the very first year, but it keeps on diverging thereafter. So the longer you use the molecule, you keep getting the benefits from it. So Trulicity is the first and the only GLP-1 receptor analog to demonstrate both primary and secondary prevention in type 2 diabetes, and I'll tell you why. LIDA was another landmark trial with liraglutide, and clearly when you're looking at the 3-point MACE, the hazard ratio was 0.87, so there was a 30% risk reduction. Now let's break it up into brackets with those who had an established cardiovascular disease and those who had the risk factors but did not have an event. So clearly, liraglutide was superior in those patients who had an established cardiovascular disease, and the hazard ratio was 0.83. But when it came to those who had risk factors but did not have the event, the hazard ratio was 1.2. So clearly, it was not a good agent when it comes to primary prevention. Again, SUSTAIN, another landmark trial with semaglutide, you see hazard ratio was 0.74 for the 3-point MACE. And if you break it up into brackets with those with established cardiovascular disease, the hazard ratio was 0.72. But again, similar to liraglutide, if you look at those who had the risk factors but did not have an event, i.e. for primary prevention, the hazard ratio was 1. So it didn't clearly show any benefits. On the contrary, if you look at REWIND, the hazard ratio for the 3-point MACE was 0.80. And if you break it up, you see that those who had the event, the hazard ratio was 0.87, and those who did not have an event or had only the risk factors, there the hazard ratio was 0.87. So it was equally efficacious whether it's those who had an event before or those who had only the risk factors but did not have an event. So both for primary as well as secondary prevention. So based on this 2019 update to 2018 ADA ESD Conscience Report, to date, the level of evidence to support the use of GLP-1 receptor agonists for primary prevention is strongest for dulaglutide, but lacks for other GLP-1 receptor analogs. Similarly, ADA standards of care says that there was a consistent benefit in dulaglutide trial in patients with and without atherosclerotic cardiovascular disease. Another very interesting data that I wanted to show you here was that the annual placebo MACE rate and the REWILD trial was lowest compared to other cardiovascular outcome trials. And this is probably because of the increased standard of care in the placebo group as compared to the previous cardiovascular outcome trials with the other GLP-1 receptor analogs, and also kind of the population that was recruited. A further HbA1c decline of 0.6 from the baseline, which was quite low to begin with. It was only 7.3, if you remember, and it was observed in the REWIND trial, and that was sustained for 5.4 years. Clear benefits in terms of glycemia. Also, if you look at the body weight, there was a 2.95 kg body weight reduction from the baseline versus 1.49 in the placebo. So at the end of the day, there was a 1.5 kg difference with the placebo, which was significant. If you look at the systolic blood pressure, again, 1.7 millimeter mercury difference with the placebo, and there was a modest increase in the heart rate of about 1.9 beats per minute. Please remember that REWIND was powered only to look into the 3-point composite MACE, and you cannot draw conclusion for the individual MACE endpoints. But yet, in spite of that, you do not see much of heterogeneity when you're looking at the individual endpoints, whether it's the non-fatal MI, non-fatal stroke, or cardiovascular death. So all of them seems to be favoring treatment with dulaglutide. Again, clear superiority compared to placebo when it comes to reduction of the microvascular composite outcomes. And when you're talking about the retinopathy, eye endpoints like anti-VEGF or vitrectomy, or kidney endpoints like new onset macroalbuminuria, or 30% fall in the eGFR for chronic renal replacement therapy, it seems that dulaglutide clearly scores over the placebo. Reduction of the composite renal outcome of the development of macroalbuminuria and sustained 30% greater decline in eGFR with once weekly Trulicity in REWIND trial. So if you're looking at the renal composite, hazard ratio was 0.85, new onset macroalbuminuria, hazard ratio 0.77, significant. Sustained eGFR decline of more than 30%, again, hazard ratio 0.89, and renal replacement therapy requirement, hazard ratio 0.75. To summarize the primary and secondary endpoints outcomes in a REWIND trial, again, to remind you that it was powered enough to look into the composite 3-point MACE, and you cannot really draw conclusions regarding the individual endpoints. So clearly, the hazard ratio was 0.88 for the primary composite, 12% risk reduction, and also you did get benefits in terms of other endpoints as well. So we now also suggest that to reduce the risk of MACE, GLP-1 receptor agonists can also be used in patients with type 2 diabetes without established cardiovascular disease with indicators of high risk. And also most other cardiovascular outcome trials with GLP-1 receptor agonists, other than REWIND, have included a minority of patients with risk factors only, but without evidence of benefit on the MACE outcomes in the lower risk subgroups. Based on that, to date, the level of evidence to support the use of GLP-1 receptor agonists for primary prevention is strongest for dulaglutide, but lacks for the other GLP-1 receptor agonists. Now, let's look at the severe hypoglycemia. So looking at the adverse events, it seems that the severe hypoglycemia in the dulaglutide arm seems to be even lower as compared to the placebo arm. GLP-1 receptor analog in patients with type 2 diabetes with CKD, again, a very interesting finding. And you see that more than 60% of the patients in this award 7 study were in stages CKD 3 and 4. So what we see at the end of the day, if you're comparing with glargine, there was similar A1C decline with better weight loss and lower hypoglycemia as compared to insulin glargine. So 1.5 dulaglutide, if you've seen here, clearly wins over glargine in terms of body weight reduction and also in terms of symptomatic hypoglycemia. And you see clear benefits which were similar with that of U100 glargine. Once weekly Trulicity demonstrated greater reduction in urinary ACR, and we know that urinary ACR or microalbuminuria is an independent risk factor for future cardiovascular events, and lesser decline in the eGFR in type 2 diabetic patients compared to insulin glargine in CKD patients. And this is what we had been talking about. And also, if you look at the eGFR decline from the baseline, that was clearly superior in the dulaglutide arm as compared to the glargine arm. This is the point that we had been talking about. So how low can we go? So now we know that low dose adjustment is required while you using dulaglutide once daily up to an eGFR of 15. So that's something which is very, very useful because you can use your dulaglutide up to the end stage renal disease as well. So treatment choice with once weekly GLP-1 receptor analogs as a first injectable in type 2 diabetic patients, and this we are talking about real world perspectives. Choosing the first injectable while treatment escalation post-OAD failure and failure of oral anti-diabetic treatments, intensification with injectable treatments, and you have 2 options. Either you use insulin or you use GLP-1 receptor analogs with evidence, and you have the short-acting ones or the long-acting ones. If you're using insulin, you have the risk of hypoglycemia, you have the added burden of weight gain, and dose titration is required. And we do not have proven cardiovascular benefits except for the origin study that we had before. And also, probably the DEVOTE study as well. So GLP-1 receptor agonists, low risk of hypoglycemia, weight reduction is there, no dose titration is required for dulaglutide, and you saw you could use that up to eGFR of 15. Proven cardiovascular benefits that has been shown from the REWIND study, LEADER, HARMONY, or SUSTAIN 6 study. And these are the real-world studies that has come in from various centers, both in India and outside India, globally. And this is a study that was done by me, where dulaglutide 1.5 was used in addition to SGLT2 inhibitors, and you could see a robust change in HbA1c, which was clearly reflected in various other studies where the HbA1c reduction was anywhere between 0.5 and 2.2. Similarly, a robust reduction in the body weight, and we saw that the body weight reduction could be anywhere between 2.1 kg up to 6.4 kg, and this was my center. So significantly, you see that higher adherence was noted with dulaglutide as compared to liraglutide, and also the time to index discontinuation was higher. So more adherence was seen with dulaglutide as compared to exenatide. What are the reasons why dulaglutide has got higher adherence as compared to the other GLP-1 receptor analogs? And one of the reasons what you always face during your consult is the first time when you offer your patient asking whether you want to take this injection daily or weekly. Of course, 99% of the time the patient is going to choose weekly dosing. Ready to use pen, there's a pre-attached hidden small needle, and one of the fears that the patients have is regarding pricking themselves, and if there is a visible needle that comes in the way, and if the needle is sort of hidden inside, that is quite beneficial while you are trying to counsel the patient. No need for dose titration to improve GI tolerability at initiation. So it fits in very nicely with somebody who has got difficult lifestyle, does not have a fixed eating pattern, etc. It's very elegant pen and very simple to use. You uncap place and unlock. So go from the red to the green button and press and hold. You hear the first click, wait, and hear the second click, and your injection is delivered. So is the right patient to be on weekly Trulicity? Inadequately controlled patients on multiple OADs and who needs to be started on injectables, who are struggling to get their blood sugar under control, and you see the HbA1c staggering between 8 and 10%. Weight gain is there in the clinic, and the concern is that the BMI is more than 25. And for Asian individuals, I think anything BMI more than 23 would make them overweight. Cardiovascular risk in clinical concern like hypertension, smoking, etc. Looking for a simple therapy which is easy to fit in with their difficult lifestyle, and somebody is motivated to take ownership of their long-term health. What are the key messages that we wanted to deliver today? GLP-1 receptor analogs has been recommended as the first-line therapy after metformin for various benefits, and we now have moved beyond only the glycemic control, and we are talking about the pleiotropic benefits. We're talking about benefits in terms of macrovascular complication reduction. And type 2 diabetes is a complex disease with multiple pathways, including micro and macrovascular risk. Lowering glucose will avoid microvascular complications. We know about that. However, lowering glucose with certain drugs does not actually do much to the macrovascular protection. And that is why you need a molecule like once-weekly dulaglutide, which has shown benefits in terms of say weight reduction, reducing hypoglycemia, and targeting the macrovascular endpoints. Early intensive treatment in type diabetic patients with certain drugs is known to reduce the microvascular complications in short term, and also reduction in macrovascular complications in the long-term follow-up. And GLP-1 receptor analogs has emerged as a preferred drug in patients with type diabetes. For those patients who does not have an event, who are at risk, and even for those patients who had an established cardiovascular disease. So both for primary as well as secondary prevention. Multifactorial approach with once-weekly GLP-1 receptor analogs, and once-weekly Trulicity is the first agent to show CV protection in a population where majority of them had not experienced a cardiovascular event but are at risk. It was highly effective glucose-lowering agent with impact on body weight, with an additional benefit and reduction of cardiovascular events in patients with type 2 diabetes. Once-weekly dulaglutide is a safe option for patients with type 2 diabetes with CKD, and you can keep using it till an eGFR of 15 mils per minute per meter square. So in real world, dulaglutide has shown better adherence and persistence, and also efficacy in terms of HbA1c reduction, body weight reductions. And so it should be the obvious choice when it comes to choosing a molecule or an injectable for diabetic management. So thank you so much for your kind and patient hearing, and back to the chairperson.
Yeah, thanks, Dr. Supratim, for lucid presentation. It's a wonderful novel drug, and maybe we'll discuss about the drug later on. We'll have question later on, because in injectable therapy we have one more speaker, and over to Dr. Pradyum Sharma to introduce next speaker.
Good afternoon. So after a wonderful deliberation, one has to be very proactive, as what Dr. said, and once weekly preparation. Now let's have a Dr. K.K. Gangopadhyay. Let's have his biodata over the screen. I'm not having his biodata on screen. Dr. K.K. Gangopadhyay. Yeah. So he's a very known figure. I have witnessed him many times, and it's my privilege to introduce him this time. So Dr. K.K. Gangopadhyay is a renowned endocrinologist, has practiced extensively in India and abroad. After finishing his MD in medicine in India, Gangopadhyay went to complete his MRCP from London CCST Diabetes and Endocrinology. Worked 12 years in UK. The last 2 years, he is a consultant diabetes in Birmingham. He has won many awards in UK for papers, presentations, Owen Wade Prize, Stephen Whiteacre Prize, Newsay Prize, Society of Endocrinology Prize. He has published more than 40 papers in international journals like BMJ, Lancet, Endocrinology, Clinical Endocrinology, and Clinical Medicine. He has been investigated in multiple international trials. He has been Scientific Secretary of Diabetes India and IDCON. He has been overseas invited speaker to to the several countries, including Malaysia, Indonesia, Thailand, and Qatar. So over to KK Gangopadhyay. The topic is insulin initiation.
Thank you very much, sir, for your kind introduction. I hope my slides are visible.
Yes.
Yeah, and I'm audible. Okay. So these are my disclaimers, conflict of interest, and these are my disclosures. Okay. So now, today I'm going to talk about premix insulin or insulin initiation and intensification. Now, this actually might be very boring for many of you who actually routinely use insulin. But I'll add a little bit of my take on it, which might be different from what is there in the slides. Now, the relative contribution of PP sugar varies between Indians and Caucasians. And this interesting slide shows this is the Indian population, this is the fasting PP, and this is the fasting PP of the Caucasian population. So if you look at the HbA1c here, look at the fasting and PP of the Caucasian and look at the Indian. Now I'm going to increase the HbA1c. Now you look at the fasting and PP of the Caucasian and look at the fasting and PP of the Indian population. So this clearly shows that for a given HbA1c, we are completely different than our Western counterparts. And it's not necessary that the guidelines which are there made in the Western part of the world should apply to us. It's not necessary that it should apply to us. Now, the guidelines and recommendations, therefore, if you look at the ADA and the Canadian Diabetes Association, they recommend basal insulin alone for initiation. NICE has a choice, basal and premix, whereas the RSSDI, Australian guideline, Malaysian guideline, they recommend choice of any. It is very important, ladies and gentlemen, to understand one thing. Any insulin will reduce the blood sugar. Full stop. Any insulin will reduce it. So no matter if a patient needs insulin, first thing is start it. Debate will come later on, which is better, which has got less hypoglycemia, weight gain, etc. Any insulin will reduce the blood sugar. Then the next question comes, which insulin are you comfortable with initiating? Which insulin would the patient be comfortable with initiating? These are the questions to be asked. And I will come to that in a minute. So these are the pros and cons of premixed insulin. So I would start with the cons first, or the downside. So there might be slightly more chance of daytime hypoglycemia. It is particularly if we are giving twice a day premix, one in breakfast, one at dinner time, and the patient is actually taking small breakfast and having heavy lunch. So they will have hypoglycemia pre-lunch. It is so much crucial to take a dietary history and so crucial to tell the patients to take their meals on time. This, I do not necessarily agree that there is more weight gain, and if at all, it is marginal. This, yes, just like I said, you may miss out the post-lunch glucose excursion if you are not targeting the lunch glucose, and if the patient in particular takes a heavy lunch and has got very light breakfast. But the advantages are you may start with one injection a day. Several trials which showed that if you start with one and then increase it 2 and increase 3 injections, the HbA1c drops further. And it is possible to have with just, there was a Garber 1, 2, 3 trial as well, which showed that even with one premix insulin, 40 to 50% of the patients can achieve their target HbA1c. So the most important thing going on from the previous slide, that this targets both fasting and PP, which the basal alone may not be able to satisfy. And you have the option to intensify the same insulin, which the difficulty you have with basal, that you can't intensify with the same insulin. However, I will go back again, ladies and gentlemen. Again, I will say that I feel, this is my personal opinion, that if a doctor is not used to starting insulin at all, for that particular person, I think basal insulin will be much easier to start. It's very easy to start, very easy to monitor, particularly in this telemedicine era, in the pandemic. It is very easy to explain to the patients as well. Because as I said, if a patient needs insulin, please start it. Now, for those who are acclimatized to starting insulin, those who have been using the basal insulins anyway, for them, I think it is time to consider whether the premix insulin will suit the patients better, because the PP surge is more, and because we may have a better glycemic control by controlling the PP. So what do the Indian physicians state? This is one study where Indian physicians, where they prefer a premix once a day, premix twice a day, basal plus or basal bolus. And we can see here for adults in general, the Indian physicians would use, majority of them would use a premix twice a day. For elderly who have got normal activities of daily living, premix twice a day. But for the frail elderly, and rightly so, the basal comes up, because you want a simplified regime, and the tight blood sugar control is not desired. But here we desire a tighter blood sugar control with better PP sugar. Now, which insulin to choose? So these are the glycemic factors, and I will not say that it is backed up by great amount of scientific data, but it's a just rough guide. So if the postprandial increment, so from baseline to postprandial, if the rise is more than 54, you need a bolus component, which will be there in the premix insulin. If the fasting sugar to HbA1c ratio is less than 20, so suppose your HbA1c is say 10, and your fasting sugar is say 160, then it will be less than 20. That means PP is contributing to your glycemic deterioration. So therefore, premix insulin might be one to consider. Now, take this with a pinch of salt. The next line, difference between bedtime and morning glucose. This is the published data, actually, this one, where the value, if it is more than 55 between bedtime and morning data or morning insulin, that means that you need a bolus insulin at the dinner time, because the dinner insulin is the problem, and basal won't sort it. But this has got a lot of difficulties, you see, because our bedtime, our dinner time is different from the Caucasian world. They take dinner at 7 o'clock. We take at 10:30, 11 o'clock, and we go to bed straight away. So we'll take a dinner at 10:30, tell the patient to check their PP sugar at 12:30. It won't happen. So it's practically, it's very difficult to do, but these are easier to do. So again, patient difficulty in understanding, then we may have to balance which one to give, premix or the basal. If you need tighter control, more better PP control, definitely the premix is there. And of course, high carbohydrate diet will dictate that premix might be the better one. So if I give you a case, diabetic for 12 years, so I'll just highlight the important issues. So HbA1c 9.1, fasting 170, PP 275, and BMI is 25.5. Now, ladies and gentlemen, I'm slowly making this a habit that when I see the results, I see the blood glucose last, because that sends the wrong message to the patients. They think blood sugar is everything. No, blood pressure is, and cholesterol, lipid profile is perhaps more important than the blood sugar in controlling cardiovascular mortality and morbidity. So what I say, what is your blood pressure today? Oh, 130/90. Let me look at your lipid profile. Oh, it is very high. So first we target this, so the patient understands that, okay, sugar is there, but he is thinking about these two first before we go into blood sugar. And that is very crucial, and we should drive home this message to all our juniors. That is what I feel. Otherwise, the blood pressure, blood sugar, and the lifestyle changes come last and is ignored. So nevertheless, today I'm going to talk about the sugar bit. So there is about more than 100 post-manual increment in HbA1c is 9.1. So ratio between fasting and HbA1c is less than 20. So this patient is on glimepiride, near maximal dose, full dose of DPP4, full dose of metformin. Patient is on atorvastatin 20, still the LDL is 165. 9.9 times out of 10, she's not taking it. That is the commonest cause, and that is the reason why we should look at the LDL first. She has got coronary artery disease. She has a family history of coronary artery disease. So she has a history of urinary tract infection 6 months back. So that was perhaps put, this is not my patient, that's what's perhaps put in to deter us from using an SGLT2 inhibitor. So 9.1%, we want to get it down to 7%. One drug ain't going to get it down to 7% if you want to use drugs other than insulin. If you want to use drugs other than insulin, add another OAD, add premix, add GLP-1 or a basal. So these are the treatment modifications. Now I go back here. So if you want to add a drug, say SGLT2 inhibitor, so what are the contraindications? Recurrent UTI, having more than 3 UTIs in a 1 year, that's a strong contraindication for SGLT2 inhibitors. Otherwise, she is actually technically overweight and might benefit. But the SGLT2 inhibitor will get it down by, say, 0.6% at the most, or 0.7%. Not going to achieve it. GLP-1, stopping this sitagliptin, yes. But if you stop the sitagliptin and add a GLP-1, you would get at the most 1% drop in HbA1c. Still, you will not get it close to target. So you don't have any option. You have to start a insulin, whether it be basal or premix, but a insulin has to be started. So now, so basal insulin, if elevated fasting sugar, if you have mealtime insulin, if the PP is high, premix insulin, if you have got both fasting and PP, which is raised, and HbA1c is more than 9%. Why? So the higher the HbA1c, we would like to assume that the PP component will be higher, and therefore the PP might be contributing in our country from what I had shown you. So therefore the premix might be a better choice. So again, favors premix, favors basal. What is the post-manual increment? More than 54, favors premix. Less than 18, favors basal. Is the patient likely to manage basal bolus? No, when intensification is needed. If they can manage basal bolus 4 times, basal insulin might be a good option. If they can't, then premix. Is there a large carbohydrate intake at 1 or 2 meals? Then premix automatically becomes a better option, particularly if you're using once a day premix and patient has a large lunch, use it at lunch. And if they have got large breakfast and dinner, which is most of our working population, then you can use twice a day. So this is the Humalog mix 25 twice a day versus glargine. However, ladies and gentlemen, a basal symposium will show you similar data with different, similar studies with different outcome. So we have to take everything in context. Now, this is a Humalog mix 25 compared with glargine. So this is glargine. You can see the drop in HbA1c, which seems to be slightly more with the Humalog mix 25. Higher percentage of patients achieved target the HbA1c values with the Humalog mix 25 as opposed to the glargine. The overall hypoglycemia was less with the basal insulin, but it was statistically significant. But the nocturnal hypoglycemia was numerically more with the basal insulin. It is a no-brainer. And I think this bit, extra bit, we can sort it by taking a proper diet history and instructing the patients about the diet. So the durability, so the premix insulin seems to last, the HbA1c at goal seems to last longer than the basal insulin. And the hypoglycemia rate, you can see here, which I've just showed you, the p-value is all not significant. So it's similar for both of them otherwise. So the patient was started on once a day Lispro mix 25, 10 units, and then it was increased. and a dinner insulin was also added and stabilized on 22 and 16 with an HbA1c of 7.3. Now, so overview, you get better fasting drop with basal insulin, better PP drop with the premix insulin. The HbA1c drop might be the same in many cases, but if the postprandial component is the major contributor, then you'll get a slightly better HbA1c. The hypoglycemia rate, more diurnal here, more nocturnal here. Convenience of initiation, I'm glad that there are 2 ticks here, which I agree. It might be slightly more convenient at initiation, particularly in this teleconsultation era. So insulin intensification, I realize I've got 3.5–4 minutes left. So this is another lady, 71 years old, liraglutide and metformin and premix 24 and 14. And you can see here the postprandial peaks have not been addressed really, but it comes quickly down. The pre-meal comes quickly down. So you need clearly mix 25, you would probably replace by mix 50 because that will get the postprandial down better without reducing the pre-meal further. 8.9%, so needs intensification of the insulin. So what would you do? So add a 3rd injection, switch to premix twice and premix 50-50 twice and premix 25 at dinner, or go to full basal bolus. Basal bolus is the most physiological insulin and should be given for every type 1 diabetes, full stop. But for type 2 diabetes, because the patients just won't take the 4 injections, that's why we have to settle for less intensive regimes. So here you have got a Lispro mix 50 twice and premix at bedtime. As compared to basal bolus, it seems to do the trick with a similar HbA1c drop and similar number of patients achieving the target HbA1c. And again, similar hypoglycemia. So premix intensification favors premix. If the patient prefers fewer injections, obviously premix. Less frequent monitoring, I don't agree. I think for both of them, you have to check it 3 times. Patient ability to inject, poor, well, then it will not inject anything. But you need a bit more cognitive ability for basal bolus injection. So this patient was switched to Lispomix 50 twice a day before breakfast and lunch, and Lispomix 25 before dinner. And the dose was titrated, and at the end of 3 months, very happy story. Mind you, these cases are not mine. This is just a hypothetical case. So in summary, postprandial sugar in Indian population is more important than the Caucasian, and it's higher at higher HbA1cs. And premix insulins are simple to start, but so is basal insulin. In many cases might be even simpler to start basal insulin in this teleconsultation age. So patients uncontrolled on 2 or more AD drugs would be started on, can be started on premix insulin, and you can intensify, and that's the advantage, I think. You can intensify with the same pen, whereas for the basal, you need another pen because you want to add a bolus insulin. And you can do 3 times premix insulin. There's plenty of data with that. So with that, I end. Thank you very much.
Thank you very much, Dr. Gama. That's a beautiful placing. But rather, what of the lecture delivers, still we are much in a dilemma to start the premix in 3 times, because they have been certain time overlapping, and timing the meal is very difficult. And amount of the meal, whether you are taking 1 chapati or 3 chapati, makes a hell of a difference. Anyway, there's a time for the discussions, and I believe there's a one question. So, what is your take of using different definitions of CV disease across leader, sustain, and rewind? Why CKD and HF were excluded from CV disease definition rewind trial? Glycemic equipoise not achieved as HbA1c difference between placebo and dulaglutide. Addressed to Dr. Sukrit Bhattacharya. So let's have the expert comment from Dr. Bhattacharya.
Okay, I think there are multiple components to it. So first of all, like You will have the 3-point MACE, that is the common component when you're talking about the cardiovascular outcome trials. There might be minor differences that they bring in at times. The population recruited also will be very different from one trial to other. So we can't have a direct comparison between the trials. So that'd be very, very difficult. So I think that was the first part of the question. Why CKD and heart failure were excluded from cardiovascular disease definition in REWIND trial. So as we said, we have the primary endpoints. So when you're looking at the cardiovascular outcome trials, you have the primary endpoints and you have the secondary endpoints, as with even, for example, GLP-1 receptor analogs or SGLT2 inhibitors, etc. So this particular trial is powered enough to look into the 3-point composite of the MACE outcomes. So we cannot comment on the heart failure from this cardiovascular outcome trials. So because that would not be part of the primary composite itself. Glycemic equipoise not achieved as HbA1c difference between placebo and dulaglutide. So this is not sort of a treat to target study. It's a cardiovascular outcome trial. It's an event-driven trial, and we do notice differences in the placebo as well as the treatment arm when it comes to the glycemic endpoints as well. But the one thing that we had to notice was in the other cardiovascular outcome trials, clearly the baseline HbA1c was much higher as compared to that in the REWIND trial, where the baseline HbA1c was only 7.3. But in spite of that, we did see there was a 0.6% drop in the HbA1c, which was significant as compared to the comparator.
Thank you very much. As we are running late, so we can have only one question. I can address to Dr. K.K. Gamopadhyay because putting 3 premix insulin with the time in range and time above range, do have some analysis with this, with the CGM trials?
Yes, well, I think I agree with you, Dr. Sharma. I'm not a great fan of thrice a day premix really, because I still feel that physiologically I find it difficult to explain that. I would rather have a twice daily premix and a lunchtime rapid insulin. That will be more physiological. That's what I feel. So for the CGMS data, yes, there is, but there are not big studies. There are very small studies which suggest that your time in range seems to improve. If somebody is not well controlled on twice a day premix, we have to seriously look at basal bolus regime for that particular person, or you add a basal insulin at lunchtime. If you feel the patient is going to get confused with 2 pens a day, then of course you have no option but to fall back on thrice a day premix. But thrice a day premix has got data. You have got data with Humalog premix. You have got data with Garber 123, which has got Aspart premix as well. So you have got data, but it is a matter of personal choice. And I feel physiologically, twice daily premix and 1 daily bolus is much more physiological.
Beautiful, beautiful. So sincere thanks to honorable speakers. And because as we are running late, we have been asked to conclude the session. So my sincere thanks to Dr. Bansi Sabu and to all the speakers, and a wonderful presentation and great Diabetes India. Wonderful. Thank you, sir. Thank you very much.
Dr. Bansi Sabu, thank you.
Hello to Dr. Jetwani, Bansi, and Dr. Chawla.
Cheers. Good to see you.
Thank you, Kalyan. Thank you, Supratik. Thanks, Pradyuman Sharma. Thank you, Sachin, Pratap. Now we can take the next session.
To all the speakers, chairpersons, and the rapporteur for excellent session on injectable therapy. Now we will move on to the next session, and that is related to diabetes and kidney. And I will invite Dr. Maulik Kinariwala, if he's there from Ahmedabad, to carry on with the proceedings of this session. Dr. Maulik. I think he's not there, so I will straightway invite our chairpersons, Dr. Munish Prabhakar, who is involved with.
Eta kon bed number?
Hello.
ঠিক আছে.
So I will invite chairpersons for the next session, Dr. Sefali Kharkanis from the Mumbai, the leading diabetologist, and Dr. Munish Prabhakar, physician cum diabetologist from Haryana, to take over with the proceedings of next session, that is diabetes and kidney. Over to you, chairpersons. Dr. Sefali, please unmute yourself, Sefali.
Sorry. Thank you very much, Dr. Jithmani. Dr. Banshi Sabu and Team Diabetes India, I really congratulate you all for this wonderful academic feast that we've been relishing the past weekend. We move on to the session of diabetes and kidney. Diabetes and kidney is one of the most common cause of ESRD in the world, and it's just going to rise exponentially with, especially with the advent of post-COVID aftermath. To kickstart this session, I invite our first speaker, Dr. Rajiv Chawla, who's going to talk about CKD equivalent to high risk, CV risk. This is a single disease spectrum. Dr. Rajiv Chawla needs no introduction. He's been a DNB teacher, a guide, and a mentor for the past 20 years. He has more than 85 papers on micro and macrovascular complications. He's authored several books on diabetes. He has about 10 oration awards. He is the past chairman of RSSDI Delhi chapter. He's the past secretary of RSSDI National Board. He has been the organizing secretary for RSSDI 2006. And he is the president of DIPSI 2019. He is an executive editor and scientific chair for many of the leading journals of India, as well as many of the international forums. So over to you, Dr. Chawla.
Thank you, Dr. Shefali, for all those kind words. At the outset, I'm extremely thankful to my very, very close friend, Dr. Arvind and Dr. Bansi. Both are like brothers, for giving me this opportunity to be part of this very, very prestigious conference. And most important thing is that being with two legends in the field of nephrology, Professor Gru and Professor Tripathi, I think it's a huge privilege for me. Task assigned to me is whether CKD is equivalent to high CV risk and whether it is a single disease spectrum. So what I'll be doing is that I'll be doing the conceptual part, because after this, Professor Tripathi and Professor Gru are going to take you through what to do to check this progression of cardiorenal continuum and how we can prevent not only CKD but also subsequent CV outcomes in high CV outcomes in these patients. So I'll be doing the conceptual part, and I'll start with the basic definition of kidney disease. We know chronic kidney disease is abnormalities of kidney structure or function for more than 3 months with its implications. We know diabetic kidney disease, we say when disease is specific to diabetes, with primarily diagnosis being based on presence of albuminuria, which is one of the core component. And of course, diabetic nephropathy, when we know the kidney disease is caused by diabetes, a kidney biopsy may be helpful for a definite diagnosis. But mind it, the terms DKD and DN are often used interchangeably. Both ultimately lead on to chronic kidney disease. So I'll be referring it to only as CKD. 2013, KDO classification said that we can stage CKD based on eGFR as well as on basis of albuminuria. And what it said that G1, which is a normal eGFR category with normal or high eGFR more than 90. G2 is when there is a little decrease in eGFR, it is between 60 to 90. G3A and 3B are important because there is going to be a mild to moderate reduction in eGFR by almost 45 to 60 and 30 to 45. Of course, G4 are when there is a severe reduction in eGFR, and G5 is end-stage renal disease with eGFR being less than 15. Similarly, based on albuminuria criteria, category A1 is when you have a normal or mildly increased albuminuria, only less than 30 milligram per gram. And when you have moderate increase, 30 to 300 milligram per gram of creatinine, it is A2. And if it is obviously more than 300 milligram, which is a gross proteinuria, we refer it to as A3 category. Why this categorization is important? Because moment we know that you are falling in the category of G3A, 3B, 4B or albuminuria category A2 and A3, there is going to be a progression of CKD, and it is going to have poorer prognosis. So if you are anything between G1 to G2 with a normal albuminuria, you are falling in the category of green box. That means you have a normal outcome and it may not progress at all. But moment there is a reduction in EGFR and falling in the range of G3A, 3B, especially with proteinuria, either mild or moderate or severe proteinuria, then there is going to be a increase in CKD progression, and it is going to carry a very, very poor prognosis. We all know that it is primarily diabetes, which is one of the most common cause for progression to end-stage kidney disease. Almost 40% of these patients, they tend to be diabetic before they have end-stage renal disease. One of the studies from US said that 50% of patients ending up with hemodialysis are diabetic. Well, diabetic kidney disease occurs as a consequence of multiple pathogenic mechanisms, although we usually blame it to hyperglycemia, but believe me, it is probably much more than hyperglycemia and many more contributors towards CKD progression. Even if you compare South Asian versus Caucasian, there is a very high predisposition for CKD in South Asians. It is almost fourfold higher as compared to Caucasian in terms of developing albuminuria. Not only that, there is a higher prevalence of advanced CKD. Stage 4 and 5 are very, very common in Asian patients. And possibly, well, there are multiple genetically predisposing mechanisms. It could be a defect in RAS, inflammatory pathways, cytokines, dopamine, rage, oxidative stress, and many more pathways contributing towards progression of CKD in these patients. But definitely, moment you have markers of DKD, which is, as I said, declining EGFR with worsening of albuminuria, it is going to be associated with increased mortality, increased renal events, increased CV events. Even CV death will go much higher, and there could be an impaired cognition also moment you have advanced or decade in these patients. We know that risk of even renal events increases moment you have this increase in albuminuria or reduction in EGFR. So anytime your EGFR goes less than 90 towards 60 ml, or you have albuminuria going towards gross proteinuria, there is going to be increase in events of overall renal components, or renal composite endpoints are also going to be increased. Another US population-based study on 15,000 patients concluded that progression of DKD is associated with increased mortality. So if you have only diabetes, fortunately mortality is not very, very high. Moment you have simply an albuminuria present, or you have a reduction in EGFR, or both reduction in EGFR to less than 60 ml and albuminuria may be moderate or severe or gross proteinuria, almost there is a 10 times increase in overall CV risk or cardiovascular mortality. So diabetes has a very, very dynamic relationship. It is something like heart failure and renal failure, and these are or sort of worsening each other. What is these days we say a cardio-renal or renal-cardial continuum in the setting of type 2 diabetes. It's a very, very dynamic relationship with persistent hyperglycemia. Not only you have oxidative stress, which induces inflammation and then leads on to cellular apoptosis, which then leads on to gradual nephron loss, setting in stage for renal failure. And similarly, there is also going to be a cardiomyocyte loss leading on to rampant heart failure or a manifest heart failure in these patients. But believe me, there are three major mechanisms which underlie the cardiorenal syndrome with the hemodynamic component. The first one, which is going to be extremely important, and actually it is the hemodynamic mechanism or the component which drive the connection between heart failure and CKD. It could be in the form of a fluid overload and retention of salt and water. It could be renal and cardiac congestion, what we normally say renal venous hypertension, which then leads on to a forward failure, a limited organ perfusion, a peripheral resistance, which then leads on to increase in vasoconstriction, and which then worsens heart failure also. But there could be neurohormonal mechanism like activation of RAS system or an overactivation of sympathetic nervous system in the presence of persistent heart failure, in the presence of persistent hyperglycemia, or it could be CKD associated mechanism like chronic inflammation in CKD with activation of cellular immunity. It could be malnutrition, cachexia, wasting, or bone mineral disorder, or acid-base metabolic disorder also contributing towards progression of both cardiorenal continuum. So if you want to check the progression of cardiorenal continuum, even protecting the kidney may protect the heart, and vice versa. It is true for both. We know kidney already has hypoperfusion. There is a ongoing apoptosis or necrosis or fibrosis or glomerulosclerosis. And I told you there is an overactivation of RAS system with sodium and water retention and huge amount of vasoconstriction which is there. So there are going to be compensatory mechanism to restore cardiac output in the form of increased venous pressure, what I said, renovenous hypertension, or sympathetic nervous system with natriuresis. And we know there is a very close and specific association between cardiac and renal physiology. So if you revise your basic fundamentals of physiology, you will remember that moment there is a decrease in cardiac output, there is going to be a reduction in renal blood flow. So overall EGFR is going to be down. Initially, there could be a reduction in albuminuria, but with progression of CKD in these patients, there is going to be a further decrease in renal function. A sodium water retention is going to happen, which will then lead on to decreased cardiac performance and will worsen chronic heart failure. So it seems to be a dual dynamic relationship between worsening of heart failure, worsening CKD, and similarly onset of CKD also leading on to worsening of chronic heart failure in these patients. So it is not only CKD which increases the risk of CV events, but mind it, even the CV events, I'll be alluding to that, even CV events, they increase the risk of incident CKD in these patients with type 2 diabetes, especially with persistent hyperglycemia. So it's a cardiorenal continuum, which is an ongoing phenomena. Not only there is a risk of CVD and CV mortality, which increases with progression of CKD through mechanism like atherosclerotic cardiovascular event like CAD or ischemic stroke or PAD. In later stages of CKD, actually, it is a non-atherosclerotic risk which also dominates, which could be manifesting as LVH. It could be like arrhythmias. It could be a sudden cardiac death or arterial calcification or hemorrhagic strokes. So together, these contribute towards very high cardiovascular risk or mortality. So declining EGFR itself is a very strong risk factor for CV death and all-cause death. So if you follow these patient, moment your eGFR starts coming down from 90 and it goes towards 60 or 45, not only there is going to be an increase in all-cause mortality with onset of CKD, but even overall cardiovascular mortality is also going to be high. And it's a very wonderful data on almost 3 lakh patients who are non-hypertensive. And good thing is that they have already removed all the confounding factors or that bias because of hyperglycemia, maybe dyslipidemia because of BMI, albuminuria, other things have already been accounted for. So alone reduction in EGFR will lead on to higher CV death and all-cause death also. Not only that, even persistent albuminuria, I told you, moment there is an increase in albuminuria from 30 to 300 milligram, there is going to be an increase in all-cause mortality as well as higher cardiovascular mortality. Again, what was seen in almost 3.5 lakhs non-hypertensive patient after accounting for another or previous confounding factor. So impaired renal function possibly is itself a strong predictor of mortality, and then it could be even higher than presence of a previous episode of MI. Someone who has already had an episode of MI or acute coronary syndrome, we know they are at a very high risk for having a second episode. But believe me that a reduction in EGFR is even stronger. Moment you have EGFR close to 45, there is almost double risk of getting a second episode of MI, which is much more than having a history of MI in the past. So the presence of CKD is commonly associated with development of fatal CV morbidities. And this is what we normally say, that older patients with CKD are almost 6 times more likely to die of CV diseases than to advancement of end-stage renal disease or dialysis. This is what we tell our DNB students also, that a patient of CKD or end-stage renal disease will possibly die of a CV death than actually dying of any cause related to renal death or renal composite endpoints. So not only that, even increasing albumin creatinine ratio and declining EGFR not only increases CV death also, it increases the risk of heart failure also. So moment there is a reduction in EGFR and increase in albuminuria towards macroalbuminuria, there is going to be increase in 3-point MACE components. That is how all CV outcomes have shown that those patients who have presence of CKD, their 3-point MACE outcomes are much higher as compared to someone who has a normal EGFR. And it is the CKD which is the most important risk factor for CVD, because if you see the study which has concluded that CVD prevalence in patient with and without CKD, you could see. So whether you are talking of CAD, heart failure risk, PAD risk, or atrial fibrillation, or CVA, or stroke, or acute MI, moment you have presence of CKD, this becomes the dominant factor as a predictor of overall CVD and outcomes. So majority of CKD patient will die actually before progressing to end-stage renal disease or maybe requiring hemodialysis. So if you follow this patient for 5 years, you will see that 33% patient will actually die of CV death, and it is only 12% patient who will require hemodialysis and they go towards end-stage renal disease. Not only that, risk of mortality is also possibly related amongst these patients, that it is the even in the CKD patient, it is the CVD death which is much more important than the getting the risk of cancer or other infection in CKD patients. Not only that, even the risk of heart failure is also, as I already said, other than CV death, which also correlates with declining renal function. So moment you have onset of microalbuminuria and going towards macroalbuminuria with reduced ejection fraction in these patients, you have onset of heart failure also. And most of the time these patients have reduced ejection fraction type of heart failure. Not only that, even CV death is also related to reduction in EGFR. So moment there is a reduction in EGFR, the probability of survival is going to go down in these patients. Contrary to that, again, it has been seen that CKD is a greater risk for heart failure compared with CVD. And it is, as I said, it is a reduced ejection fraction failure, which is much more prevalent in these patients of heart failure in CKD, which is much higher than the preserved heart failure. Conversely, even heart failure, it is not only the presence of CKD which is worsening CV death or risk of heart failure or 3-point MACE, but even presence of heart failure. That is why in the beginning I said it's a dynamic dual relationship between cardiorenal continuum in the setting of type 2 diabetes, because heart failure itself increases the risk of incident CKD of and further declining of renal function. So moment you have heart failure, the overall decline in EGFR is going to be much rapid as compared to someone who is not having heart failure, and these patients are obviously going to have much higher mortality. So it was very rightly said that chronic kidney disease could be a coronary disease equivalent, and a very good study which is a comparison with diabetes over a decade time, and again it was seen that the presence of CKD has hazard ratio 3.7, almost 2 to 3 times higher than having alone diabetes or than having a prevalent coronary artery disease in this patient. So moment you have CKD, it is going to be associated with the risk of death similar to that of established coronary artery disease, and it is much higher than that of alone diabetes if you don't have CKD or you don't have CAD. So moment you have CKD, you are even worse placed than having a coronary artery disease in the setting of type 2 diabetes. Just concluding, the risk of coronary events in people with chronic disease has been compared with those without diabetes, and it is a wonderful population level cohort, large study with 12 lakhs patients who have been included in this analysis. And again, it was seen the patients who had diabetes with CKD, they were at a much greater risk for myocardial infarction or all-cause mortality. So this study concluded that chronic kidney disease could be added as one of the most important criteria for defining people at the highest risk for CV death or long-term cardiovascular mortality. So kidney disease today is taken as a risk factor for development of cardiovascular disease, and this task force recommended by AHA that patients with CKD should be considered at a higher risk for subsequent CVD events, and they should be managed accordingly. So if you today are talking of a cardiorenal continuum with a common soil hypothesis for not only development of hypertension, type 2 diabetes, rampant atherosclerosis, onset of heart failure, we know which happens almost within 5 years in 60% of patients, whether a manifest or a non-manifest heart failure with progression of atherosclerosis and LVH. Not only these patients are at a greater risk for developing heart failure, and we know microvascular complications which follow a linear course in terms of progression over the time, and we are at a greater risk for developing diabetic nephropathy. But our own publication, which I am not showing you, said that micro and macrovascular complication seems to be a continuum. This got published in IGM 2016. That time we hypothesized that it is micro and macro which is a continuum, and today's I'm very happy it is getting true with huge amount of evidence coming that it should be viewed upon as a cardiorenal continuum. And if you want to break this, we have to intervene early. I'm not going to talk about how to intervene at what stage we are going to intervene, because that Dr. Tripathi and Dr. Groove will take over. Thanks a lot for your patience is listening, and towards the end we can have some discussion. Thank you very much. I'll stop sharing here and listen to Professor Tripathi.
Thank you so much, sir, for a wonderful, absolutely a wonderful talk. I think you've made it that having a microalbuminuria, macroalbuminuria, or any kind of is definitely a CV risk equivalent, and we have to be we have to see if regression of CKD can actually benefit the patient, and how can we regress the CKD, and whether halting the progression is an option. So I invite Dr. Kamlaka Tripathi to take over the next session.
Thank you. Can I share my slide?
Dr. Tripathi, I welcome you. Dr. Tripathi is a well-known professor, and he's been a mentor to many of the students all over the world. And he's going to talk about halting the progression of chronic kidney disease, whether it's a myth or a reality.
Thank you, Dr. Banshi. Is my slide is visible?
Yes.
Yes.
Thank you very much, Banshi, for giving us opportunity, and then thanks to Rajiv putting a very good background and creating a solid foundation. What we are going to talk today about halting progression of chronic kidney disease, which is a myth or a reality. Most of the work already he discussed. The myths have been that kidney disease is rare. It's not true. It is 9th leading cause of death in the US. Another myth is there is nothing you can do about getting kidney disease. Most cases of kidney disease could be prevented, and that was the purpose of today's presentation. Another myth is you would know if you had a kidney disease. Certainly, yes, there are certain markers. Though initial part, there are no symptoms. Dialysis is a cure. No, it's not a cure. It's another replacement therapy for the time being till you get your another transplant. And kidney stones causes disease. It is, but then it is reversible, and it can do a permanent damage, and you need to treat and know the etiology of the disease. One of the reasons why it takes a little longer time is because of the progressive nature. Stage 1, there would be patient would be absolutely normal, may not know about it. Stage 2 onward, it's the blood pressure and the protein in the urine which makes him aware. It's anemia, bone disease later on, and fatigue, vomiting, which makes him sick, and only then he visits to a doctor. So there is no cure. Certainly there is no cure, but then at the normal function, it's only the awareness. Stage 2, between the 60 89, that's the time when patient comes with the blood pressure, control of diabetes, weight loss. Stage 3, there's a moderate decrease. But GFR starts now, and this is the time when patient would be accidentally discovered having creatinine high, lower blood pressure. We need to control the diabetes. We need to look at the fluid restriction, prevent malnutrition and uremia. Stage 4, disease is severe. Now patient goes to clinician. Now patient goes to doctor, cares about his symptoms. Stage 5 is now when we need a replacement therapy in different form. What are the risk factors which can stop the progression and halt it? You cannot do with modified factors like age, male, oligonephronia. I think Raju did talk about the how many number of nephron you are born with. If you are born with the little nephron, this is the Bricker's intact nephron hypothesis, and Brenner's hypothesis, how many nephron working you have. And if you have a less number of nephron, you are likely to develop insult much quickly. Hereditary factorial Port's disease, many other. What are modifiable condition? And everybody has been talking since this morning: diabetes, blood pressure, autoimmune disease, inflammatory condition, infections, urinary tract, obstructive neuropathy, drugs, and the diet, smoking, and obesity. The tubular interstitial versus glomerular disease. Tubular interstitial present more as the incapacitation in the form of edema. The patient could have a metabolic disease, could have a thyroid dysfunction, could be a calcium dysfunction. Glomerular disease make you visit doctor early because of the hypertension, massive sodium and water retention, blood pressure, proteinuria, intraglomerular hemodynamic factors, and diabetes. This has been there since 1993, and we knew that microvascular complication can be stopped with a very good control of diabetes in type 1 diabetes patient. But we also understand now that the earlier referral to the patient and look at the serum creatinine value and look at the demonstration of slow CKD progression would make person to get the diagnosis and intervention early from the baseline to the steady cohort. Diet has been now become very popular, and if you look at the Google, you would get so many articles, but the key question remains always about the alkali intake, decreased sodium intake, decreased potassium intake, and decreased oxygen intake. All these could lead to, and there are different papers available, but what is important to know is that the non-vegetarian diet adds to more urea turnover and the creatinine turnover. So there are all now indication consuming protein less than 0.8 gram per kg body weight in an established patient of the CKD stage 2 is going to halt the progression. And this is the recommendation. This is a busy slide. I would like you to concentrate on this energy 25 to 35 kilo per calorie per kg and look at the sodium consumption. And ultimately, when patient reaches to chronic kidney disease, in the field of replacement therapy like hemodialysis, peritoneal dialysis, one becomes little liberal in food because appetite becomes better with hemodialysis, maintenance hemodialysis. Phosphorus should be reduced. Calcium should be less than 2 grams per day, and then fluid should be restricted according to the diet. This I was talking to you about the alkali, and then look at the looking at the albumin creatinine excretion, and when you do dietary acid control, then it also decreases your protein albumin over the period. This is the question related to obesity. What I talked to you, pre-dialysis, you need to take care of obesity in these patients because they have a high risk of CKD progression. During dialysis, also obese patients have a problem. It is the intradialytic weight gain which leads to decide the prescription of what should be the ultrafiltration and what should be the required hours of dialysis. Of course, in transplant also, obese patient may be excluded from the kidney transplantation program because they have a survival disadvantage. And therefore, obesity is an important factor in deciding the progression of kidney disease. Second is anemia. And we know now because erythropoietin is low, leads to anemia. It induces, and this was being talked before with Dr. Rajiv also, this is the cardiovascular continuum, that increased progression of renal disease, decreased renal perfusion, decreased filling pressure, heart failure, cardiomyopathy, and myocyte death. Last part is important because even chronic kidney disease, like diabetes, independently can lead to cardiac myocyte damage, hence would enhance the progression and decrease the eGFR. There have been landmark trials for anemia, and we now understand that the 3 drugs we have used, initial improving the iron, then going to the roxastatin, we'll talk in a moment, and then looking at the erythropoietin, and the last looking at the hemicidine, which is an important factor in treatment of the anemia. Therefore, it is the insufficient production of endogenous erythropoietin, iron deficiency, inflammatory condition which increases hepcidin and therefore tries to retard the release of iron from the macrophages. Hyperparathyroidism is another component which needs attention, and you treat it and it's completely reversible. Albumin toxicity as well as hemoglobinopathies all add to deterioration of renal function. IV iron is important, and whenever we plan now to treat these patients, it's better to look at the IV iron preparation. They significantly reduce the erythropoietin requirement in dialysis patient, and is an important component also to halt the progression of the kidney disease. I talked about roxadustat. Now this is what I was referring to you. This is again hypoxic induced fat factor inhibitor. And when we use roxatrate, it effectively, this is the 2016 publication about 107 Japanese patients, dose-dependent increase in hemoglobin, and no miss occurred in roxatrate group. And therefore, it is another addition to retard the progression of anemia and CKD. This is when you use dark erythropoietin than the erythropoietin. And still the old is good. And there are about 10 studies available. And this is the review meta-analysis which have shown that either you use, they both have a positive factor, but dark erythropoietin have got least chance. Conventional erythropoietin has some inbuilt problem. And we know about the problem of the malignancy. We know about the conversion as well as aplastic anemia subsequent time. There was some paper, and therefore the dark erythropoietin have got least toxicity, least chances of hypertension, least weight gain, and edema. I was talking to you about the hepcidin, and this is an important component which is which regulates transferrin and at the increased erythrocytes level, and this is blocked with the chronic persistent inflammation as well as ongoing inflammatory insult, as well as the most of the inflammatory factors, pro-inflammatory factors at the level of the endosome. And treatment of this hepcidin inhibitors have got a role. Dr. Rajiv also talked about the management of the blood pressure, and this is important because the problem with the chronic kidney disease is as the systolic blood pressure increases, the renal blood flow tends to decrease, and because of that, there is also increased from intraglomerular hypertension. And when you use a drug, you try to do vasodilatation, there's improvement in the renal blood flow. According to systolic blood pressure also, increased GFR, massive proteinuria, with the renal damage is directly proportionate to the systolic blood pressure. So control of blood pressure would not only take care of the albuminuria, would also retard the renal damage and also retard the progression of GFR. This slide I got it for the reason, look at these squares. Yeah, these are the black square. This is the dihydropyridine CCB, and these are the stars are the ACB and ARS and the RAS blocker, and the white are the empty one are the uncontrolled. What is said that if you reduce the blood pressure even with traditional old calcium channel blocker, dihydropyridine, they would also decrease the incidence of glomerular sclerosis. This is not old, very old paper. This is hypertension paper and published in Kidney International. And this is the paper only published into 2017. So this paper still says 2007, 4-year back paper, that the traditional use of calcium channel blocker would also retard the blood pressure, would also retard the proteinuria, and would also retard the glomerular sclerosis. Therefore, when you try to take a decision, should you use AZ or ARB? Initial stage, yes, certainly you should. But if the serum creatinine value is less than 25%, you need to monitor. If it is more than 25%, stop AC and evaluate for RAS. Otherwise, creatinine would go high. And this is one of the reasons why we do not recommend patients to use long-term unsupervised, especially in this country, for the hyperkalemia. Continue until the contraindication arises. No absolute GFR is cut off. Better proteinuria suppression with low sodium diet and diuretics. Avoid volume depletion because that would enhance AC and ARB toxicity. Do not use in the combination. Another problem is the hyperkalemia. I said you, and you have to be very, very cautious about it with the dietary as well as the use of furosemide. Now, this is another article which I wanted to show you. This is about the control of the systolic blood pressure proteinuria. These are the two parameters, and this is the highly significant. And the moment you use ACE, ARB, beta blocker, calcium channel blocker, whatever drug you choose to control the blood pressure, the systolic blood pressure reduction and proteinuria would decrease significantly. With dual RAS blocker, you do not get this advantage, and any other drug does almost same thing. So it is still better you have a chance to use either drug looking at the rationality of using beta blocker, calcium channel blocker according to the guidelines. When these are the huge study and they try to compare between the ARB and ACE. And when you come in relation to the reduction of proteinuria, ACE inhibitors are still better. They are still better than the control. When you come to the progression of the ARBs, then ARB is better. Overall, if you look at the numbers on both sides, ACE inhibitors score much better in controlling the regression of proteinuria and then the referring to the hypertension. This is the short and long-term use of the, we are talking in relation to the, this is 2012 publication, a systemic review which have talked about the use of the bicarbonate, and this is in fashion now. This was in our time in initial training, this was very favorable, but then somehow this was dropped. But now again, the sodium bicarbonate use is prompted, and this has led to regression of EGFR initial part. Allopurinol, another one, and we know now urates, and we know the hyperuricemia. Initially, we thought that hyperuricemia is a consequence of decreasing EGFR, but now today we understand if you need to reduce it, and if you treat it, the hyperuricemia with any drug, whatever you have, whether you use faboxate, whether you use allopurinol, then certainly it would try to enhance the EGFR and would also decrease the progression of the sclerosis. And this particular paper looks at the, if you look at the bottom line here, the last one, fatal or non-fatal cardiovascular event. This is in relation to the allopurinol. This drug, and look at 0.7, this is about 21% favorable in decreasing the progression of EGFR when you are using allopurinol. And this is in relation to those patients whose EGFR was less than 30% decrease and 40% decrease. Thereby, you have a fair chance of using these drugs even in those patients who are getting into the CKD. Polycystic kidney disease. And now we understand that tolvaptan, though this is the costly drug for Indians at least, but then it has a potential to decrease the progression and decrease the volume of the cyst and the kidney size. And this is another paper. Everolimus, which is mTOR inhibitor, could be also used in the regression of polycystic kidney disease. Then looking at the glucose control, and this has for last 2 days we have been talking about all it. It also again depends on the EGFR. If even in the CCT trial, when we used glucose lowering insulin, and we know that at that time we knew it that these would retard a good glycemic control. Whether EDIC study subsequently showed us that we can sustain our EGFR less than 60 in a 50% number of patients. So it's a huge advantage of not only retarding the microvascular complication, but also macro and also sustain EGFR. And this is the EDIC trial 1 to 8 years, which have again shown microalbumin reduction 54%. Macroalbuminuria, micro is 59%. Significant finding. No talk is complete without the SGLT2 inhibitor, and you all understand. But what word of caution, dapagliflozin they used at the initial study with 60, when dapagliflozin they used almost up to 30. EMPA also used more than 30. Canagliflozin also used more than 30. And they have been able to show the advantage in reducing and sustaining the EGFR. Look at the value composite, 40%, more than 40% decline, and the progression up to 45, and renal replacement therapy or up to the 60% decline. So we have all the advantage of using these drugs. And look at the hazards ratio, canagliflozin 40%, empagliflozin 46%, and then 43%. Cana stands much better, and you have seen since this morning. And this is another study which was done by EMPAREC, and also have shown that it is a renoprotective effect independent of concomitant medication that you are using for the hemodynamics. Invocana, again, the same study showed 30% risk reduction. And this is the, again, comparative study. What is important here, look at the bottom point here. All these drugs, this is here 0.61, so this is about 49, 59, 49%, 28%, 38%, 26%, all these three glyphosate with a difference of 5 to 10% deviation have shown that there is an advantage in sustaining the EGFR. But what level you use, and look at the bottom, you should not less than 30 ml per minute. And this is the important information to all of you, to most of us who are still provocating. And we have seen time and again, even during COVID time, that if you continue to use unsupervised use of the glyphosate, even during COVID time, then there is a problem and patient can go into acute kidney injury and serum creatinine can go high, EGFR would be reduced. This is the 2021 publication, Kidney International, and look at the bottom. I wanted you to make it aware that it is a DAPA CKD study. At the bottom, it's very small writing, but I cannot make it larger because of the technical reason. They have shown the advantage, tremendous advantage, about the 39% sustaining in EGFR rather than any other glyphosate, and this is in relation to various outcome trial. Somebody was talking about the sclerosis. Perfendon, which was being used to decrease the fibrosis in the lung, also had been used to decrease and have shown a beneficial result in sustaining the EGFR, decreasing the glomerulosclerosis. Then this is again another study published in New England Journal. This is 2020, only last year publication, which have shown it lowers the risk of CKD progression in cardiovascular event than the placebo. And this is the urinary albumin excretion. This is another drug, avocentan. This is avocentan is a molecule which is the endothelin receptor antagonist ET1 and shows the decrease into the albuminuria, also in progression of the diabetic nephropathy. Pentoxifylline. We published this paper in Nephron about 1984. But then it keeps on coming, and there are a group of the patients, especially where there is a decreased rheology, diabetic own food, and they are not improving. Use of pentoxifylline also significantly reduces proteinuria, improves rheology, improves intraglomerular hypertension, and tries to preserve CKD. This last one slide, you must be very cautious of using nephrotoxic drug like radiographic contrast, aminoglycoside, lithium, calcineurin inhibitors, and because of those patients who have multiple complications in ICU or CCU, or they are into the tertiary care with multiple problem, metabolic conditions, surviving for longer time, prescription must be screened for, and you should try to prevent it. Therefore, to summarize, halting progression of CKD is a reality and not a myth. Early detection and prompt treatment would try to do some justice with the halting the progression. Dietary and obesity management is equally important, and you have seen the slide that they are important not during the progression of disease, but also during the treatment and transplant as well as the dialysis therapy. Strict BP reduction. I told you, even you use calcium channel blocker, traditional blocker, they do this good job, and you should use them judiciously. Rational and early use of ARB and ASI. And I must mention Dr. Mani from Chennai, very, very old octogenarian now, he must be about 90. He used even Adelphane as a drug. He published the article in Kidney International. For some reason, this did not gain the light because of the industry did not support it. But he used Adelphane, one of the very old antihypertensive drug which we wrote initially during our training time, and over the 10 years have retired the incidence of the CKD in patients who had a hypertension. In diabetic strict glycemic control, SGLT2, GLP, RA, antifibrotic drugs, mTOR modulating drugs have a role. Early referral to the nephrologist is necessary, and last, avoid the nephrotoxic drug. Thank you very much.
Thank you very much, sir, for a wonderful presentation. I think now we can all surely say that diabetic albuminuria progression can definitely be halted, and it is in our hands, and we must make sure that every patient of ours, we can try and reduce the albuminuria as early as possible. To unleash the potential of renal protection of SGLT2 inhibition, I now invite Dr. Per Hendrik Group. Sir is a very well-known figure He is a professor of medicine at the University of Helsinki. He is an advisory board member for Acta Diabetologia. He's a board member for ESD. He's a board member for Diabetic Research Foundation of Finland and has many original studies to his accreditations. Welcome, sir.
Thank you very much, Dr. Shefali. Let me share my slides. There we go. First of all, thank you to Banshi for inviting me once again to this wonderful meeting, Diabetes India. Of course, it would have been much nicer to be seeing you all face to face, but during these difficult times, we have to stick to our computers and try to do the best of things. And thank you, Dr. Chawla and Dr. Tripathi, for making my task so much easier, because you set the stage very nicely. What I will do during my 20 minutes is to actually convince you all that diabetic kidney disease is common, the consequences are grim, and we need to take action. And there's a lot of things we can do. Very good news is now that we have these novel glucose-lowering medications, SGLT2 inhibitors, that not only have been shown to be cardioprotective, but also renal protective. And I will go through that information from various studies to show you how we can see that SGLT2 inhibitors can actually maybe not prevent, but at least retard the progression of kidney disease. These are my disclosures. As I said, diabetic kidney disease is common. And you already saw wonderful data from Dr. Chawla about how common diabetic kidney disease. This is a very busy slide, but in the middle you can see the demand study was actually run by our friend Hans-Henrik Parving. The demand study was screening for diabetic kidney disease around the globe. And you can see that 56% of patients had either albuminuria or a reduced eGFR, or both. So that means that more than every second patient had signs of diabetic kidney disease. If you then look specifically at Asia, 68%. And that was very nicely shown by Dr. Chawla, that in your part of the world, diabetic kidney disease is extremely common. Then the question is, what are the consequences of diabetic kidney disease? And you already saw this slide also, that showing that there is an increased risk of premature mortality. You also saw this one. There's an increased risk of cardiovascular events when the albumin excretion rate increases, and also when you lose kidney function. Now, look at this one. If you have a reduction in your eGFR, that reduction in eGFR is strongly associated with the risk of the patient to end up in hospital because of heart failure. That was also very nicely shown by Dr. Chawla. And also on the right-hand side here, you can see the more albumin that leaks into the urine, the more likely the patients are to be hospitalized because of heart failure. So an increased risk of dying early, an increased risk of cardiovascular events, and also an increased risk of ending up in hospital because of heart failure. So let me now show you the really grim consequences. Diabetes in a 60-year-old patient, you can expect a 6-year shorter life expectancy by that patient having type 2 diabetes. If that patient, 6-year-old with diabetes, has suffered a myocardial infarction or a stroke, you can expect 12 years shorter life expectancy. But now, if you find early signs of diabetic kidney disease, as in the demand study, you can see that there is a 16-year shorter life expectancy. So diabetic kidney disease comes with grim consequences. So we need to do something. So we need to take action. So let me now go through what we have learned from various trials with SGLT2 inhibitors. But just let me first highlight that. How do we apply the standard of care? That is basically a 5-finger rule. It's optimal blood glucose control and A1C below 7, optimal blood pressure control below 140/90, or if you have 1 gram of proteinuria, maybe below 130/80. The use of ACE or blockers or angiotensin receptor blockers, and stop smoking, and also consider a statin. This slide just shows the RENAL and IDNT studies in patients with proteinuric diabetic kidney disease. So what you could see that losartan reduced the relative risk of progression to end-stage kidney disease by 28%, and also in the IDNT a similar reduction. But the most important thing is this residual risk, and you can see this is something that we need to address, and that is now what has been done in the studies I'm going to show you. So the EMPA-REG outcome trial was the first trial out with an SGLT2 inhibitor on top of standard of care, basically the 5-finger rule. Now, in the EMPA-REG outcome trial, what was shown, there was a 39% reduction in a composite kidney endpoint. That was, of course, very much driven by progression of macrobinuria, but also hard kidney endpoint, so 39% reduction. Also, what was seen in the EMPA-REG outcome trial was there was an initial drop in eGFR, and after that, a preservation of the kidney function. And that was in contrast to what was seen in placebo, where you saw a steep decrease in the eGFR. And this is what we see in our patients in the clinic. But when you expose the patient to an SGLT2 inhibitor, you saw initial drop, which is hemodynamic, nicely shown also by the previous speakers, and then you saw this preservation of kidney function. The CANVAS study was another cardiovascular trial with canagliflozin showing exactly a similar findings of 40% reduction. Now, you can see that the composite renal endpoint was slightly different in the CANVAS. Here they talked about 40%, or they assessed a 40% reduction in eGFR. In the EMPA-REG, it was a doubling of serum creatinine, which equals 57% reduction in eGFR, not 50%, 57. So very, very hard endpoint. Otherwise, need for renal replacement therapy or death from renal causes, that was the same. And also in the CANVAS, a similar initial drop in eGFR, and after that, a preservation of the kidney function. Very, very good news. So that was cardiovascular outcome trials. And of course, they were not designed to test what happens to the kidneys in a dedicated kidney study. However, these studies are now being undertaken, and the first one out was Credence. And the primary endpoint in Credence was a composite of end-stage kidney disease or dialysis or transplantation, doubling oral serum creatinine. So this serum, doubling oral serum creatinine, means a 57% reduction in eGFR. Renal death or cardiovascular. Just keep in mind that renal death basically means that the patient should be on dialysis but refuses. So in all of these studies, very few patients have shown renal death here. So in the Credence, what was shown was a 30% reduction in the primary outcome. Look at this. The primary outcome was a composite of kidney and a cardiovascular. The Credence trial was actually designed before any of the other cardiovascular outcome trials for SGLT2 inhibitors. At that time, people were not really thinking that maybe we could see an effect on the kidneys, so you had to put it together with cardiovascular outcome. In the secondary outcome, endpoint in Credence was basically to get rid of the cardiovascular death and only look at the renal composite. And you can see an even stronger effect. So, so you can see down to a 34% reduction. Now, if you then extrapolate these data from the Credence, you can see that the average Credence patient, 63 years of age, and the eGFR at baseline 56. So in the placebo, these patients lost about 4.6 ml per minute per year, but those in the exposed to canagliflozin 1.85 or 1.9 ml per minute per year. So then if you think that the eGFR of 10 is the the cutoff for ending up on dialysis. You can see in the placebo group, it would take about 10 years to come into dialysis, but it can take up to 25 years in those exposed to canagliflozin. So that could basically be 15 years. And you remember what I told you about the grim consequences of kidney disease. You can expect a 16 years shorter life expectancy. So here it seems that we might be able to retard the progression of kidney disease with SGLT2 inhibitors very nicely. However, these data are not measured. These are extrapolated from the data from the credence. Now, there's also another trial that you saw briefly in Dr. Tripathi's talk, the DAPA-CKD. In the DAPA-CKD, you can see that the primary composite endpoint was a 50% reduction in eGFR, end-stage kidney disease, renal cardiovascular death, and 39% reduction. If you then get rid of cardiovascular death, it's basically a stronger one, 44% reduction. Now, the credence and DAPA-CKD, wonderful studies. However, there's one problem with them. They do not include patients with non-albuminuric kidney disease. And I can tell you that 20% of patients with diabetic kidney disease will have non-albuminuric kidney disease. 20%, so 1 in 5. And they were not included in credence and the DAPA-CKD. So there's another trial ongoing, the EMPA-Kidney, empagliflozin 10 milligram on top of standard care versus placebo. And this study actually includes also patients with non-albuminuric kidney disease. So if you look at the credence trial, sorry for that, credence trial included patients with an eGFR 30 to 90, and they all had to have albuminuria. Now, if you look at the DAPA-CKD, they had an eGFR down to 25 and up to 75, and they all had to have albuminuria. Now, if you look at the EMPA-Kidney, that basically covers the whole range. So watch out for these data in the future, because then we also see whether SGLT2 inhibitors work in the non-albuminuric diabetic kidney disease. My guess is that they will work, because we have much data from other studies that might tell that story. However, we need to wait for the results from the EMPA-Kidney. So let me then finish off with other dedicated studies and the dedicated heart failure studies with SGLT2 inhibitors, and then what happened to the kidneys. And you can see in the EMPA-reduced, empagliflozin 10 milligram on top of standard of care versus placebo. And there was secondary endpoints, this slope of change in eGFR. And let me tell you a little bit about that, because as I showed you before, there's an initial drop in the eGFR when you expose the patient to an SGLT2 inhibitor. After that, you see this preservation. So this is the so-called chronic phase. And at the end, you actually see that the eGFR goes up. Now, I will refer to a wonderful study that you should look at. Different interventions with, for instance, RAS blockers, low protein diet, any intervention you can see here, when they have looked at the treatment effect on the eGFR slope, so the slope, and also the treatment effect on the clinical endpoint. And you can see that if you have an observed change in the eGFR slope of 0.5 ml per minute per year, you can expect a hazard ratio 0.8. If you have a change of 1 ml per minute per year, you can expect 0.65. Let's now look at what happened in the EMPA-reduced. If you take this into account and you look at the chronic phase. So in the EMPA-reduced initial drop, and this is then the preservation of the kidney function, the chronic phase. Now, at the end of the study, when empagliflozin was stopped, the eGFR went up as expected. Now, let's see what happened in the EMPA-reduced. It was not a 1 ml per minute per year gain. It was actually plus 1.73. So then the question is, what was the hazard ratio? And you can see hazard ratio was lower than the 0.65 1 ml per minute per year would have given us 0.50. So it means that when you can retard the change in the slope, you will actually also have wonderful effect on the risk, so hazard ratio. And this is just to summarize from the EMPA reduced, the eGFR slope 0.173 and the hazard ratio 0.50. And if you then look at those with CKD at baseline, and those without CKD, very, very similar effects on the slope and also on the hazard ratios. So it means that SGLT2 inhibitors also work in patients with heart failure with or without CKD. And there's also a meta-analysis with EMPA-reduced and DAPA-HF. I didn't show you data from the DAPA-HF because they didn't look specifically at the kidneys, but later on data have been looked at, and you can see that consistent findings in these two trials. So it basically means that SGLT2 inhibitors, you have renoprotective effects also in dedicated heart failure trials. So basically means that cardiovascular outcome trials, dedicated renal trials, and dedicated heart failure trials have shown not only cardioprotection, but also renal protection. So one final slide, what do the guidelines say? Yes, they say you should consider the use of an SGLT2 inhibitor if the patient has signs of diabetic kidney disease, and that's very common. So take-home message is diabetic kidney disease is common, consequences are grim, we therefore need to take action. Standard of care leaves a substantial unmet need, so we need to do something else. And now the novel SGLT2 inhibitors provide an effective tool to improve the prognosis of patients with type 2 diabetes and diabetic kidney disease, since they have not only been shown to be cardioprotective, but also renoprotective. And that said, Dr. Shefali, Kakanis, and all of you, thank you for your attention.
Thank you very much, sir. Thank you. Thank you so much, sir. I think we've really simplified the data that is available all across the board. And I think we have a couple of questions. We are running short of time, but I think we can take a couple of questions. What is the correlation between diabetic nephropathy and myocardial infarction? Is any of the esteemed speakers can probably address the question.
Any of us can do that. It's a strong college. It's a strong. You know,
Raju, you said
Yeah,
it's
I said
equivalence.
in the beginning in my whole presentation, I said that there is a very, very strong link. It's a continuous dynamic relationship between the onset of CKD, onset of albuminuria, progression of albuminuria with increased risk of not only heart failure, CV death, and even 3-point composite MACE also. So it's an ongoing thing. Not only you have on one end loss of cardiomyocyte, but you also have nephron losses. So together, these contribute towards higher CV risk. And one study I've already shown that it is, if you have CKD, it is something like even worse than having a previous MI in the past. So I think it is a continuum of risk which increases with onset of nephropathy, reduction of eGFR, and increase in albuminuria, and it goes on towards end-stage renal disease and end-stage cardiovascular disease with composite 3-point MACE also going very, very high.
Can I add to this a little bit? Because I think I'm always a bit concerned that a lot of cardiologists, they tell us, yeah, these people die of cardiovascular disease, which is true. But the main driver of the cardiovascular disease is, as Dr. Javla was showing, is the kidney disease. And they don't die of kidney disease. And that is the reason why we tend to tone down the importance of the kidney disease. And that is a misconception. The kidney disease is the driver. So when you have signs of kidney disease, you will also have signs of cardiovascular disease. Just watch out for it. So it's very important that we watch out, screen for kidney disease, and then take action.
True. Very true, sir.
Yeah. Just to add one more thing, it's a mechanical factor as well. We have a wide variety of cardiorenal syndrome. You can start with acute kidney injury affecting the heart. You can have acute cardiac event affecting the renal perfusion. You can have a chronic kidney disease and chronic heart disease, and then you have a combination of the two. And all these five different combination makes the pump failure, the perfusion failure, and add to further cardiovascular risk. So it's not only the perfusion, cardiac myocyte, molecular level, but also the mechanical factor, which is equally important. 5 factors have been added into it.
Absolutely. 25% of cardiac output reaches the kidneys. So 25%. It basically means that the kidneys have to protect themselves against too much oxygen. So the co-work between the heart and the kidneys is very strong. And that's the reason also why we see these wonderful effects when you treat, for one organ, you see effects on the other. If you have positive effects on the heart, you will see that positive effects on the kidneys and vice versa, as we have seen in all these studies. So I think the most important take-home message for clinicians is that keep in mind that diabetic kidney disease is common and you need to take action. And we now have the means to do it. And we have shown cardioprotection and renal protection. And now we also have another medication that I didn't talk about today, finerenone, that also add to the benefits. So we live in a much better situation now than before 2015, 17th of September 2015, when EMPA-REG outcome was first reported in Stockholm.
So one more question, sir. What are the guidelines for CVD prevention in CKD patients and diabetes, especially in the aftermath of COVID that we are now seeing? Dr. Koop, if you could answer that question.
Say that again. So what is the guidelines?
Yes.
The guidelines.
What do the guidelines say about CVD prevention?
So the guidelines, all of the guidelines actually nowadays, we talk about the ADA, EHD guidelines, the S guidelines, the ERA-EDTA, the KDIGO, they all actually urge us to watch out if the patient has signs of diabetic kidney disease and cardiovascular disease or heart failure, and then you should consider the use of an SGLT2 inhibitor. That is what they all say. That is a problem, of course, now, because the guidelines, they have taken on all the information we have from these wonderful cardiovascular outcome trials, dedicated renal trials, heart failure trials. But there is one obstacle, because the local guidelines not always allow the use of SGLT2 inhibitors if you have an eGFR below 60, some countries down to 45 and some countries down to 30. And the reason for this is that it's historical, because when SGLT2 inhibitors came on the market, they were by definition glucose lowering medications, and losing the glucose lowering effect when you lose the kidney function. So in eGFR 90, 60, 30, you lost the glucose lowering effect. What we learned from EMPA-Kidney, from the EMPA-REG outcome trial, from the Canvas, etc., was that the effects on the kidneys and the heart was even stronger at lower eGFRs. But EMA and FDA have still to accept that we can use these medications down to much lower eGFRs. And you can see that EMPA-REG, the Canvas was down to 30, the Credence was down to 30, the DAPA-CKD down to 25, and the EMPA-REDUCE down to 20. EMPA-Kidney also go down to 20. And I was responsible for a sotagliflozin study where we went down to 15, and no signs of acute kidney injury. So I think it will change in the future. So the guidelines have already adopted, but the only obstacle is that can you use them if your eGFR is at the lower end? And there is where the local guidelines come into place. And of course, you need to stick to the guidelines in your own region.
Yes. I think we're running short of time. We can proceed for the next session, sir. I thank you all very much. I thank.
Definitely, you can continue. Still, we have got 5 minutes left. You can continue if there are any questions. Yes.
5 minutes
one
left.
practical question that one practical question is, how frequent do you do 24-hour proteinuria in your patients of diabetic mellitus? Sir, Dr. Chawla, if you could answer that.
So,
right at the time of diagnosis, this is what all algorithm and guidelines suggest, that once you have answer to type 2 diabetes, first time you should have a microalbuminuria done, like with other lipid profiles and baseline investigation, a fundus for diabetic retinopathy and a foot examination. In type 1, it is first time after 5 years of the onset of type 1. And in type 2, then every 1 year you need to repeat, even if your previous microalbuminuria has been negative. If patient is already having micro to macroalbuminuria or gross proteinuria, it may be repeated every 3 months to 6 months to see the progression of albuminuria. But even if it is normal, at the time of diagnosis, first time, and then every year annually.
Can I add to this?
Yes, sir.
Yes,
Yeah.
yes, sir. Please.
Yeah, you know, I think it's a very important question. And I see the measurement of albuminuria and EGFR in two ways. First of all, you need to screen for the presence of kidney disease, because as I showed you the grim consequences that comes with that. So we need to do that. But also, after that, it's so important to follow the albuminuria and also to follow the EGFR. Why? Because it's basically the only measure we have that the effect of the treatment. It's just like we measure the blood pressure when we prescribe blood pressure medication, and this is exactly the same. That can we achieve a reduction in albuminuria? Can we retard the progression of EGFR by our treatment? And if we can do that, we can actually get a sign that we are doing the correct things. That is exactly, as I see it, you know, the use of the albuminuria and EGFR, screening and then follow up. And that is important. And keep in mind that, you know, increase in albuminuria makes you more prone to end up in hospital because of heart failure, get cardiovascular events, or die early. So, of course, if you see a reduction, that can be considered a positive sign. And also the same is for EGFR. So these are extremely important and also simple measures that we should do on a routine basis in our patients.
So I think more often we do a urinary ACR, UACR, the urinary creatinine albumin ratio, rather than 24-hour urine protein in our country. I think that's an easier way to diagnose and albuminuria at an early stage.
So albumin creatinine ratio is of course the morning. You can do that. It's not the the standard, which is the 24-hour. The standard is the overnight urine collection. We know that extremely difficult to get patients to collect urine. So I think albumin creatinine ratio is absolutely fine to do.
May I ask one question?
Yes.
Yes. So don't you feel that we are a bit reactive as far as diabetic kidney disease is concerned, because we are using treatment, particularly SGLT2 inhibitors, when either EGFR goes below 60 or when the patient develops albuminuria or macroalbuminuria, significant proteinuria? Don't you feel that we should start it much earlier for protecting our kidneys rather than be reactive? We be proactive as far as kidney disease is concerned.
That's a very good question. I think that the only problem, my answer is yes, we should do that. The only problem is that we don't have any studies for that, and we are not going to get those studies. But I think what we can say is that SGLT2 inhibitors, they also have another indication, that glucose lowering. So by that, and then later on will come definitely the protective one. But let me tell you a little bit why I think we should use them at earlier stage. I told you 25% of the cardiac output reaches the kidneys. So the kidneys have to protect themselves against too much oxygen. And in the kidneys, you have a shunt. So that regulates the blood, the circulation also in the glomeruli. Now, the shunt shows us that in the tissue, you have a lower oxygen level than in the renal vein. Now, this is physiology, and it protects the kidneys from damage that comes with too much oxygen with the heart, with the cardiac output. Now, in diabetes, in obesity, and also in hypertension, they all go with insulin resistance. They also go with an increased renal blood flow and hyperfiltration. And anytime you have hyperfiltration, what happens? You push the sodium handling in the proximal tubule. And 90% of the oxygen consumption in the kidneys are due to sodium reabsorption in the proximal tubule. So basically, if you have hypertension, obesity, and diabetes, you push the sodium handling and you cause kidney hypoxia. And I can tell you that if you induce kidney hypoxia in experimental mice, do you know what the phenotype is? By giving a mitochondrial uncoupler dinitrophenol, without having diabetes, anything, you just cause kidney hypoxia. The phenotype is proteinuria, inflammation, cell damage. So kidney hypoxia is something that causes the damage in the kidney, and is very much driven by hypertension, obesity, diabetes, which is related to insulin resistance, increased renal blood flow, that makes you hyperfilter and so on. So this is the reason why this starts at much earlier stage, and we need to intervene very, very early. So I think your suggestion is absolutely wonderful. The problem is we don't have the data.
Thank you, sir. Over to you, Shefali.
So I think that about answers all the questions.
Hello, group. How are you?
Yes.
Fine, thanks. Thanks, Panchi, for inviting us.
Good evening, Dr. Guru. Wish to see you again.
Wish to see you again in India, you know.
Yeah, in India.
Physically. I don't want
remember
to
our
see
Delhi
more
meeting
of
2 years
on
ago.
the digital platform.
Yeah, we wish we can have you this year physically at Delhi again.
Maybe in 2022 we will have him.
Maybe 21 or 22. Let's see. Ours is in this number.
Maybe 25.
Hello, Dr. Adil. Hello,
Hello,
Harshna.
Banshi. Hello, Banshi.
Hello, Prasad.
Hello,
Banshi.
So we can close, Pratap, this session and we can start the next session.
Yes, sir.
Shefali, you can conclude.
Yes, sir.
So that
Thank you so much.
Bye, Hendrik.
Yes, sir.
Bye-bye.
Thank you so much.
Thank you. Bye-bye.
Thank you so much.
Bye, Rajiv boss.
Thank you for a wonderful session.
Tripathi Saab.
Thank you, sir.
Tripathi Saab, yesterday we missed you. You and Rajiv both.
Thank you. No, I was there, but I was there, but
Okay.
I kept my video off.
Okay.
So
Thanks
thank
a lot.
Thank you so
Bye.
much.
Bye-bye.
Thank you. Thank you so
Dr.
much. sir.
Rajiv
safe,
Chawla,
everyone.
sir.
Bye, Shefali. Thank you for nice
safe, everyone.
Thank you.
Bye.
And all the speakers, thank you
Thank you, sir.
for wonderful deliberations on diabetes and kidney. And we will move on to the last session, that is Diabetes in Asia Study Group and Diabetes India Symposium. I will invite Dr. Vipul Chawda, a young diabetologist from the city of Ahmedabad, to carry on with the proceedings. Dr.
Thank you
Vipul?
so much, Pratap sir. After having a wonderful discussion about diabetes and kidney, now we enter the last session of Diabetes India DASD Symposium. And to chair this session, we have Dr. Mesbah Kamel from Egypt. And the second chairperson is none other than the Dr. Bansi Sabu, who is my teacher, my mentor, and my guide, and also who is the main showstopper of this wonderful Diabetes India 2021. So over to you, Bansi sir.
Thank you. So first of all, I just introduced Professor Mesbah. Professor Mesbah is currently the president of Diabetes Association of Study Group, which is one of the study group from all across the country, Asian countries, they are the member. I was previously the secretary. Now I am the vice president of this group. And we have two eminent persons along with us who will be speaking in this DSG Symposia, which is Diabetes India and DSG Symposia. Unluckily, just now I got a call from Dr. Vishwajit. He will not able to join because of some medical emergency in his family. But as this is the last symposia, so we will have the two major talk and followed by a discussion. Diabetes Asia, I just want to introduce to my friends from Diabetes Asia that this is the meeting of Diabetes India. Many of them, they know Meshba and Adil very closely because it was founded by Professor Dr. Shokar Sadikot, and they are very close friend of Dr. Shokar Sadikot. Unluckily, we lost him before 2 years. And this meeting, this time we are doing on digital platform with a 4 hole, and since last 3 days, this is the last day, today is the third day. We have more than 40,000 delegates who are registered for this meeting. This meeting is completely free registration we had capped, but I just request all the member of Diabetic Asia and Diabetes India, please go through as a delegate. You can listen all the talks. As a faculty also, you can listen all the talks which were previously recorded. We are going to keep this platform also live for next 3 months, and all the recorded lectures will be there on our website, also on Diabetes India. And for the DSG Symposia, this DSG Symposia dedicated, I'll be sending you the dedicated recordings of these 2 speakers, which we can put on our website also, and we can circulate to all our members. Those who are not the member of Diabetes Asia Study Group, here I take an opportunity to chair this session, and I just want to tell all those who are attending this session and listening to us, they can become the member of DSG. They can see the website of Diabetes Asia Study Group, and they can become the life member of Diabetes Study Group. With this, I now inviting Professor Dr. Adil, who is a professor of internal medicine, Sohag University, Cairo. He's a past president of Diabetes in Asia Study Group. He's a past chair of IDF, International Diabetic Federation, with Middle East and North Africa region. So over to Adil, but before that, I would like Dr. Meshba to make some comments about this Diabetes India and DSG symposia, and then we will have Dr. Sayed to talk about it.
Okay, thank you, Banshi, for this nice introduction. Always, I said people makes difference, and I think Banshi makes a great difference in Diabetes India. As he's told before, me and Professor Adil was close friends to late Shaukat Sadikot, peace upon him, and we now see that Diabetes India is going forward with Banshi. Banshi is a very active moderator, and I am lucky to have in my board in Diabetes in Asia Study Group to have someone like Banshi Sabo. Banshi Sabo now is a dynamic. He is not a dynamic kid, but he's a dynamic talent and dynamic innovative for diabetes in India. And I congratulate you, Banshi, for all these 3 marvelous days. The next thing that I appreciate is that this kind invitation from Diabetes India to Diabetes in Asia Study Group to have this symposium. And I think all of us working close to each other in our region, because it needs more. It needs more for differentiated diabetes care other than the original styles, because we have our ethnicity, we have our culture, we have our special situations, either economic or social. So diabetes in Asia and all the region must have this its own style dealing with diabetic problems. So without further delay, I am thankful and grateful to Banshi Sabo, to Diabetes India, to organizing committee, to the IT, and also to our speakers, our eminent speakers. They are eminent persons in the Diabetes Study Group. Either Professor Adil is the immediate or the ex-president of MENA region and the Diabetes Study Group, or Professor Barsad, and we now waiting for them to have a lot about the this symposium, to know a lot. And again, Thank you, Banshi, for your introduction. And we will go to the first speaker, Professor Adil Sayed. Please, the floor is yours. Professor Adil, you are muted, Adil. Adil, you are muted.
Dr. Adil,
you are muted, Adil. Adil, you are muted.
Adil, you are muted. I think you have to unmute yourself. Adil has joined from two mobile, I think.
Adil, you are muted, Adil. Adil?
Both devices are muted, sir.
Both devices are muted. Meshwa, can you call him?
Okay, I'll call. I just call.
Dr. Adil, we can't listen you. You have to unmute.
Yeah.
Now you can now you can hear me.
Yes, and you joined with the two devices.
Yes, actually I am because my PC didn't allow my voice to reach you, so I am now using my iPhone.
Okay, no problem. That's great.
Is that okay for you?
Oh yes, it's okay. Yes. That's fine.
Thank you.
Let's share your screen.
So through PC, you can share your screen now.
Okay, thank you. This is my screen. On nephropathy, neuropathy, and retinopathy, then the scientific conclusions about the idea of combining these drugs, then covering the gaps between the trials and the required evidence. I would like actually just to try to lower the voice or decrease the voice. This voice is it still the voice is not asked well? Is not
no.
heard well, I mean?
It is a good, Adil. Adil, go on.
Okay.
It is clear, yeah.
Okay, thank you. Now let me have a look to nephropathy. SGLT2s and nephropathy. Of course, the evidence is very clear regarding the SGLT2 and nephropathy. They clearly show that SGLT2 inhibitors, in addition to lowering glucose levels, they exert a protective effect on microvascular and macrovascular levels. And the EMPA-REG outcome trial was the first to appear regarding that issue, and it clearly showed that SGLT2 empagliflozin reduced the progression of macroalbuminuria, doubling the serum creatinine in patients with fairly low estimated glomerular filtration rate, and the requirement of renal replacement therapy, either kidney transplantation or kidney or renal dialysis. In addition to that, nephropathy improved by the effect of empagliflozin. The second member is the canagliflozin, and the CANVAS trial showed in a diabetic patients with high cardiovascular risk, a gross and significant reduction in the EGFR EGFR deterioration, for renal replacement, the need for renal replacement therapy, and the death from renal causes. All of these endpoints significantly improve. And it decreases the progression of pre-existing albuminuria and change from normal or micro to micro or macro albuminuria. The CREDENCE trial, again on canagliflozin, is the only trial which tackled the issue of nephropathy as a primary outcome, not secondary outcome like the rest of the trials, but the results were basically the same. The DECLARE trial was the largest among these trials, based on dapagliflozin with a primary outcome cardiovascular as the rest of the trials, and the renal endpoints as secondary outcome. The results were similar to other drugs. There has been an improvement in renal composite eGFR decrease, new end-stage renal disease, death from renal and cardiovascular disease as well. So, these are the conclusions of nephropathy, the effect of SGLT2 inhibitors and nephropathy. The evidence is very clear, actually, and overwhelming about the ability of SGLT2 inhibitors to improve nephropathy and reverse it, actually. Multiple factors might have contributed to that. I mean, they improve the glycemic control, they improve blood pressure, they decrease glomerular pressure and volume overload. So these factors might contribute to the beneficial effect of SGLT2, but the credence trials of canagliflozin, in this trial in particularly, the effect on the glycemic control was very minimal, and very minimal body weight reduction, blood pressure reduction compared to placebo. So they suggest that the mechanism of benefit is likely to be independent of these factors. And further details, of course, on trials to validate these benefits and to elucidate us about the improvement, the rationale behind kidney function improvement. Now, let's have a look to the effect of DPP4 inhibitors on nephropathy. Only few clinical studies evaluated the effect of DPP4 inhibitors in clinical nephropathy. One of them is the SAVOR-TEMI 53 trial, evaluated the effect of saxagliptin on renal outcomes in patients with diabetes. And treatment with saxagliptin was associated with statistically significant improvement and or less deterioration of urinary albumin-creatinine ratio and reduction of albuminuria with saxagliptin. But the problem is the effect on eGFR, serum creatinine, and initiation of dialysis were similar in treatment or placebo. So DPP4 inhibitors did not improve the functions of the kidney, but they decreased the proteinuria. The TECOS trial did not show, that's for sitagliptin, of course, did not show any clinically significant impact of sitagliptin on CKD outcomes, irrespective of the baseline eGFR. The third line on linagliptin. Linagliptin actually was thought to be very efficient in improvement of kidney functions, but the Marilina, the Marlina type 2 diabetes trial, which aimed to investigate the renal effects of linagliptin on patients with baseline albuminuria, showed the same thing. They reduced albuminuria, but they didn't affect the estimated GFR. Finally, the Carmelina trial, the same thing. I mean, to study nephroprotective effect of linagliptin on renal complications of diabetes, but in spite of decreased albuminuria, progressive albuminuria progression, linagliptin did not result in any statistically significant effect on GFR. So this is the conclusion of DPP4 inhibitors. Compared to other microvascular complications, nephropathy is considered the most studied in major trials of DPP4 inhibitors, TECOS, SAVOR, Marlina, and Carmelina. But the overall conclusion of this study, the positive effect of DPP4 inhibitors on progression of albuminuria, however, their effect on urinary artery, albumin creatinine ratio and eGFR is still lacking. Now let's have a look to nephropathy, SGLT2s and nephropathy. Not all the studies with the SGLT2s, EMPA-REG, CANVAS, DECLARE, CREDENCE, all of them, they did not assess the effect of SGLT2 inhibitors on neuropathy. So far, we do not have any human clinical trials assessing this combination. However, there is an SGLT2 called epagliflozin. It is not approved by FDA. And its effect on neuropathy was studied in rats. And the motor nerve conduction revealed a dose-dependent improvement in rats treated with epagliflozin versus diabetic control. So this is the conclusion of SGLT2s on neuropathy. Animal studies performed so far revealed promising outcomes in delaying neuropathy. However, human trials are needed to assess the reproducibility and the mode of these protective outcomes, whether through a direct mechanism or simply by controlling blood glucose. We do not know, and further clinical trials are required regarding that. Debiform and neuropathy. Again, currently, there are no available large trials focusing on the effect of DB4 inhibitors on diabetic neuropathy. Some studies on this topic have been conducted, although most of them are animal studies. These are 4 studies conducted on rats again, and they evaluated the effect of vildagliptin and allogliptin on peripheral nerve degeneration in rats, and the results were very promising, showing a significant decrease in nerve degeneration and conduction velocity in the DB4 inhibitor treated group. There is, regarding the clinical studies, there is a retrospective cohort study using a large sample from German electronic medical record database, and to compare the effect of vildagliptin versus sulfonylurea in diabetic neuropathy. And treatment with vildagliptin was associated with significant lower incidence of neuropathy when compared with sulfonylurea. Another small clinical trial was conducted in patients who were uncontrolled diabetes or metformin and glyburide, and they were randomized to receive either sitagliptin or insulin. And sitagliptin did not show any improvement compared to insulin after follow-up for 1 year. So the conclusions of DB4 inhibitors and neuropathy, that animal studies showed promising beneficial effect of DB4 inhibitors on diabetic neuropathy. These studies mainly used vildagliptin, with one study using allogliptin. However, human clinical studies are still scarce in this field, making conclusions about the benefits of DB4 inhibitors on neuropathy. It's too early, and we need more study. Now let's go to retinopathy. SGLT2 and retinopathy. The expectation that SGLT2 inhibitor will be good for retinopathy, will improve retinopathy. This assumption is rational because retinal pericytes employ SGLT2 receptors for glucose uptake, exactly similar to mesangial kidney cells. And in the early phases of diabetic retinopathy, these pericytes were observed to swell and then to eventually die, resulting in microaneurysm formation, bleeding, and proliferative changes in the retina. So clinical trials so far did not, in spite of this very encouraging theoretical benefit, but clinical trials so far did not address the effect of SGLT2 inhibition on diabetic retinopathy, and this is an open field for research. The effect of epagliflozin treatment on diabetic rats retinopathy showed improvement of some retina markers. It's a surrogate marker rather than clinical improvement. And in conclusion, clinical and animal data are limited regarding the effect of SGLT2 inhibitors on diabetic retinopathy, and more trials are needed to evaluate the potential retinopathy benefit of these agents, which is understood from the theoretical background, and to understand the basis of the limited results obtained from the previous study. Now, the DB4 inhibitor, similar to neuropathy, there are no available large trials about the effect of DB4 inhibitors on retinopathy, but we have 3 animal-based studies, the effect of sitagliptin, vildagliptin, and linagliptin on the retina of diabetic rats. They showed a protective effect and improvement on the retina surrogate markers as decreased in retinal inflammatory status and neuronal apoptosis by a mechanism independent from glycemic control. A clinical study to evaluate the effect of saxagliptin on early diabetic microvascular change suggested a potential improvement of central hemodynamics and protection of retinal microorganisms. This is the cohort large sample from the German electronic medical record database compared the effect of vildagliptin versus sulfonylurea on the retinopathy, and treatment with vildagliptin was associated with a significant lower incidence of retinopathy when compared to sulfonylurea. However, there is another study giving an opposing results. They used various in vivo and in vitro diabetic retinopathy models and demonstrated that DB4 inhibitors increased renal vascular permeability and leakage. And this result, although preclinical, it's not clinical results, raised concerns of the safety of DB4 inhibition in diabetic retinopathy in type 2 diabetic patients. This is about the combination. This is my last part of the study, and I'll finish in a couple of minutes. So this is a review article published two years ago about the combination of the 2 agents together in treating patients with type 2 diabetes. There had been 8 randomized clinical trials comparing combination of SGL2 and DB4 inhibitors with DB4 inhibitors, 5 trials comparing this combination with SGLT2, and 3 articles involving both comparisons together. SGLT2 DB4 combination resulted in a greater mean hemoglobin A1C and body weight reduction than did DB4 inhibitor alone. But this was much less marked than compared with SGLT2 alone, reflecting the more potent hemoglobin A1C reduction and body weight losing ability of SGLT2 compared to DB4 inhibitor. And this is an expected result, of course. The risk of hypoglycemic events was low and similar between the two groups. When subjects were stratified based on the baseline hemoglobin A1C, any reduction by the combination in relation to or compared to DB4 inhibitor was proportional to the baseline hemoglobin A1C levels. However, compared with SGLT2, hemoglobin A1C reduction with the combination were modest regardless of the baseline hemoglobin A1C. So in conclusion, combination therapy between the 2 drugs is both efficacious and safe. In particular, a marked additional glucose lowering effect is evident when SGLT2 is combined with added to DB4 inhibitors and not vice versa, of course. However, baseline hemoglobin A1C determined the additional glucose lowering effect of SGLT2 is combined treatment with them. Now, these are my conclusion, ladies and gentlemen. SGLT2 inhibitors appear to have promising nephroprotective outcomes with less promising outcomes seen in DB4 inhibitors. More studies are required to understand the rationale behind these outcomes and the benefits of these diabetes medications. On the contrary, the neuroprotective outcome has still not been assessed in human clinical trials in neuroprotective. So far, the available results are based basically on few studies mainly conducted on rats. Regarding retinopathy, the effect exerted by SGLT2 inhibitors and DB4 inhibitors, although theoretically promising, was only slightly testing basically on mice with not enough human clinical trials yet. The DB4 inhibitors showed discrepancy in the results between different trials, as we mentioned. Finally, combination therapy with SGLT2 and DB4 inhibitor is both efficacious and safe. In particular, the marked additional glucose lowering effect is evident when SGLT2 in particular is compared with or added to DB4 inhibitors. And all in all, a clearer picture of the microvascular outcomes will manifest over time with the release of the multiple upcoming clinical trials. Thank you very much.
Thank you, Dr. Adel. Should we have the question answer at the end? That's fine.
Yes, sure,
with you,
absolutely.
Dr. Adel? That's
Yes,
great.
yes.
Sure, absolutely.
Thank you. Now I request Meshba to introduce our next speaker.
Okay,
Please.
we will
Yes.
now go for
Dr. Prasad.
yes.
Please share his slide. Yes, yes.
Dr. Prasad is one of our friends, close friends, and diabetes nature study group, and he's a consultant endocrinologist, diabetologist, and senior lecturer, and he is in the department of the clinical medicine, University of Colombo, and we are waiting more and more work there in our in this our area, because we need his efforts much. He was awarded for best poster presentations, and he is a well-known physician there, and he has many publications regarding the diabetes epidemic in Sri Lanka as a growing problem, like other Asia groups, and he has membership of International Diabetes Epidemiology Group and Sri Lanka Diabetes Association, and I think we will gain much when we are listening to Dr. Barsad regarding managing diabetes. How can we go beyond the glycemia for getting our targets and our goals for diabetic populations? Please, Dr. Barsad, welcome, and the floor of yours.
Thank you, Dr. Kamel. And first of all, let me first thank the Diabetes India study group, particularly Banshi, and also particularly I should congratulate very profusely for the magnificent performance in this conference, and it's really remarkable. And let me now start sharing my slides. Can you see my slides?
Yes.
So actually, I had to think a little bit on how to, make this presentation, manage diabetes, thinking beyond A1C. I think I would do some justice to the topic Banshi suggested. So this shows the numbers of death from diabetes in the people worldwide. You can see this is killing millions of people, and particularly in the old ages, the numbers are pretty eye-watering. And this study is from Taiwan, showing some causes of death among patients with diabetes. You can see diabetes itself, cancer, cardiopulmonary disease, stroke, and then the vascular disease, nephropathy, infection, and then some unrelated causes. This is again from a UK registry showing the diabetes death in 2001 compared to deaths without diabetes in the same year as well as in 2018. Two important things in addition to the usual causes of death, which I'm going to highlight, is that if you compare people with diabetes and also from 2001 to 2018, you can see there's a huge reduction in the deaths due to ischemic heart disease and the vascular disease. And in people in the developed countries, conditions like cancer, dementia are becoming more important compared to other causes. So this is a bit of a shift that we are seeing in the developed countries, still not in our part of the world. And this is some data I managed to get from India. Again, seeing a vascular disease is number one, then infection, malignancies, renal disease, and other organ affection. And if you take all these data, what are the important causes of mortality and morbidity in patients with diabetes? Again, we can say number one, ischemic heart disease, vascular disease, heart failure, a very important cause which we have neglected perhaps. And then the other causes of vascular disease, glycemia related, both hypo, sepsis, cancer, kidney disease, liver disease, and rare causes and unrelated to diabetes. When we think about mortality, morbidity, we need to think about the underlying risk factors. Perhaps we know that glycemia may be still the overwhelming number one. Then glycemia may be unrelated to A1C in some cases, particularly because the A1C is just an average. And then hypertension, dyslipidemia, obesity, and the non-modifiable factors like duration of diabetes, age, and the genetic risk. If you see this slide, there's a very good correlation between the HbA1c and the average glucose, which we all know about this. And if you look at the strategies that has evolved over a few years or decades, it's mainly based on these landmark studies like the DCCT and the UK-PDS, which elegantly showed the association of the HbA1c and the microvascular disease, both in the UK-PDS in type 2 and the the DCCT in type 1. Then everything became glucose-centric strategy, where you think about the HbA1c in the modification of the treatment of people with diabetes. But if you compare other studies in addition to UK-PDS and DCCT like the ACCORD, Advanced, VADT, everything together, there is very impressive reduction of microvascular disease with HbA1c control, but hardly any effect from for macrovascular disease, particularly in the early phases of the studies. In addition, just forgetting about the long-term follow-up in UK-PDS and the EDIC, the DCCT version of long-term follow-up, and even the mortality was not very impressive, except in the UK-PDS follow-up study, and in the ACCORD, actually, it was inverse. So the traditional paradigm of management was progressive escalation of treatment according to the HbA1c, and in fact, which we can say that this is treatment for failure. So why the glycemia-based A1C not the only option for diabetes management? Because the A1C, the traditional measures always does not reflect overall glycemia, hypos and severe hypoglycemic spells, macrovascular risk, effect on the weight, and effect on heart failure, which is an important cause of death, and association with cancer and the quality of life. Now, this new strategy, which I am proposing, the diabetes remission strategy in type 2 diabetes, where we attempt reversal of type 2 diabetes, particularly in the early onset patients with early onset diabetes, we might be potentially able to reduce or reverse all the complications associated with diabetes if this is successful. Bariatric surgery and VLCLD diet-based programs have shown the promise. If you look at these data, the bariatric surgery has shown that more people compared to intensive medical therapy can be off diabetes by weight reduction with bariatric surgery. And this study, the direct study, showed that with very good weight reduction programs like here, when the weight reduction is more than about 15 kilos, you can see about 86% of people became free of diabetes. And this is mainly attributable to the loss of liver and pancreatic fat. And you can think that by these measures, we may be able to reduce the risks of insulin resistance, as well as non-alcoholic fatty liver disease and cancer. So coming to the proper managing diabetes beyond A1C, diet and weight management becomes a cornerstone, because there are many potential benefits, which I'm not going into detail, quite obvious to most of us. There are multiple benefits. Because of these, we need to think in each of our patients about the diet and well as individualization of the diet according to the culturally adopted diets in our part of the world. Although there is a paradox in the obesity, where some studies have shown that lower weight is associated with higher mortality and higher mortality due to heart failure. There are benefits of weight reduction. So we need to be cognizant about new studies to look at the effect of obesity and also use multidisciplinary approaches for managing these patients. Smoking, there are many adverse effects of smoking for people with diabetes, which are listed here. So there should be programs to assess the smoking status and also to help people to reduce smoking. It should be an integral part. Then coming to the pharmacotherapy, I think my talk is made easier by the previous speaker because he has alluded elegantly about the new medications like the SGLT2 inhibitors. But if you look at the ideal pharmacotherapy, they should be effective for A1C, should have beneficial effect on weight reduction or control. For heart and the vasculature, should be renoprotective, should prevent the heart from failing, and should have beneficial effects on liver disease and cancer, and should not be causing significant hypoglycemia. So I will rush through these HBA2 inhibitors because it has been already spoken in detail, but just for the completeness of sake, you can see the mechanism of action of SGLT2 inhibitors, and this seminal study, the EMPEREDGE, was the beginning of many other stories, which showed that before all this time, there was no such study that showed this sort of impressive results in a short period of time, reducing the cardiovascular events, the 3-point MACE here, cardiovascular mortality, non-fatal MI, and the stroke, and then overall cardiovascular mortality, all-cause mortality, hospitalization for heart failure, and so on. And then the mechanisms of these benefits have been already spoken. Just to highlight the changes in the fuel, metabolic fuel regulation in the heart, cardiac metabolism is largely attributed for the benefits to the heart, in addition to the reduction of blood pressure and the lipids. And then there are many postulated mechanisms for the kidney, like the reduction in the oxidative stress, inflammation, and the intraglomerular pressure. And then effects on the liver, where there's increased hepatic glucose output leading to reduced hepatic fat, and even effects on the pancreas, where there can be reduced pancreatic fat and reduced glucotoxicity, which are all beneficial for the diabetes. And also on the fat tissue, where there is reduction of fat tissue, and which will also lead to reduced fat mass and the resultant benefits. And I don't like to individually go into all these studies, but the canagliflozin in the canvas, declare-TIMI, dapagliflozin, EMPEREDGE, in empagliflozin, credence again in the canagliflozin, all have shown benefits in the MACE, cardiovascular death in different magnitudes in the different studies, and the heart failure. And the other important thing to appreciate about this group of drugs is that some of these studies are done in people without diabetes, particularly like in the credence, and then also Emperor Reduced study, and DAPA-HF, there are people without diabetes. So it is not just based on the glycemic benefit. Similar group of drugs with different action is this GLP-1 receptor agonist. They have been shown to have major benefits on the cardiovascular system in the LEADER study programs, the liraglutide, and people think that there's the marked weight loss that is associated with this group of molecules is beneficial, as well as their effects on the blood pressure and their effects on the lipids, as well as perhaps on the endothelial function and the cardiac contractility and so on. And you can see the meta-analysis of different types of GLP-1 receptor agonists, except for the lixisenatide in the ELIXIR study. Most of the other studies have favored the GLP-1 receptor agonist used for reduction of the MACE. Then let me take you through the primary prevention and the reduction of atherosclerotic cardiovascular disease, because it is the heart disease and the vascular thrombosis that causes most of the preventable deaths in diabetes. So the lipids, which is one of the biggest culprits here, needs to be discussed. You can see multiple studies on statin studies showing on the x-axis the LDL cholesterol level, and on the y-axis the percentage of CHT events. All have been elegantly shown to reduce, be associated with the LDL cholesterol and the cardiac events. And if you look at these 5 cardiovascular studies using statin, they have shown that particularly in their subgroup analysis, there is much higher effect on these studies on people with diabetes. And this study, the collaborative atorvastatin diabetes study, or the CARD study, was a landmark study that revolutionized our approach to patients with diabetes, where even with a modest dose of atorvastatin 10 mg in people without very high levels of LDL cholesterol and without heart disease, they showed that there was very significant benefit in reducing the hazard of cardiovascular disease. And the other important thing is this study highlighted that the reduction of the cardiac event is not based on the baseline LDL cholesterol and other levels of cholesterol. This has changed the way we use statins for diabetic patients. Particularly, there's a very low threshold to start statins for our patients. As you can see here, people with 40 to 75 years, irrespective of their lipid status, cardiac status, they should be given any form of moderate dose of statins. But if the risk is higher, you should give high intensity statins. And then people with even younger people, if they are having very strong risk factors, or if they already have vascular disease, you need to consider statins. And even in the old people, unless they are very, very low risk and has any contraindications, you need to think about use of statins on those people as well. Antiplatelet therapy was quite a like a debated area, where diabetes initially, when it was considered the CVD risk equivalent, almost all of our patients were on an antiplatelet agent. But subsequent studies showed that this increases bleeding. So we were doing things without firm evidence. And these studies, like the Popadad study initially, they showed that irrespective of the age group, there was no statistically significant benefits in people either in reducing composite outcomes or cardiovascular death by the use of aspirin for primary prevention. And then these meta-analysis by the collaborative groups like this one, it showed that there's definitely benefit in the secondary prevention of cardiovascular disease by using antiplatelet therapy, but not particularly in diabetes patients. For primary prevention, there was not significant benefits. And this was subsequently tested in these recent antiplatelet trials, ASCEND, ARRIVE, and ASPRI, where although they showed that there's some benefit in some people in reducing the cardiovascular risk, there is increasing risk of bleeding. Therefore, overall benefit, it may not outweigh the risks of bleeding and the damage and the danger. So the now what we advocate and adopt is that we don't uniformly use antiplatelets for all patients with diabetes for primary prevention, but consider only those with very high risk after comprehensive discussion. But again, this needs to be discussed among ourselves. Particularly South Asians, we know they are at high risk of diabetes. We might need our own trials to test this hypothesis. Diabetes and cancer, I told that cancer is an important cause of death and morbidity in people with diabetes. Then there are commonly associated cancers and less commonly associated cancers with diabetes. And people think that it may be due to shared risk factors like obesity, insulin resistance, which causes in one way hyperinsulinemia. We know that insulin is a agent that leads to cell proliferation directly or through the IGF-1 mechanisms. And then hyperinsulinemia lead to hyperglycemia, and the hyperglycemia leads to reactive oxygen species and advanced glycation end products and so on, which promotes inflammation. And these inflammatory response also might cause tumorigenesis by changing on making changes in the genes. So there needs to have integrated cancer risk reduction into diabetes care, particularly using lifestyle measures like diet, exercise, and smoking cessation. In addition, we should have screening mechanisms and programs to detect early based on the national guidelines. Blood pressure. We know that blood pressure has multiple deleterious effects on different organs, from the brain to heart to kidneys, and even in lesser extent to the eyes and other organs. And the UKPDS, the blood pressure arm, has elegantly showed that intensive blood pressure control has multiple benefits for all endpoints: the deaths, stroke, microvascular disease, heart failure, retinopathy progression, as well as for vision. So, although this was shown in the UKPDS, the blood pressure control was not as intensive as normal level of blood pressure. Then people want to be more aggressive and see whether near normal blood pressure or the very intensive blood pressure control will be further beneficial. This was tested in studies like the SPRINT trial, and then also in the Accord BP study, and subsequently they showed that particularly in this study, like the SPRINT study, you can see here, there is benefit for heart failure, cardiovascular causes, death, but at the same time, there are other adverse effects like the hypotension, acute kidney failure, and syncope, hypertension, bradycardia, and so there's increased morbidity due to treatment. Because of this, now the general consensus on blood pressure treatment is that hypertension should be treated to achieve benefit, particularly when the blood pressure is around 140 to 90. And the mean attained in intensive blood pressure level is around 130/80, and particularly when there is benefit needed, particularly for stroke, you might go further down, but this is at the expense of other adverse events, which I have already alluded. And then particularly there are studies which I'm not going to highlight here, showing that particularly the ACE inhibitors and ARBs to be more beneficial in the presence of proteinuria and high cardiovascular risk. Then coming to the kidney, we know that significant number of people with diabetes die due to kidney and suffer due to kidney failure or kidney disease. So what are the mechanisms and methods to reduce this mortality and morbidity? We know about the glycemic control. I have alluded about the blood pressure control. In addition to this, lipid control has been shown to have some benefit. Reduction of proteinuria has been shown to be beneficial. And then new agents, which we have already discussed, has been shown to be very promising in protecting kidneys. In addition, there are the minor ones like urate lowering, which are again debated in the fraternity. So we know about the importance of the intraglomerular pressure, which causes the damage to the glomerulus and the kidney. And the drugs like losartan in the renal study, irbesartan in the IDNT study, and many other studies, as shown in this meta-analysis, have shown that there is benefit from the ACE inhibitors and ARBs on renal outcomes, including quite advanced renal disease. And not only that, in these people, it reduces renal events as well as improves the cardiovascular death as well as all-cause mortality. And again, studies have shown that in people with albuminuric nephropathy, these drugs retards progression to end-stage renal failure and also reduces the doubling of serum creatinine, and in addition reduces the progression of microalbuminuria to overt proteinuria. And even in normotensive microalbuminuria, they retard the progression of macroalbuminuria, but without significant renal disease progression in this group. And in those without hypertension and without proteinuria, there is absolutely no benefit. There are other new agents which are being discussed, like the aldosterone antagonist, and this new drug, the finerenone, has been shown to improve renal outcomes. And this is the other the area that the people had been talking about, the hyperuricemia. Hyperuricemia, we know, is associated with CKD in progression, but studies have not convincingly shown the reduction of hyperuricemia to be associated with significant benefit. And this area we have already spoken in the previous talk, as well as in the early part of my talk, where the empagliflozin, dapagliflozin, canagliflozin all have been shown to have positive renal outcomes in reducing dialysis, transplantation, end-stage kidney disease, substantial loss of kidney function measured as doubling of serum creatinine, and even reduction of proteinuria, and also acute kidney injury. And there are multiple postulated mechanisms. I think they have been discussed, but just for the completeness of sake, natriuresis, which leads to increased delivery of sodium to the macula densa, and as a result, vasoconstriction of afferent arterioles, reduction of blood glucose, body weight, blood pressure, uric acid, all of which leads to multiple benefits, as well as reduced inflammation in the kidney and fibrosis. GLP-1 receptor agonists also have been shown to have renal benefits, but at a lesser degree compared to SGLT2 inhibitors. The other important thing that I would like to highlight is the heart failure prevention, which people did not talk some time ago, and which is increasingly recognized as an important cause of morbidity and mortality in people with diabetes, even without ischemic heart disease. The diabetic cardiomyopathy leads to the heart failure, particularly through myocardial fibrosis and different mechanisms. Hyperglycemia, blood pressure, lipids, body weight, all have been associated with heart failure, and the control of all these are important. But the most promising thing that we have now is the glucose lowering therapies, mainly the SGLT2 inhibitors, having massive benefit, as suggested from the initial studies, which were not mainly based, designed for heart failure benefit, but the post-hoc analysis showed the benefit of heart failure, and the subsequent ones, including some of the ones where there were patients without diabetes, showing the benefit of reduction of heart failure, as you can see in the forest plot from a meta-analysis. Again, not only overall heart failure, we know that there are two types of heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. In both these entities, there is benefit. And the GLP-1 receptor agonist, which I have already spoken in the coronary artery disease, has also been shown to have some benefit, except in the ELIXIR study with lixisenatide. But again, not as to a higher degree like in the SGLT2 inhibitors. So, ladies and gentlemen, now we are having a paradigm shift in the treatment and management of type 2 diabetes, from the more glucocentric approach to more cardiovascular nephroprotection approach, as well as an approach to reduce or prevent obesity, and also to reduce other outcomes like the hypoglycemia, based on this American Diabetic Association algorithm. But this can be more comprehensive, and our management, although the HbA1c we can't forget, it should be beyond A1c. I think we need to seriously think about reversal of diabetes, and also diet and weight control can never be forgotten. And the blood pressure, multiple benefits. Heart failure needs to be in our mind always when we see a diabetic person. And then other things like hypoglycemia, NAFLD, the quality of life, I didn't touch very seriously on that. The nephroprotection, cancer, because I see a lot of my patients, even in the clinic, I diagnose colorectal cancer, because the moment when their hemoglobin drops, in older people, it is most often due to colorectal cancer. Then the CVD risk mitigation with lipid control, antiplatelet therapy when that is indicated, and the neuropathy and the neurodegeneration. These are the areas, and the diabetic foot, which we have not discussed in detail, and we should also be looking forward for newer therapies in these areas, and also the retinopathy. So ladies and gentlemen, that comes to the conclusion in my talk, and I'm happy to take any questions. And again, thank you very much, Banshi and the organizing committee for inviting me.
Thank you very much, Dr. Barsad, for this elegant presentation. And all of us know that diabetes is a multifaceted disease. It is not only the item of glycemia, but it is important. The item of the glycemia is important, but we now addressing the what is called the metabolic cardiorenal systems that are interrelated to each other. And when you protect your kidney, you protect your heart, when you have optimum glycemic control, when you have a global look, not glucocentric only, this is the era now of diabetes care. And in this situation, may I address the last slide of you, Dr. Barsad. That is the map for diabetes care when we addressing the cardiovascular issue, the renal issue, the weight reduction, hypoglycemia. But in our area, we must come to the cost also. And I think that the newer therapies, when we have generics with a good brand, good quality, I think this will minimize the cost. What is your opinion in our region, in Asia countries, for the socio-economic situation, for uses approved the newer therapies like SGLT2 and DPP4 inhibitors and statins for managing of our problem in diabetes?
Dr. Mesba, I think that is a very good question. But what I saw in the last few years is that we initially thought that the cost for patients can be prohibitive. But I have seen that if you carefully use these agents, particularly I know GLP-1 receptor agonist is still quite costly and it is prohibitive for most patients. Now that we have generic forms of SGLT2 inhibitors, they have been quite useful, particularly because they are actually cost reducing. You get the very good glycemic control, you get their weight down, you can cut down on their diuretics, you can cut down on their antihypertensives, and you can cut down on their insulin dose. And I have seen that actually we should do some more research on this, and actually sometimes it can be cost saving.
Okay, this is nice, but can you add another item for your beautiful slide? This is diabetes management beyond the glycemia for education of diabetic patient, education of the community, education of the caring physician, the patient education. Education.
Yes, definitely. Actually, as I completely agree with you, and all these things cannot be achieved successfully without patient education. Perhaps we should have a bigger slide, bigger circle encompassing all these circles, and which should be, the patient education and empowerment, I think.
Yes.
You are correct.
Okay, if you have another comments for Dr. Barsad before we going to Dr. Adil, if there is any comment for this elegant presentations from our audience, I see there is no comments. Okay, Dr. Adil, thank you very much for your elegant presentation. And the matter of DPP4 inhibitors and the SGLT2 inhibitor now is widely studied for their early use and combinations. And I want to ask you a question. For all of us know the synergistic mechanism for DPP4 inhibitors with SGLT2 inhibitor. Maybe this mechanism is mandatory for over counting the hyperglucogonemia with the use of SGLT2 inhibitors that is observed in some patients. So we need glucagon inhibitor like DB4. What is your opinion in this respect? Radil? Or around? Radil? Okay, if he's not around, I think
Thank you,
we
Dr.
can
Arvind.
Radil it.
This is the last lecture, and we are going to close after this. So I will be requesting all other faculty
Adil,
members.
Adil, you are here, Adil.
Closing of this lecture, we will have the final closing function for our program also.
Adil, you hear me? You are muted, Adil. You are muted. You hear me, Adil?
It's fine now, sir.
Adil?
Sir, you are not audible, Dr. Adil, sir.
Adil, you are muted, Adil. Adil?
He is trying, he's trying.
Yes. You are now? Adil, you hear me? Adil? Okay, can Dr. Barsad, you are with me online. What is your opinion about the hyperglucogonemia and SGLT2 inhibitors?
Actually, yeah, I also, I think there was one of my slides show that, you know, this imbalance between, you know, glucose and, sorry, insulin and glucagon. On one side, we were, you know, at one point we were thinking that the glucagon, increased glucagon is a like a risk factor in the pathogenesis of type 2 diabetes, but at the same time there seems to be hyperglucagonemia in when you use like the SGLT2 inhibitors, and I think we might need to think about the potential benefits, and I'm not 100% sure at this point how it might provide the benefits, but this is a very interesting area that is being highlighted.
Yeah, yes. What I mean that
I'm here. Can you hear me? Can you hear me now?
Yes, yes, we
hear
you now. And this is your turn to yes.
I'm sorry. Actually, I don't know. There is a problem in the voice. It's coming and going. So I'm sorry about that.
Okay. Our question, Adil,
yes,
Adil, to you.
Please.
First of all, thank you very much for this elegant presentation and you clarifying the issue of two of the most promising therapies in the field of type 2 diabetes now, DB4 inhibitors and SGLT2 inhibitors. What is your comment about the speculation that SGLT2 inhibitors use sometimes result in hyperglucagonemia? So the use of DB4 inhibitors with SGLT2 inhibitors as a combination therapy can overcome this problem. What is the magnitude of this problem,
yes.
and what is your comment?
Well, thank you very much. Before answering this question, I would like to second you regarding the issue of the cost in diabetes and our friend from Sri Lanka and the well, I'm sorry, we haven't met before in person, so but hopefully we'll meet again in the coming period. But the issue of the cost is very important. Of course, the presence of generic drugs from different classes is very important. But at the end of the day, we have to put the issue of the cost right in the center of this circle in the last slide regarding that. well, we can of course use the generics. We can use somebody who can make a sort of, giving money or something, anything. But the cost has to be. We have to teach. We have to learn physicians to put cost right in the center of their interest. It's a patient-centered care, and one of the important aspects of the patient-centered care is just looking for the cost. So the cost must be put in that slide, in spite of everything. It has to be put there right in the center of the interest of every physician, actually. Well, you can see the WHO guidelines and everything. I mean, even these low-cost generics might be very expensive for particular people. So it depends on the type of the patient, and it is a patient-centered care, and we have to look for the cost. So emphasizing this issue is very important. That's my objective here. Regarding the issue of the ability of DB4 inhibitor to cover the increase in glucagon production during use of SGLT2 inhibitors. It's an attractive theoretical mechanism of action for that combination. But theoretical assumptions cannot be based, cannot be used as a base for using in a drug. I mean, we have to have evidence at the end of the day, and we do not have evidence whatsoever. I do not know of any trial which tackled this point to clarify it. I might not be aware. There might be there, and I don't know. I don't know about that. But to the best of my knowledge, that this point, because for example, the use or the benefit of the DB4 inhibitors and of the SGLT2, I'm sorry, in retinopathy, for example, it's very attractive theoretically because the behavior of the pericytes exactly the same that of the mesangial cells in the kidneys. However, we don't have evidence. So these issues are open fields for research, and I hope to hear about that in the coming period. It's a very good area for collaboration between clinicians and people with basic science, ophthalmologists, and all other fields. So it's an attractive theory. I do agree very much, actually, but we have to prove that through a randomized controlled clinical trial with hard outcome. I'm not treating membranes or enzymes or hormones. I'm treating people. So I need to see that effect in the clinical field.
Thank you.
Thank you very much.
It's a wonderful discussion we were having with the Diabetes Asia Symposia. Even we are missing our friend Vishwajit from Bangladesh. So we could not have him here as it is the last session. So we don't have the issue related to the timing, but everything has to come to an end. And we will be sending you these 2 recorded lectures to Ashraf you, so we can put on our website also, so the people can listen later on also. I have already sent you how you can listen to all the speakers, and I am sending you the Ashraf even the complete recorded lectures of full program of Diabetes India. One can listen also anytime, even if you can visit it as a delegate, and you can listen all the recorded lectures for next 3 months, and that will be great. So I'm sending you to Meshba, Adel, and Ashraf that how you can do it, and to Prasad also. And with this, Vipul, if we don't have any other questions, we can close this session. But once again, thank you. It's like, virtually we are getting connected so closely, and like every time we feel that we are there. I mean, since last 6 months, we met multiple times with Meshba and with Ashraf by doing some meetings of DSG, and with Adel and Prasanna. Again, I am very, very thankful to you, both of you, for sparing your very valuable time for Diabetes India meeting. Otherwise, to come and attend one meeting and to give a talk, it's like a job of 5 days or 7 days all the way to travel. So now the things have changed completely, that digitally. As I was listening, Adel, and we were also talking in our DSG meeting in the executive committee, why can't we have, as patient-centric care, a a guideline, a sort of a clinical practice recommendation in a very short way, because we Asians are different. And again, in Asia, the East Asia, Middle East, and Southeast, again, different. So we can come out with some sort of a guideline, which could be patient-centric approach. And Prashant, your talk was really fantastic. Yeah. Beyond A1C, that was what I was thinking. It's beyond A1C, mean all other complications and all other aspects of a diabetes are to be taken care simultaneously. It's just not be only A1C. We cannot be only glucocentric approach. We should have an approach to treat all aspects of diabetes and all comorbidity to have a better quality of life for our patients. With this, I end the session. If you have any last moment comment, Meshba.
Yes, my last comment is thank you very much for your elegant organization, for your motive, for your dedication for not only India but the diabetes community all over, and Diabetes in Asia Study Group especially. I am thankful also for our eminent speakers, Dr. Barsad, Dr. Adil, and the coordinator, Dr. Shavada, and I thank the organizers of this Diabetes in India, and being one of the members of Diabetes in India Congress since 4 or 5 years. I appreciate this effort of Banshi, and I take the last sentence of Banshi. We have on our Diabetes in Asia Study Group, we have now a committee for the scientific and committee, and this can starting these practical guidelines for our Diabetes in Asia care, suiting our socioeconomic and our target population. Thank you very much for all. Thank you for Banshi again, and thank you for the speakers, and seeing you inshallah near.
Just I want the last word again. Banshi, it is a fantastic, I went through the entire program. I can't imagine how you have done it. Again, congratulations.
Thank you. You must have seen the computer. Bye. Thank you, Adel. Bye, Ashraf. Bye, Meshba. Bye, Vipul. Bye, yes, sir. Dr. Sundaram, sir. Thank you. Thank you for attending the last session.
God bless you.
Thank you. Lily and all, Vipul, everyone, please join the Alpha Hall so we can have the closing session and the final closing session. Thank you.
Okay. Meshba, see you, inshallah.
See you.
Assalamu alaikum, Professor Adil Said. How are you? I think you're muted. Cannot hear.
Hi. How are you?
I am fine. How are you, doctor?
Good.
That long time not see you. There is no physical meeting.
Yes. Actually, I've been, not been able to go out of Sri Lanka for the nearly 2 years because my son did his final school exams and university entry last year. So because of that, I cut down 1 year and then go to the COVID, and now nearly 2 years I have been not able to even go to anywhere.
That's also here also stuck now. In Qatar the cases become low now. Thanks God we are 80% of stuck in the office, and the school is going online. My son was in Malaysia in higher study. He come back and they are staying with us.
Where is he studying?
In Malaysia.
Which medical school?
No, he's going to MBA, not in medical.
Really? Actually, my son also is going to Monash Medical School in Malaysia.
Malaysia, okay. It's an Asian specific. Hi, Dr. Adil. Assalamu
alaikum. Hi, Ashraf. You can hear me now.
Yeah.
Alhamdulillah. But has to connect and reconnect again, disconnect and reconnect again. So sorry, I have got problems regarding the voice. I don't know why.
How is everything in Egypt?
How things in Doha?
Doha, alhamdulillah, is good now. Cases are become down and 80% strength.
Okay.
Yeah. Inshallah, everything come normal. Hopefully.
Inshallah. Inshallah.
Yeah,
Inshallah.
a bit of a bad
I'll visit
time here.
Doha. I'll visit Doha soon.
Inshallah, inshallah.
Right. Inshallah, I'll visit you in Doha soon.
Yeah, inshallah. Of
And
course.
Sri Lanka and Sri Lanka as well.
We are having a bit of a time these days. Our epidemic suddenly went up, and we were doing quite well. But I think because of that, the numbers went up, and slowly now getting down with the lockdown.
Yeah.
Dr. Prasad,
yeah. Well,
sorry?
Sri Lanka for that.
Hopefully.
Because
sorry?
We need some more members to do.
Yeah, actually, now I will get, I have spoken to some companies also to register some doctors. But just I'm waiting till this wave goes, because nobody goes around, and so as soon
Hello, that's your, I think your camera is check.
No, the connection lost at his end.
Egypt is fine. How's family? Dr. Adil, can you hear
My
me?
son is there in Doha.
Yeah, that's I know.
Hello? Hello?
Yeah.
Can you hear me now?
Yes.
Good. My son is living in Doha, and he is coming in a few days' time. So, I mean, and